What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandal? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life.
Прогестерон – это стероид, состоящий из 3 циклогексановых и 1 циклопентанового кольца. Для терапевтического использования прогестерон производится из корня дикого ямса, вида Диоскорея. В связи с интенсивным пресистемным метаболизмом в печени, прогестерон обладает очень низкой биодоступностью при приеме внутрь, и концентрации его изменчивы, поэтому его вводят инъекционным или интравагинальным путем, что сопряжено с определенными трудностями и сопровождается побочными эффектами. Дидрогестерон начали использовать под торговой маркой Дуфастон с 1960-х годов для лечения состояний, связанных с дефицитом прогестерона. Процесс производства дидрогестерона очень сложный. Начинается он с модификации прогестерона, за которой следует важнейшая фаза преобразования в дидрогестерон. Происходит это путем пропускания молекулы через ультрафиолетовое излучение с соответствующей длиной волны, интенсивностью и временной последовательностью, что приводит к формированию уникально модифицированной структуры ретростероида. Такой процесс производства делает дидрогестерон единственным ретро-прогестероном на фармацевтическом рынке. Изогнутая форма перорального дидрогестерона усиливает жесткость молекулы в сравнении с прогестероном. Благодаря своей уникальной структуре дидрогестерон является высокоселективным к рецепторам прогестерона, восполняя дефицит эндогенного прогестерона. Он почти не взаимодействует с рецепторами других стероидов, что обеспечивает отсутствие андрогенного, эстрогенного, глюкокортикоидного и минералокортикоидного эффектов, которые возможны при применении других прогестогенов. Дуфастон, содержащий 10 мг дидрогестерона в каждой таблетке, обладает высокой биодоступностью, что позволяет пациентам пользоваться преимуществами перорального применения. Улучшенная биодоступность и повышенная рецептивность его метаболитов приводит к изменению секреторной деятельности эндометрия, прогестогенной активности, при дозе в 10-20 раз ниже, чем для микронизированного прогестерона. Для поддержки лютеиновой фазы при дефиците эндогенного прогестерона изучено применение различных прогестогенов. Только дуфастон, прогестерон и 17-альфа-гидроксипрогестерон капраат одобрены для применения во время беременности. Кроме того, дуфастон имеет широкий спектр показаний для восполнения эндогенного дефицита прогестерона. Доказано, что он эффективен при нерегулярном менструальном цикле, дисменорее, эндометриозе и вторичной аменорее. У женщин, забеременевших с помощью вспомогательных репродуктивных технологий, дуфастон при приеме внутрь восполняет эндогенный прогестерон и обеспечивает эффективную поддержку лютеиновой фазы, способствуя более успешным исходам беременности по сравнению с микронизированным вагинальным прогестероном. Около 113 миллионов женщин по всему миру принимали дуфастон. В включая 20 миллионов детей, которые родились на фоне приема препарата Дуфастон.
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
5, 4, 3, 2, 1.
Something that brought us to other further horizons.
Say again, Houston. Roger, we'd like to get both of you in the field of view of the camera from
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life.
Прогестерон – это стероид, состоящий из 3 циклогексановых и 1 циклопентанового кольца. Для терапевтического использования прогестерон производится из корня дикого ямса, вида Диоскурея. В связи с интенсивным пресистемным метаболизмом в печени, прогестерон обладает очень низкой биодоступностью при приеме внутрь, и концентрации его изменчивы, поэтому его вводят инъекционным или интравагинальным путем, что сопряжено с определенными трудностями и сопровождается побочными эффектами. Дидрогестерон начали использовать под торговой маркой Дуфастон с 1960-х годов для лечения состояний, связанных с дефицитом прогестерона. Процесс производства дидрогестерона очень сложный. Начинается он с модификации прогестерона, за которой следует важнейшая фаза преобразования в дидрогестерон. Происходит это путем пропускания молекулы через ультрафиолетовое излучение, соответствующей длиной волны, интенсивностью и временной последовательностью, что приводит к формированию уникально модифицированной структуры ретростероида. Такой процесс производства делает дидрогестерон единственным ретро-прогестероном на фармацевтическом рынке. Изогнутая форма перорального дидрогестерона усиливает жесткость молекулы в сравнении с прогестероном. Благодаря своей уникальной структуре дидрогестерон является высокоселективным к рецепторам прогестерона, восполняя дефицит эндогенного прогестерона. Он почти не взаимодействует с рецепторами других стероидов, что обеспечивает отсутствие андрогенного, эстрогенного, глюкокортикоидного и минералокортикоидного эффектов, которые возможны при применении других прогестогенов. Дуфастон, содержащий 10 мг дидрогестерона в каждой таблетке, обладает высокой биодоступностью, что позволяет пациентам пользоваться преимуществами перорального применения. Улучшенная биодоступность и повышенная рецептивность его метаболитов приводит к изменению секреторной деятельности эндометрия, прогестогенной активности, при дозе в 10-20 раз ниже, чем для микронизированного прогестерона. Для поддержки лютеиновой фазы при дефиците эндогенного прогестерона изучено применение различных прогестогенов. Только Дуфастон, прогестерон и 17-альфа-гидроксипрогестерон капрат одобрены для применения во время беременности. Кроме того, дуфастон имеет широкий спектр показаний для восполнения эндогенного дефицита прогестерона. Доказано, что он эффективен при нерегулярном менструальном цикле, дисменорее, эндометриозе и вторичной аменорее. У женщин, забеременевших с помощью вспомогательных репродуктивных технологий, дуфастон при приеме внутрь восполняет эндогенный прогестерон и обеспечивает эффективную поддержку лютеиновой фазы, способствуя более успешным исходам беременности по сравнению с микронизированным вагинальным прогестероном. Около 113 миллионов женщин по всему миру принимали дуфастон, включая 20 миллионов детей, которые родились на фоне приема препарата дуфастон.
Доброго ранку всім.
What
Good
would
morning.
you say if I were to ask?
It's a pleasure for me to open this second day of our symposium. I hope it's going to be even more interesting than yesterday. I appreciate everybody who has joined in right now, those who are present here in the studio, and those who are watching this remotely. I would like to say words of gratitude to all our sponsors who enabled this symposium. Thank you. Today, this morning, we have a vice president of our association, Mr. Valery Zukin. Valery, the floor is yours. This morning, I would like to welcome everyone to the traditional event. Ukraine is surviving. We keep on working, even though we have some disadvantages this year. But I hope next year we all will meet offline. Now I give the floor back to you. Thank you. So we are starting our first session today. It's gonna be quite packed. And remember that you can send in your questions. You can ask them online in different ways. We broadcast this on our Facebook page, and today we start with the true gift for all our embryologists. This is a gift from our good friend Pasha Isiktsev. He has invited Dr. Dozortsev to give the first speech. He is a doctor of biomedical sciences. He is the president of the American College of Embryologists. Mr. Dmitry, the floor is yours. Thank you. Thank you for the invitation to this conference. So, without further ado, let me start. My presentation is called Hormonal Stimulation of the Ovaries and the Quality of the Oocytes. It's based on the article published this year jointly with Antonio Pellicer and Michael Diamond. It's called Term Oocyte Maturation and Term Ovarian Stimulation, Impact on Oocyte Competence. And it's one of a series of 4 articles that were dedicated to the revision of the central paradigm of ovulation, which had been prevalent for the last, say, 8 years, which presumes that the trigger for gonadotropins is estradiol. We have proposed a new paradigm and provided the reasoning, the trigger for the LH is progesterone. I highly recommend these articles if you have the interest. They would be of interest for both embryologists and reproductologists. The main component of success in IVF is, well, a quality egg. If you have a quality egg, you'll get a quality embryo. If you have a quality embryo, you have a good chance that the child will be born. But how can we assess the quality of the egg? Well, we usually do it only retrospectively. We look at the embryo development. We cannot do it prospectively so far. We do not have any marker for egg competence. We can only say that it is chromosomally mature, and today we only have the target to get as many matured eggs as possible by minimizing the risk of hyperstimulation. But we know that the nuclear maturity of the egg is one of the earliest stages of the competence, which can be achieved even by the egg which would be metabolically failing in other regards. For example, this can be compared to selecting a tomato by its shape and its size without looking at its color. Same with the egg. And the chromosomal maturity, to make it clear to the OBGYNs, if we look at some comparative benchmark, it's more or less like a sucking reflex. It's a very early phenomenon. This reflex is there even in preterm babies. So the same is about the chromosomal maturity of the eggs. It really is metabolically immature in all other regards. So it might be, for example, failing in the division process. When we look at the follicles, the follicle does not say anything about the quality of the egg. Its size, well, we check the size of the follicle, and it does not say anything about the quality of the egg. And the estradiol is also a derivative of the size of the follicle, and also it does not predict anything. Why? Why is follicle not predicting anything about the egg? Before the FSH receptors come out, the egg controls on the granules in the follicle, and in this way, while the follicle is still small, it controls the outcome for the follicle. After the FSHR, the receptors come out in the adequate quantity, so that it is supported in the big growth phase. At the end of the luteal phase of the previous period, the egg loses control of the follicle. The gradient of the factors is too weak to keep the granulose cells from differentiation when the FSH receptors appear. And after that, the outcome of the egg will depend on the outcome of the follicle. And the duration of the follicle will depend on the quality of the hormones, on the quality of the ovary cortex, and of course the efforts of the reproductologists, which can start triggering, and in this way they will end the follicular stage for this egg. Measuring the follicle size can be compared to measuring the size of a pregnant woman's abdomen in order to try to calculate the maturity of the fetus and the date of the possible delivery. So it's quite clear that this idea is ridiculous. We know that the timing of pregnancy is the most important factor which defines the maturity of the fetus, and we don't have to measure her waist size. We can simply ask, when did she have her last period? The duration of the bioprocesses is often fixed. It cannot be reduced without any losses. These are processes like pregnancy, prepuberty, cellular cycle, the stages of embryonal development, or champagne maturation. When I was preparing this, I found out that it has to mature for 9 months, So haste makes waste, as they say. We know the time is a critical parameter for the egg maturation. We know this first and foremost from the epidemiology data. Look at this small graph. The left is the fecundity on the vertical axis, and here we have the menstrual period length. We see that if the menstrual cycle is shortened by 5 days, the fecundity goes down, well, more than twice. This is in the population of general women. These are not patients. This is just a random sampling of women of reproductive age. What's important? That the length of this cycle is defined by the length of the follicular phase. We know that the luteal phase is more or less permanent. And so the length of the cycle depends on the extension or shortening of the follicular phase. So the time the follicle has got for the last stage of the egg maturation. We know that the short cycle is always shortened due to the follicular phase, and it's always related to the fertility reduction. The long cycle is always extended because of the follicular phase and is not related to fertility reduction. And we are not talking about patients with cycle disruptions or ovary polycystic syndrome and so on. This data is there in the table. It is taken from the article which has been published in the Nature recently, and these figures of the follicular phase duration is based on 600,000 cycles, so quite a big sample. How critical is that? How time is critical? This table is not kind of really scientific, but it gives a good impression how the duration of the follicular phase can impact. This is the number of days of the follicular phase minus the last 37 hours that start from the age spike. And this is the term pregnancy duration in weeks. And these are days of maturation. So you see, we kind of compare in percentage-wise the weeks of pregnancy. So we see that 10 days would kind of be equivalent to the 23rd week of pregnancy. So we think that as you cannot shorten the time of pregnancy without the impact on the fetus, you cannot shorten the duration of the egg maturation during the follicular phase without the impact on its competence. So women with high AMH have an additional problem. It's the so-called double failure, which is often mentioned in young women who in IVF have worse results than in elder women, 30 plus. These women have many follicles, they have the risk of hyperstimulation, they have short stimulation at the end. And then that might explain this double failure. So, age-dependent reduction in the quality of eggs. Usually it is considered that as women grow older, well, we know that the pregnancy change, the fecundity goes down, and in both the natural pregnancy and the IVF, and usually it's considered something fatal, something irreparable, and they say, well, the eggs deteriorate, the quality goes down. Usually it's because of the free radicals damaging the DNA, and in some way this causes the disruption in the chromosome, the division during the meiosis or mitosis, and well, it can be changed. At the same time, if we look at the cycle length in aging women, we see that the length of the follicular phase extends by 3 days, and relatively this is quite a lot. 3 days, if we compare it with the length of the follicular phase, it's quite a long time. We know that in these women they lose the elasticity of the ovarian cortex, and this is one of the reasons which can cause preterm spontaneous luteinization of the follicles. And there were articles published about this, and it's common practice. People who are dealing with IVF, they know that aging women have this phenomenon, this spontaneously disappearing follicles. And this is most probably caused by the loss of elasticity of the ovarian cortex. We know that fertility goes down with age, and the length of the follicular phase goes down as well. So in aged women there is an additional problem. It is related to the high FSH in the beginning of the follicular phase. The follicles grow faster because of it, so there is more granulose which is recruited into the mural, and as the result there's less granulose which supports the egg. Even we know that the egg receives almost 30% of the metabolites that are required for its development. Also, as there's more mural granulose, because there's higher FSH, the follicles grow faster. It's also quite well known that during the stimulation, the hormonal stimulation, the follicles in women grow about 1.2 times faster than during the natural cycle. So they are faster in getting the sites when the follicle cannot be preserved intact, and they get the trigger injection sooner. We think that the task of the stimulation, a very important task of the stimulation, is to give time to the egg, to give time to achieve the optimal maturation. And you can use estradiol. For this, at the end of the lethal phase, you can use minimal stimulation. We use diclofenac quite successfully for in the last 2 or 3 days of the stimulation. And one of the approaches is ignoring the loss of the biggest follicle, so that the remaining follicles, eggs, would have more time for the full-scale maturation. The stimulation naturally has some limit in improving quality, and we only deal with kind of 2 weeks of the egg development, while the previous history also matters, and it's, essentially longer. The stimulation can sometimes improve the quality of cells if a woman has issues related, if the fertility issues are related to the shorter follicular phase, we can extend it, and in this way we can improve the quality of eggs. But most often we lower the quality of eggs due to the above mentioned reasons. Of course, only a certain percentage of the eggs is of quality, and this percentage varies patient by patient and cycle to cycle. I understand that many doctors might respond to this immediately. They say, I have a fantastic result with short stimulation. Of course, that is possible. That is possible because the standard deviation of the follicular cycle is quite large. But if we look at it, if we compare, and yeah, it's not a scientific comparison, but still it might be valid. We see that children born at, say, the 22nd week, like severely preterm, they also have a 30% survival rate, but it doesn't mean that we can optimize pregnancy by doing C-section to women when the pregnancy is at the early stage, even though they can have quite a percentage of, well, if not healthy, but at least surviving babies. And some might react that if the situation goes too long, then the embryos don't grow. Yeah, it happens, of course. But if the stimulation extends because the follicles do not grow despite the adequate quality of gonadotropins, there's a pathology, and you have to figure out, you have to look why. So, to conclude, the follicle does not carry the information about the egg. The chromosomal maturity of the egg does not mean its competence. That's important. The stimulation can improve or worsen the pregnancy chance. A good stimulation is a full-term stimulation. So we use the full-term term to make it similar to the term pregnancy. So just like the two-term pregnancy, we have the term follicular phase and term stimulation. So this term varies from patient to patient. For some patients, young women who have good cells, and maybe they're shortening of the follicular phase, it's not that important. But for the majority of patients, there is a certain limit. If the duration of the follicular phase goes below this limit, then the quality of eggs goes down significantly. And to conclude, I would like to say thanks to Pasha Itzekson. He was one of the first listeners of this presentation, and he gave me quite a lot of useful recommendations. Andrei Rybushkin, Anastasia Kirillova, Albert Ichmelian, Konstantin Boyarsky, Dmitry Holodov, Maria Zharova, and Dmitry Gerkulov. They all have chipped in and gave a lot of useful advice. Thank you. I conclude my presentation. Thank you, Dmitry. Thank you for this most interesting presentation. We understand that it has been not so easy because you were in Texas and the time zone is quite different. But it was very interesting. Are there any questions? You know, I have more questions than answers. That's good. Yes. Yeah, the concept is somewhat new, somewhat it is not new, but I have a question. Look, we have like quite a lot of doctors listening to us. There are at least 100 doctors online. But if we want to be specific, what do we do to optimize the stimulation? That's question number one. And question number two, regarding the quality of eggs. But what do you mean? What does quality of egg mean? Is it chromosomal status? Is it mitochondrial status? Is it survivability? So, question one. What can one do Oh, there's the echo. The echo. Oh, yeah, it's gone. It's very good. Thank you. So, what can we do to improve the stimulation? You see, my presentation is narrowly targeted to only one aspect of the stimulation, which is often neglected. And it's only about the duration and the time, the moment of stimulation. So, if you ask, how can we improve? I can give this narrow answer. I can only repeat that to improve this aspect of stimulation is to use estradiol to suppress, starting from the luteal phase of the previous cycle, to suppress the basal FSH, if that is the problem, if it's high, to use the diclofenac. And we have found that diclofenac, 50 mgs twice a day for the last 2 or 3 days of the stimulation, it really helps to extend the life of the follicle, because its last phase, before it starts disintegrating, it's related to the inflammation. And diclofenac, especially the suppositories, we use the suppositories mostly, they are very effective in reducing the inflammation, and in this way they extend the follicle life. Now, and naturally, the general stimulation, well, we cannot give some general recommendation, because you have a lot of experience yourself. You know that every woman is unique. You have to know their cycle, what is happening there, hormonally, not hormonally, and we have to be based on that. You know this even better than me. As for the competence markers, as I said, we can only talk retrospectively about the quality of the eggs, because the clinical marker is there. When we transfer mitochondria, yeah, of course, the mitochondria matter for the development. We know that the transfer helps sometimes to patient. So I think many of the patients would benefit from the extended stimulation duration. But as for mitochondrial transfer, we transfer not only mitochondria, you know, we transfer many things into the cell, into the egg. You know that sometimes even the nucleus is transferred to the different cytoplasm. There are different options of transfer, you know. Sometimes the cytoplasm of the donor is transferred to the recipient's egg, and sometimes it helps to get pregnant. But I think that the figures, the number of patients who have babies after this procedure is still quite low, and we do not really know what exactly in this transfer has been helping to improve the quality of the eggs. Maybe something helps, but we don't know. Anyway, in the IVF, we don't have any markers we could use routinely, and I don't see any perspective for them in the foreseeable future. But anyway, the markers, would they be really helping? Because we have the egg already in the lab. We cannot improve it anymore. The only thing that can improve the egg is the stimulation. Nothing else from the available tools can help us. Thank you. Thank you, Dmitry. Can you hear me? There is also a question from the audience. What is which duration of the stimulation is the optimal? I think that the best guide for this is the nature. That would be my best response. If you look at the duration of the menstrual cycle in young women, we will see that the cycle lasts for 18 days, but we have to, I mean, this is starting from the first day of the period until ovulation. As the ovulation happens 37 hours after the beginning of the LH spike, we have to deduct 37 hours, and then that would be the optimal duration of the follicular phase, which the nature suggests. If you ask my personal opinion, I think for elder women, it can be an even longer phase, because maybe their eggs require more days. However, it's not very realistic to make this long phase. It takes some very meticulous work with this woman, and the stimulation might fail if you make the stimulation too long. I think, well, there are two things. Firstly, there's some threshold below which all the patients will have a drop in the pregnancy rate, and I think about 8.5 days is the threshold below which you cannot go, and the optimal duration, I think, is 14 days. Thank you. Thank you. Valery Dmitrievich, do you have another short question? We don't have much time. We understand that it's a late hour for Dmitry. Oh, well, that is not a problem at all. I can happily answer any questions if they're there. Okay, so I have a provocative question then. Does the quality of egg depend on the of the gonadotropins used? I don't think so. Well, it depends on the dose, of course, but, well, indirectly, because it is going to change the duration of the follicular phase. But simply, I don't think so. The minimal stimulation, its effect, I think, is caused by the extension of the follicular phase in these women. And it's not because there's less gonadotropin. I don't know if I've responded and if I understood the question correctly, but that was my answer. Thank you. This is it. Looking forward to seeing you maybe next year at an offline meeting. Hopefully we'll manage. Yes, thank you. Thank you very much for the invitation, and I wish you all the best. Thank you. Goodbye, and say hi to Texas. We continue in the meantime, and with great pleasure I introduce Mira Tolle, the Doctor of Medical Sciences from Finland, Helsinki. And the most important is that she takes part in the ESHRE group, and the recommendations she's going to present are going to be very interesting. Mira, the floor is yours.
Hello, everybody. My name is Mira Törli. I'm a specialist in gynecology and obstetrics, and working at the moment in Kanta-Häme Central Hospital and Mehiläinen Clinics in Helsinki as an infertility specialist. And first, I would like to thank the organizers for the very kind invitation to speak about the ESHRE guideline on ovarian stimulation on IVF and ICSI. These are my disclosures. Today I'm going to first talk about the introduction of the guideline, then the different stimulation protocols, trigger, and luteal phase support. And first, to the introduction of the guideline. There have been earlier recommendations. For example, the NIS has a guideline for fertility problems. The Australian and New Zealand doctors have their statement on ovarian stimulation, and WHO has a narrative review of evidence in 2017, but it didn't contain any recommendations. And due to the lack of guidelines on ovarian stimulation, ESHRE then decided to set up a working group to do the first ever evidence-based guideline. And it was finally published in 2019. The guideline was developed under the Universal ESHRE Guideline protocols, and I was part of the group working on it. The guideline, we were 17 members representing 12 European countries. We had first face-to-face meetings and online meetings, a lot of abstracts screened by the ESHRE Central Office and by the guideline group members. 849 full papers screened by us, a lot of comments received during the stakeholder review, and we came up with 84 recommendations. And the scope of the guideline was to provide clinicians with evidence-based information on the different options how to do ovarian stimulation. And we took in account, for example, optimal ovarian response, live birth rate, safety of the treatments, mainly meaning prevention of hyperstimulation, of course, patient compliance, and individualization of the treatments. And for that, also in the guideline, we wish to introduce new terminology, especially the old categorization of predicted response to ovarian stimulation was felt very stigmatizing by patients. It was like poor, normal, and excessive response to stimulation. And the low response is the same as the poor response defined by Bologna criteria. And the high or excessive response didn't have a definition before. And we defined high response, 18 or more follicles on the day of triggering, or 18 or more eggs collected. And also throughout the guideline, we are using standard FSH dose, lower FSH dose, and higher dose. And the standard dose is something between 150 and 225 units. Higher dose is 250 to 300, and lower is 125 or under. For those doctors who are not working on the field of IVF, I wanted to first go through the different protocols for IVF stimulation. And the main difference is between how we prevent the premature ovulation by suppressing LH. And the long agonist protocol, the prevention of ovulation starts or begins in the previous cycle. So the woman starts to use the medication 2 to 4 weeks before the menstruation begins, and also she starts to inject herself with FSH. The problem with this protocol is that when the agonist is started, the woman enters into menopause for a short while, and that's not really nice for a young woman to have hot flashes or have poor sleep or have mood swings. So this is quite poorly tolerated. And normally the treatments with FSH, you have to inject for a couple of days more than if you compare to the short protocol. And the only option to trigger is with HCG. On the other hand, the short antagonist protocol follows the woman's own cycle. You don't have to suppress your own hormonal balance and induce menopause. And you start the antagonist injections normally on the day 6 of the injections. And then there are 2 options to trigger the ovulation with HCG, or then there's another possibility to use agonist triggering, and that's mainly for prevention of hyperstimulation. Both of the different stimulation protocols are as efficient, but on the other hand, with the long protocol, you might get 1 or 2 eggs more, but the clinical pregnancy rate and also the live birth rate is the same. And then to the guideline. If you are looking at predicted high response, so the people in risk of agonist protocol is recommended for PCOS women because it's safer and because it's as equally efficient. And on the other hand, it's also recommended for predicted high responders because it's safer. And if the long protocol is used, a reduced gonadotrophin use is probably recommended to decrease the risk of hyperstimulation. So basically, you would, with lower dose of FSH, you would have less eggs for the pickup. For normal responders, the antagonist protocol is recommended because it's safer. And for the low responders, with low responders, the problem is not to get too many eggs and hyperstimulation. It's mainly to get enough eggs or follicles for the pickup, and you don't have to do cycle cancellation. So basically, both of the protocols are equally safe. But on the other hand, if you use levels of response and basically cycle cancellation, but on the other hand, if you exceed 300 units of FSH, it doesn't have an effect on live birth rate, even though with higher doses you might get a couple of eggs more, but still the end result is the same. So basically, in general IV population, we strongly recommend that the antagonist protocol is recommended over the long protocol because it's equally efficient, but it's safer than the long protocol. Then for the triggering, for those who are not into IVF field, I will go first through what kind of LH effect the different triggering methods have on the endometrium and also on the LH levels. The agonist triggering has a really short effect. It's about peak of 20 hours. It produces nice, good quality eggs, but on the other hand, since its effect is so short, the woman will have her menstruation in 2 to 3 days normally if you don't add luteal phase, add LH activity to the luteal phase. The natural ovulation has an LH effect up to two days, and if you trigger with HCG, it has an effect for 6 days, and therefore it also supports the endometrium. And if you then go for the agonist triggering, it's, if you take in consideration the normal IVF population and do a fresh transfer with a normal luteal phase support, it's not recommended because the pregnancy rate is so low. And if you are then thinking about, if you trigger with an agonist, its effect is really short and it destroys the endometrium. And if you put an embryo into a bleeding uterus, it doesn't stick and basically the woman doesn't get pregnant. On the other hand, if you use the agonist triggering and add LH activity for a fresh transfer, the endometrium is saved, but it's still probably not recommended for a predicted normal responder because triggering with HCG has a better effect on the endometrium. But then if you then decide to trigger with an agonist, the dosing of triptorelin can vary between 0.1 to 0.4. But on the other hand, if you want to prevent hyperstimulation, the agonist triggering is recommended for women in risk of hyperstimulation. And then there are two options. If you trigger with an agonist and have decided that you freeze all the embryos beforehand, it's unclear whether you should use the agonist trigger or you should use a lower dose of HCG for triggering. And if you then decide to do a fresh transfer, the agonist trigger should follow by luteal phase support with LH activity. And if you then have decided that you are going to freeze all the embryos, the agonist triggering is better than the HCG. Then finally to the luteal phase. Since in a stimulated cycle we first try to prevent ovulation, then we induce the ovulation, and it causes luteal phase deficiency. And it's really old studies that in a stimulated cycle you did something extra for the luteal phase. And big studies, also Cochrane meta-analysis, show that if you add progesterone to the luteal phase, you get better live birth rate and pregnancy rate. And we also recommend progesterone for luteal phase after a fresh cycle. Administration route can be vaginal, rectal, intramuscular, or subcutaneous. It doesn't have an effect on the live birth rate. And dosing of the progesterone doesn't really have a big effect. You should start progesterone for luteal phase support on the window between the evening of the pickup to the day 3 post-oocyte pickup. And the progesterone for luteal phase support should be administered at least to the pregnancy test. And with the length of the luteal phase support, it really depends on the country and culture. In Scandinavia, we normally stop to the pregnancy test. I know that in Central Europe, quite often you continue progesterone until the first trimester or the pregnancy scan, so basically to week 7. And in some countries, you use it until week 12. And we don't really have the data to show that which is the optimal length of the luteal phase support. But we are not doing so poorly in Scandinavia, so we think that it's good until the pregnancy test. Luteal phase, it doesn't have an effect on the live birth rate. If you add HCG to the luteal phase, it doesn't really improve the pregnancy rate or live birth rate. During last couple of years, agonist after the embryo put into the uterus has been studied a lot. So I think that the results are promising. What we are still lacking the big data, big studies. So that's the reason why we think that the agonist on the luteal phase, it's only for research. And if you add LH as a luteal phase support, there we found just a couple of studies, so it's not recommended. And then another option to replace progesterone is dydrogesterone. It's a stereoisomer of progesterone, and that enables it to be taken orally. If you compare to progesterone, it can be taken vaginally, orally, or as injections. And its bioavailability is much more higher than progesterone. So basically it's much more potent. And on the other hand, the oral treatment is preferred to vaginal treatment. And if you ask the patients that how you feel about putting vaginal capsules or gel into the vagina, they complain about irritation and discomfort and feeling wet all the time. That's uncomfortable. And if you then were to use dydrogesterone as a luteal phase support, the daily dosage of 30 milligrams is mostly used. And meta-analysis shows that when you compare it to progesterone, the pregnancy rates and live birth rate is the same. And there are 2 big studies, Lotus 1 and Lotus 2, showing also the same results. And if you're looking at the Lotus 1 and 2 studies, especially I love the setting in Lotus 1 because it's double-blind, double-dummy, multi-center, and randomized. So basically neither the doctors nor the patients knew what they were getting. Both of the studies have had large amounts of patients, and they were in different countries. They started either oral dydrogesterone 3 times per day, or vaginal capsules in Lotus 1 or Lotus 2 vaginal gel on the day of the pickup, and continued until week 12. And the mothers and also the children were monitored after the delivery. And the data shows that if you compare oral dydrogesterone to vaginal gel or capsule, the pregnancy rate is similar, and also live birth rate is similar. Dydrogesterone was well tolerated, and it had similar safety profile to vaginal progesterone. And the future will tell what will happen. Will it replace vaginal progesterone as a luteal-based support in IVF? And what the guideline says about dydrogesterone. So basically, progesterone is recommended for luteal-based support. And we had a long discussion about dydrogesterone, that since it's an off-label medication in Europe, it doesn't have an indication for IVF. We didn't know whether we could recommend something that doesn't have an indication, but still we think that it's a brilliant possibility to replace vaginal progesterone. And the dydrogesterone, we think that it's probably recommended for luteal-based support. And that's mainly due to that it doesn't have an indication in Europe yet. And if you're looking at the safety with dydrogesterone compared to vaginal progesterone, mothers have a similar side effect profile, and also there was no significant impact on the baby's health. And then to the last part, I've been using dydrogesterone for many years. In Finland, as in other European countries, we use dydrogesterone as an off-label medication, and we really wish that we would have the indication for IVF. The first personal experiences with dydrogesterone was in 2017 from a private IVF clinic in Helsinki. And most private clinics use dydrogesterone in Finland now. And last week I heard that at the moment also all the university clinics use dydrogesterone in Finland. When I was relocated into a public hospital in Hämeenlinna, we started to use dydrogesterone in 2019. And in Finland, we have quite democratic approach to the treatments. We have discussed also with the patients what they want. Most patients, if they are given the option to have an oral medication that is as safe and also as efficient as the vaginal one, they will choose the oral one because it's a lot easier and more convenient to use. There is a small patient group that they don't want to change anything from the prior treatment. But what we saw is that there's really no difference in pregnancy rate or live birth rate compared to vaginal progesterone. However, the patients that used dydrogesterone, they were happier to use it. And finally, I would like to thank the ESHRE Guideline Developmental Group and the supporting team for the great work that you have done over the years. And we were happy to introduce the guideline to use for everybody all around the world. Thank you very much.
Thank you so much, Mira, for such an interesting presentation and such an interesting topic and such an like in an intro on how the Finland works. We are continuing our work, and with a great pleasure I invite the Samuel Santos Ribeiro from the Portugal was the more interesting topic, diagnostic management of the infertile couple.
Самуель, прошу, сподіваюсь.
Samuel, the floor is yours. I hope you are well rested and we are ready to hear you.
I'm more than ready. Very much for the kind opportunity to speak to you all about a topic that at first instance is going to sound a little bit boring, because it sounds like we're going to talk about the diagnosis and that we have returned back to school and what is the definition of infertility. However, I hope to you that this presentation will give you some novelty, and I'm also open to hear from your side a potential discussion of if you have different practices or not. However, but before we start actually talking about the diagnostic purposes, I would like to talk a little bit about the human reproductive system. And to talk about this, this huge intelligent group of organs, I would like to start with a number, which is 186 million. That is the amount of people that are currently unable to have a child. So of course, if the number is that large and that important, we know that the machine basically being operated. How much of the machine that's a little bit difficult, because these patients are used to what other situations are sure defined. Now, the diagnosis, incapacity to have a child after 12 months with unprotected sexual intercourse. And we call it unexplained if after doing visits to the ovaries, to the fallopian tubes, and assessing that the testes work well and that their ejaculate is normal, these patients have normal coital frequency, we say, well, then everything is good to go. Sorry about that, I was switching off my sound here. Now, there is a question, and still going into the opening setting of how to diagnose and what to diagnose, there's also a question that still comes out, which is how should we be advising our patients? And I'm showing you what NICE and ESHRE both propose. I tend to use the same approach as well, which is to guide patients about the early versus too late assessments. And in my belief, I think it is up to the patient to decide when they would like to start. We don't use a 1 year or 2 year cutoff. We are quite informative about telling that about 80% of the patients until 40 should get pregnant. However, we are also a glass half full kind of people, which tell patients that while willing to give them treatments, they should know that up to 50% of them will be capable of conceiving spontaneously within a second year as well. Then we start, when looking into patients, we all do the same. We try and look at their baseline even before they're in the door to try and understand what will be the main problem. And these are the problems that are very common in terms of our infertility patients, and unfortunately more and more common. And that comes with aging, overweight and underweight, smoking, occupational hazards, and the existence of other comorbidities such as STIs. And I'm showing you the image of Frenesiac. I know that you are very commonly known or privy of the information regarding the huge percentage of unemployed embryos as age goes. And this blue graph, or this blue section of this graph, shows you how little embryos are actually viable as age starts to increase. And I also want to show you very old data, but it's still interesting for us to remember about when you combine overaging with smoking habits, with alcoholism, with also being overweight. When you combine these factors, 1, 2, 3, they seem to sum up very importantly and to reduce very significantly the cumulative pregnancy rates of patients who are trying to conceive. This is information that we tend to sometimes take too seriously, and many of the clinics, especially in Europe, will tend to refuse treatment to patients after a certain threshold of EMI is reached. And this slide here is an objective just to say that we should also tame our will to have everything perfect. As you can see from this retrospective, however, very large registry database data, which is in patients performing IVF, when you go through the line of normal weight to super obesity, the pregnancy rate doesn't seem to decrease so steeply as when you compare it to how much it decreases for 1 extra year of infertility. So it's really important to encourage patients to lose weight, but not to forbid treatment year after year after year if they don't reach a certain weight class that you have been trying to get them to reach. And more importantly, it is interesting for us to talk a little bit about the causes of infertility and to understand that it's not all over on the woman. It's also on the male, and it's combined factors, and many of them can also be unexplained. And I don't want to bore you with the specific causes, but I do want to explain and to give in 2 or 3 images the plethora of causes that we need to discuss. And it's coming from both male and female, both from the hypothalamus to the thyroid, to the testes, the ovary. And gross mode, if we talk about this, there are many controls that can inhibit the production of hormones, that can block sperm transport or production. And in the woman, there are ovulatory disorders, also endometriosis, tubal infertility, and other uterine factors. Now, talking specifically about the topic, although we know there are multiple factors of infertility, today the objective is to discuss what are we doing as a first approach to our patients. And tendentially, both NICE and ESHRE will propose these sorts of tests to you. They will propose that in the male you perform a semen analysis, and in the woman that you assess how their ovarian reserve is, check if ovulation is occurring naturally, and their normal hormonal tests such as E2 and progesterone and FSH. And they will also propose that you check the tubal or uterine abnormalities, both by ultrasound and by screening for tubal occlusion. However, things aren't always the same. And this image for me is extremely interesting because it shows you the evolution over time of how things were introduced and then removed. On top, you see exams that used to be rather considered as standard, that no longer are discussed as standard. And in the meantime, you see also that with evolution of time, other tests such as semen analysis and AMH were increasingly included and stay still as very important tests to be done. And today what I'll be discussing with you a little bit about 2020, and it's actually a provocative talk because the objective is to see, are we all doing the same? And going topic by topic, I would like to discuss with you the female reproductive system. And we know that this uterus, tubes, and ovaries all will have specific points where we need to tackle and be sure that it's working. When it comes to normal ovarian function, this one I hope that you don't mind, but it will be the full topic of my next talk, so we will talk about that a little bit later. But I would, however, like to discuss with you about tubal function. As I just discussed, the guidelines are pretty clear to say that you should test tubal function in patients that are seeking your help due to heterosexual infertility. But the question that I asked you is, do you actually always perform it? Do you only perform it when you do an IUI? Or do you only perform it in patients who are smokers, who have had surgery in the abdomen, or previous history of either chlamydia or ectopic pregnancies? I can tell you that from our experience, we are more and more converting to this last stage, in which we tend to only assess patients at high risk, or at best those that are considering to perform IUI in a more advanced stage. What is the best test to use for tubal function? This is something that also creeped up on us. And all of a sudden, many physicians were doing many different types of tests, not actually talking to each other to assess which would be the best and worst tests. And I'm showing you tests such as the hysterosalpingography, which we're all classically used to, but also the more advanced testing with a gel called commercially as the exam foam, which is, for example, what we do in our clinic. When you assess this, you do see that there are some studies looking at this. And most importantly, what is happening over time is that physicians are trying to ease the pain patients suffer by performing a hysterosalpingography, trying to use less invasive approaches. And when you look at the data from Christiansen, which is quite recent, from 2018, you will notice that both with sonography or with hysterosalpingography, the tendency is that the pregnancy rates looked very, very similar with very equivalent live birth rates. However, we very recently had a back to the future instance in a very good publication by the Netherlands group of Dreyer, where they tried to reassess the old question of, does oil hysterosalpingography have an increased pregnancy outcome when compared to the water hysterosalpingography or water-based systems? And the assessment here, or the theory here, is that a more viscous product would allow to remove obstructions of the tube and allow for a more fluid or a reset of the tubal function. And what they showed and published very interestingly was that indeed the oil group, something that a lot of us have now abandoned due to the extra pain, was increasing the cumulative ongoing pregnancy rates. And this continued for quite some time. If you look at this curve, which is a longer assessment over time, you will see that it wasn't only in the first 6 months, but that it almost went 48 months over the maintenance of this larger and faster time to pregnancy in the oil group. And another analysis that they showed, which was quite interesting from the same data in a different study, was that the effects only seemed to be limited to patients that actually had pain during the procedure. My apologies, I now noticed there was a failure in one of the percentages, which is actually 30% and not 3%. But if you look at those that had a VAS score above 5, those with an oil-based treatment had a higher pregnancy rate. So most of the inclusions and the ameliorations that they had was in patients that actually had pain. So this rationale about the tubal plug being in the way could make some sense. Talking further about how we evaluate our female infertile patients, 2D ultrasound was something that has been classified as being enough for a long time, but many have been trying now to assess with hysteroscopy, even in a first instance prior to IVF. Yeah, however, the data is more in controversy that there seems to be no benefits. Although hysteroscopy is a really simple exam to perform, so long as you have a well-done ultrasound, both the trophy trial and the INSIGHT trial, in patients performing their first IVF cycle or with multiple failures before, showed no benefit whatsoever, and both of them were very large RCTs, both published in the same year in Lancet, if you're curious to read them more. Talking about the endometrial biopsy, that is also another back to the future moment that we are noticing. And indeed, in the 70s, it was the moment where endometrial biopsy started to become the mode, try to date according to the Noyes criteria. Unfortunately, it had a very poor reproducibility, so the clinical value was limited. But if you fast forward now to 2018 and to 2011, when the tests came out, more robust tests using transcriptomic analyses came out. And the first impression was that this exam, when you compare it to the previous versions, such as the Noyes criteria, was much more reproducible with itself. So when you assess the exams here, there were 2 evaluators and they were looking at receptivity and post and pre-receptivity. And what you notice is that this endometrial receptivity test agrees with itself much more time. So it's much more reproducible. These results were very, very encouraging. And there was a test to perform the use of these sort of strategies in women in general. So a first-time approach, those that are trying to do IVF without a recurrent implantation failure. And these results that were first published in first shown in 2016 and just recently published of the first ERA trial didn't really show that we've cured infertility. So it doesn't seem to me that this sort of endometrial dating could allow you to correct infertility in the patients if you do it before testing. It could, however, get better for those with recurrent implantation failure. And I'm showing you results presented in 2018 in which there is a new, better self-learning strategy in patients with recurrent implantation failure. And the results there seem to go much better when you try to date the endometrium. There, it seems more likely that you will be finding a problem. Let's, however, wait for the RCTs that are actually ongoing on this topic. However, I still want to remain on the topic of endometrial biopsy to discuss with you the reappearance of chronic endometritis. This has been something that historically has been let fall down, but with the advent of more approached strategies such as using histochemistry, immunohistochemistry, and the search of plasma cells with CD138 positive markers allowed us to better and better diagnose chronic endometritis. And we knew that it existed before, but since it really gave us very little symptoms, we were very oblivious to actually testing it. And moreover, those that abandoned testing it were doing so because originally they tested giving antibiotics for 5 to 10 days, and that didn't seem to work. However, we have more and more information about the antibiotic profile or adequate treatment for these patients, and it seems that you actually should be treating it as a PID to see if it works or not, and to better treat these patients. And if you actually look at the meta-analysis published by Vitigliano on this topic, you will notice that those that have occurred chronic endometritis will tend to have better pregnancy rates after IVF. And in comparison, those that have a non-cured chronic endometritis will have different results that make life a little bit more difficult for you. So the most important take-home message that I would give is, if you are somebody that believes in the effects or the increasing effect of chronic endometritis, then I would always propose that you at least test to see that your treatment worked and that you use the more durable treatments. However, why do I talk to you about chronic endometritis in patients with unexplained infertility? I will tell you off the bat, this is a study which is very well designed, looking at patients that routinely did chronic endometritis testing in infertility and that didn't perform any sort of treatment after 1 year. But I'm also going to tell you off the bat that I manipulated this graph, and that the results that I'm showing you are the results that I thought would be the real results. And what I thought would be the real results is that patients that had chronic endometritis diagnosed, and which you see is actually quite common, around half of these patients had chronic endometritis. I would guess that those that had chronic endometritis would be the ones that wouldn't improve after 1 year, and that after 1 additional year of unexplained infertility would not have a better outcome. However, these are the actual results of the study, which I invite you to go and see from Cincinnati et al. And what you notice is that those that had chronic endometritis were given the antibiotics, and in which the treatment resolved their clinical pregnancy rates, included without any further treatments after 1 year. Of course, this needs to be validated, but it's a very interesting topic, which is difficult to reproduce in those that already have 1 year of infertility. Finally, more and more information, and a word also for the use of 3D ultrasound, which has increased a lot our accuracy to diagnose not only uterine malformations, also adenomyosis, and also descent from the suture of a C-section, which is becoming more and more common as medicine becomes more and more medically assisted. Also talking now about male fertility, we tend to perform a semen analysis. Is that enough, or will we need to perform more tests? Should we, for example, routinely check in the beginning, even before doing treatment, for DNA fragmentation? Well, this was the question that was recently posed Basuigara and all in his meta-analysis. In patients performing first-line treatments proposed for insemination, will you have any benefits in performing DNA fragmentation to see if they are good candidates or not? And what he noticed in his results were that indeed those that had low DNA fragmentation had a tripled chance of conceiving with insemination. Does this mean that this test is compulsory and it will predict those who will fail with insemination? Well, unfortunately, no. It didn't have the hugest specificity, which means that indeed we still will have patients with high DNA fragmentation that will conceive with insemination. When we go into more details, some would argue that it's interesting to look right from the beginning if there is DNA fragmentation in the sperm or elevated fragmentation, because you could give antioxidants. And again, I'm showing you a very recent trial published in Fertility and Sterility that compares the administration in a long term of at least 3 months of antioxidants. And what you will notice is there was no benefit whatsoever, not only on morphology, on motility, but also on DNA fragmentation itself. Doing this sort of intervention had no benefit whatsoever on those patients. And also, if you try to treat DNA fragmentation in IVF, they also seemed, at least using the microfluidic hypothesis recently published as well, in this setting of an RCT, you also did not notice any increase whatsoever in the live birth rates of fresh and frozen embryo transfers. There is only one study which seems to point to the benefits of using a routine sperm DNA fragmentation for patients that are trying to perform ICSI. And that is the possibility that both in normospermic patients with repeated ICSI failure or in oligospermic patients that haven't even had a failure, it seems that in those cases, when there is a very elevated sperm fragmentation, that it could be beneficial to actually perform a testicular biopsy and use testicular sperm instead of using the ejaculate. This, however, is still very early days to give this as a final response, as the data set that we have on it is quite small. So in summary, I hope that what I showed you is that the diagnostic scheme that we use for infertility is in continuous flux. To continue to do what we used or learned in university may not be the best approach. However, don't go immediately to the new strategies, because they are also directed to very less understood infertility diagnoses, such as tubal plugs or endometrial receptivity with chronic endometritis, and also to sperm DNA fragmentation, which is also still fairly poorly understood. Thank you very much for your attention.
Дякую, шановне Самуелі.
Thank you, Samuel. It has been a very, very interesting presentation. Now let us look at the questions. The gel is very, very interesting. As far as I understand, it's the ultrasound sonography gel, right?
I was mentioning the one that we use is gel, which is commercially called exam foam. We've been using it for a long time. We noticed a huge difference in terms of the pain of patients. We no longer have experience of patients telling me that it hurt more than delivery or something like that we will normally hear. And it does have a learning curve. You do need to take a little bit of time to feel comfortable to do it. We have been using it in the past. However, this data with Lepiodol that I showed you from New England, from the group, once made us think again about the of returning to more invasive approach. What we're honestly doing is waiting for a new study that's coming out from the group of Belgium, which is trying to assess what is the real theory for the benefits? And because there are two theories around the oil-based approach. One, that it's either unblocking these plugs that I was talking about, but the second theory is that it might be actually bathing the endometrium. So there's actually a study now ongoing in a group from Belgium, which is assessing the outcomes of using Lipiodol previously to frozen embryo transfers. So we're awaiting that result very curiously to see if we can understand better the results with the oil-based system.
Самуель, дякую.
Thank you so much, Samuel. The work on oil-based and water-based, these researches come up, and thank you for raising it again. It's very interesting about the oil-based solutions. My understanding is that, well, that is why we're doing oil-based gels. Oil-based gels. It's a way to the future. Now I give the floor to more questions.
I would like to ask you a question. Do you think in our situation, maybe the DNA fragmentation must exclude from the infertility clinic? Because, as you explained, we have not any benefits. If we could answer only for one question, to do ICSI or not to do ICSI. But for this moment, when the ICSI approximately 100%, what is the value of this investigation for DNA fragmentation? What is your point of view?
Yeah, so I get your point. So the question that you're raising is, in a setting in which ICSI is increasingly performed, is there any benefits to perform DNA fragmentation or not? Well, for us, we believe it's still quite early days to check these results. I wouldn't, however, discuss on the ICSI and not ICSI approach, because the DNA fragmentation for us, it doesn't allow us to make the decision of ICSI versus non-ICSI. For us, what is on our table, and we do that, is in patients with excessively high DNA fragmentation, we consider the possibility of actually doing, and we invite patients the possibility to do testicular biopsy if they have multiple previous failures. So it's actually not about just ICSI, it's about using testicular sperm in cases such as those. But we are also quite open to patients, telling them that it's very early days for that information. But some have accepted, and we have had positive results.
Thank you. I would like to thank you, if you have not another questions, for your very interesting presentation, and we hope to see you in Ukraine in our offline meeting next year. Okay.
Thank you very much.
У мене ще одне запитання.
Samuel, I have just one more question. When can laparoscopic control of tubal status can be used?
Laparoscopy to two instances. We use it either when there's concomitant pathology. So if there is a cyst that we are curious to evaluate, if we have a doubt that there might be deep infiltrating endometriosis, we will advance immediately. If there is a myoma that we want to treat, that is the situation that we most normally use laparoscopy. And the second alternative is when we have a doubtful exam from tubal testing with more traditional approaches. I must admit to you, however, that the use of laparoscopy for us has become less and less common. We're doing it almost never now because, like I told you, we are selectively testing the patients that we do tubal testing to start with. So what used to be a huge factor for laparoscopy, which were the false positive tests, we now have them less and less.
Самуель, дякую. Я зрозумів.
Thank you, Samuel. I understand that your attitude to laparoscopy is quite cautious. right? So all the methods, non-invasive to control the tubal status, they are better.
We are much more non-invasive in that approach. We wouldn't recommend in favor. And the more the ultrasound comes out, the more you notice that the first line treatments are becoming more and more similar to the gold standard. If you look at the RCT published in Human Reproduction comparing non-invasive gel for hysterosalpingography, you look at sensitivity and specificity numbers which are almost overlapping. So they just got so good.
Thank you, Samuel. There's also a question from the colleagues in Belarus. Oleg Tishkevich has a question on ICSI, on PIXI methodology.
From PIXI or not. If the question is open-end, do we perform super selection via PIXI? We don't. We really believe that the data is very completely out there. The most recent analysis on the topic performed, if I recall well, from Annick de Vos, was very clear on the lack of benefit. There is also a recent RCT from the UK group also showing exactly the same. So I would argue that PIXI at this moment is not a lot more than a gimmick. And what we don't know yet, although we do know that the most recent microfluidic approaches aren't the best, we don't know if approaches such as MAX, those are still lacking. And to be honest with you, I believe that is a huge area of infertility that we are failing as a community. We're not investigating as much as we could the sperm selection. So I would encourage not routine untested methods to better sperm selection, but I would encourage further research on this topic. For instance, our group here in Lisbon, we're trying to use a thermotaxic approach by small changes in temperature to diminish DNA fragmentation. And the animal models showed very, very good results there, but I wouldn't encourage that you all do it, at least for now.
Thank you, Samuel. There's another question. And also we have not only Samuel, but we have Mira online.
Good morning, everybody. Hopefully you enjoyed the lecture. Hopefully you can hear me. Let's see.
Waiting for questions, Mira.
Huh?
We're waiting for questions.
Okay, good. Because I thought, yes, I'm unmuted and I guess everybody can hear me. Good?
Mira, I would like to ask you one question. That
yes.
You declared the SWE guidelines for today, yes?
Yeah.
You understand that? Let's see in the future. What do you think? What is the future trends to development of ovarian stimulation? What could you predict?
I'm sorry, I didn't hear the question properly.
You understand that? You describe in your presentation the existing SWE guidelines for IVF-XC.
Yeah, that's true.
Let's see the future. What do you think? What will be the future trends to develop in the ovarian stimulation? What you could predict there?
The future trends, I think we are trying to get more safety, meaning by, of course, prevention of hyperstimulation. And the second theme, what we were thinking about is the individualization of the treatments, and therefore trying to diminish the burden of the treatment. So we have a lot of couples who go through many IVF treatments. And what happens is that we find that the patients find the treatments very difficult, and we get a lot of dropouts.
Okay, thank you.
So basically, we try to individualize get kind of the best treatment for a couple that they would be successful in as short as time as possible. I guess that's everybody's goal.
You understand it. By another words, simplifying and more flexible for the patient.
Sorry.
Александр Михайлович,
Повторіть запитання.
Okay. We haven't heard the lecture so far, and
for all of our...
Oh, I'm sorry, there was some trouble.
Okay.
So back to the question, if you can...
Yes, I would like to thank all participants of our session, and I hope that this pandemic time will finish next year, meet in Ukraine or in other countries, because the efficiency of offline meeting, I think it's better than online. But in spite of this, we try to use the possibilities, increase our knowledge, and to diverse the information about the new kind of treatment, new approach between the members of Ukrainian Association of Reproductive Medicine. Thank you.
Шановні колеги, ми будемо...
I would like to say thanks to Valery Dmitrievich. We are concluding this very interesting session. I would like to say thanks to Samuel, to Mira, to Dmitro for organizing this session from 3 different continents. Thank you for the very interesting discussion. I suggest we now have some tea or coffee, and we will reconvene at 11 o'clock, and we will have another very interesting presentation from the speakers in the studio. See you at the next session at 11 o'clock. Thank you.
Прогестерон – это стероид, состоящий из 3 циклогексановых и 1 циклопентанового кольца. Для терапевтического использования прогестерон производится из корня дикого ямса, вида Диоскорея. В связи с интенсивным пресистемным метаболизмом в печени, прогестерон обладает очень низкой биодоступностью при приеме внутрь, и концентрации его изменчивы, поэтому его вводят инъекционным или интравагинальным путем, что сопряжено с определенными трудностями и сопровождается побочными эффектами. Дидрогестерон начали использовать под торговой маркой Дуфастон с 1960-х годов для лечения состояний, связанных с дефицитом прогестерона. Процесс производства дидрогестерона очень сложный. Начинается он с модификации прогестерона, за которой следует важнейшая фаза преобразования в дидрогестерон. Происходит это путем пропускания молекулы через ультрафиолетовое излучение с соответствующей длиной волны, интенсивностью и временной последовательностью, что приводит к формированию уникальной модифицированной структуры ретростероида. Такой процесс производства делает дидрогестерон единственным ретро-прогестероном на фармацевтическом рынке. Изогнутая форма перорального дидрогестерона усиливает жесткость молекулы в сравнении с прогестероном. Благодаря своей уникальной структуре дидрогестерон является высокоселективным к рецепторам прогестерона, восполняя дефицит эндогенного прогестерона. Он почти не взаимодействует с рецепторами других стероидов, что обеспечивает отсутствие андрогенного, эстрогенного, глюкокортикоидного и минералокортикоидного эффектов, которые возможны при применении других прогестогенов. Дуфастон, содержащий 10 мг дидрогестерона в каждой таблетке, обладает высокой биодоступностью, что позволяет пациентам пользоваться преимуществами перорального применения. Улучшенная биодоступность и повышенная рецептивность его метаболитов приводит к изменению секреторной деятельности эндометрия, прогестогенной активности, при дозе в 10-20 раз ниже, чем для микронизированного прогестерона. Для поддержки лютеиновой фазы при дефиците эндогенного прогестерона изучено применение различных прогестогенов. Только дуфастон, прогестерон и 17 альфа-гидроксипрогестерон капрат, одобренный для применения во время беременности. Кроме того, дуфастон имеет широкий спектр показаний для восполнения эндогенного дефицита прогестерона. Доказано, что он эффективен при нерегулярном менструальном цикле, дисменорее, эндометриозе и вторичной аменорее. У женщин, забеременевших с помощью вспомогательных репродуктивных технологий, дуфастон при приеме внутрь восполняет эндогенный прогестерон и обеспечивает эффективную поддержку лютеиновой фазы, способствуя более успешным исходам беременности по сравнению с микронизированным вагинальным прогестероном. Около 113 миллионов женщин по всему миру принимали дуфастон, включая 20 миллионов детей, которые родились на фоне приема препарата дуфастон.
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
There's something that brought us to other further horizons.
Say again, Houston. Roger, we'd like to get both of you in the field of view of the camera from
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life.
I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be. I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be.
Greetings, dear colleagues, and I'm so grateful to be here and to greet you this year's warm, independently of everything that happened, everything connected with coronavirus. It still are happening, and we have today a wonderful and interesting opportunity to speak on the new gonadotropin. We've been waiting for that one. The launch of this drug have happened in Europe on ESHRE 2017, and from that on, I was constantly in contact with the Ovarian company. I always ask, like, when we will see this drug in our country, when we will see and have an ability to use those wonderful capabilities. And finally, we have this ability to join to the number of clinics who have tried the medicine that we are talking of, the experience that our international colleagues have. And today's section will be dedicated to the new gonadotropin, to the folitropin delta. And today we are having such an interesting composition of our speakers. I would say it's a star drag race, which is the Professor George Griesinger, a big friend of our Association of Reproductive Medicine in Ukraine, the Professor Antonio Lamarca from Italy, and also Professor Fabio Cruz. And before each and every presentation, I'll tell you more in detail about every of the speakers. I'm quite sure, my respected colleagues, that you have a enormous amount of questions after those presentations, and we have planned the sections for questions and answers for 30 minutes, for 30 whole minutes, and the end of all of the three presentations. So please pile up all of your questions to the chat box, and maybe we won't be able to answer all of the questions, but we will try to cover the most interesting ones. And the name of today's presentation, or the section, Personification in ART, Delta of Opportunity. Delta here came up not for no reason, because we will talk more on folitropin delta. It's prominently known for illness that recombinant gonadotropins, they do exist on the market, and we do use them from the 1995, and still only after 20 years of usage, the scientists were able to develop the new approach, and this gonadotropin, it's being produced no longer on the animal cell lines, but on the cells of the human lines. And this has given the new capacity and makes this medicine more of a natural type and more active, and it has properties as close to natural that human has as possible to the gonadotropins that the person actually produces. And I think that we can give the floor to the Professor George Grisinger. His presentation is called The Optimization of Ovarian Stimulation. I was a great pleasure to listen to all his presentation because they are so practical, so interesting, and we do know for a fact George Grisinger, for a long time, he took part for the longest time in most of our conferences, and they're dedicated to the stimulation of ovaries. And I would like to tell you just a few words about our dear professor. This is the professor of Lübeck University, Department of Gynecologist, Obstetrics and Endocrinology of the University Clinic. His scientific interests include endocrinology of the ovarian stimulation, evidence-based medicine, epidemiological tests and trials and studies. His doctorate degree was dedicated to the stimulation and the usage of GnRH gonadotropin antagonists. And you will be surprised, actually. I was also quite surprised that he is leading in a chair of one of the manufacturers of such an interesting journal or a magazine as the Reproductive Biomedicine Online. One of the best and the most practical or clinical scientific issues or releases.
To the first presentation. Please, dear Professor Grisinger, we have a pleasure to see you and have a pleasure to listen your lecture, Optimization of Ovarian Stimulation. All questions which we will have, we will try to ask you at the end of 3 sections.
Thank you very much. So, hello everybody. It's a pleasure being invited to speak to you. Let me just clarify, do I need to share my screen with you guys? People?
Could you share your screen? Could you share your screen, please? Could you share your screen, please? Could you share your screen?
You should share your screen because you are in Zoom conference.
Thank you very much. Yeah, thanks for the introduction. I have the pleasure now for 30 minutes to talk about optimization of ovarian stimulation, a whim or necessity. And I would want to firstly share quickly my potential conflicts of interest, which you see here. This is the second slide. So you will see I've been engaged with many players in the field. And I would like to firstly share a thought with you. I've been working on ovarian stimulation for 20 years. And I think we all have come to understand that efficacy-wise, by modifying ovarian stimulation, we cannot forever increase pregnancy rates and live birth rates. So a lot of the optimization of ovarian stimulation has something to do with making things safer, more tolerable, easier, more predictable, and at the same time being as efficacious as possible. And this is delivering a given number of oocytes to the lab, which we need for running a good IVF service. So having said that, I would want to start with safety. And my question to you is, what is the incidence of OHSS at your center, and how do you really reliably monitor that? And I'm always amazed to see when I talk to colleagues, they tell me OHSS in my center is not an issue. I hardly ever have one. But is that really true? And it's quite amazing if we look at registries, for example, the UK registry, and we have a similar situation in Germany, where doctors put into their software files the incidence of OHSS. But then when we look of how many patients go and see another doctor or go to hospital because they do have problems, it is quite disparate. So let's have a look. This is what's been reported for the UK. This is OHSS reported by the clinic, and this is the ICD coding of emergency hospital admissions. These are women who often in the evening at night, because they have severe pain, they have severe discomfort, go and seek the emergency hospital admission. So we see this discrepancy in what we classify as OHSS, but what really, as a consequence of ovarian stimulation, leads to discomfort and issues at the emergency admission. And these people, of course, code that as OHSS, even if we, as reproductive medicine people, would by a very strict classification not classify this necessarily as an OHSS of severe grading. So, but then what do the data tell? So this is sort of a real world thing, and I do think there's some truth to that. But if we talk about OHSS requiring hospitalization, what do we know from controlled data? And this is the old phase 3 trials comparing long agonist and antagonist stimulation. And if we look at long agonist stimulation with HCG trigger, data tell us controlled trials, not risk patients. These are phase 3 trial populations. So the PCO women and all these will be out. It is 3 to 4 in 100 that went to hospital in these studies because of severe OHSS. And then what you also see in this slide is the effect when we compare antagonist with agonist for the incidence of severe OHSS. The relative risk in the column effect is 0.47. So it's approximately half the risk with antagonist. That means if per 1,000 women previously treated with long agonist, 30 to 40 went to hospital because of severe OHSS, only putting these patients on antagonist and triggering with HCG will result in only 10 to 20 people of 1,000 going to hospital because of severe OHSS, still a very high number. This is something that we have nicely seen in our own data. This is from my center, OHSS grade 3 prospective data published in Reproduction, mostly antagonist or nearly exclusively and HCG triggering, 2.7 patients severe OHSS. We see this in other data, more recent data. This is from the corifotropin licensing program, Talat's first author. Here you see the incidence of moderate to severe in a large phase 3 trial program. Here we talk about 2,000 patients that were prospectively followed through stimulation, triggering, and luteal phase. And then again, bear in mind, these are selected populations, not the PCOS, not the irregular cycles, and all that. So we all understand that secondary prevention by agonist triggering is extremely important. What does secondary prevention mean? That means you put your patient on ovarian stimulation, and now she's hyper-responding, and now you need something to prevent OHSS from occurring. Primary prevention would be to already identify patients that you need something different to be done in terms of stimulation. And tertiary prevention would be the patient has OHSS already, and now you need to deal with the issue. So I think we all also agree that for secondary prevention, it is agonist triggering is the method of choice. You're all familiar with agonist triggering, a short endogenous LH surge eliciting final oocyte maturation, but then leading to luteolysis, and the symptoms of OHSS should vanish rapidly. Now, for who shall we do agonist triggering and freeze all? High responders, obviously, but who is a high responder? And this is what you see here. I think the data are pretty strong on that. Let's say prospective study post hoc analysis. So what we have here, we have 3 phase 3 trials in which all the women received recombinant FSH or corifotropin alpha for advanced stimulation, all antagonist, and of note, all the patients received HCG. A few were cancelled because of extreme hyperresponses, but all the other patients that went to oocyte pickup received HCG. So we have 2,500 prospectively collected cases, of which we observed 35 severe OHSS. Severe meaning these people had to go to hospital and they were severely ill. And so this is an incidence of 1.4. I think that's quite realistic for the type of population, prospectively collected data. And what we did was we were looking at who were these patients that went to hospital. And what you see here is we looked at follicle numbers, we looked at estradiol levels, and we looked at combination. What you see here is the areas under the curve to predict severe OHSS with people going to hospital. And what you see is that follicles perform very well. E2 does not perform that good. Follicles and E2, there's not a lot to gain. So our recommendation for that paper was clearly, let's go for follicles. And you also see the cutoff at 19 follicles larger than 11 millimeters. On the day of triggering, the sensitivity and specificity was 74 and 75%. Now, what is very important to understand with these sensitivity and specificity comes a positive and a negative predictive value. And extremely important to highlight that is, if a patient on day of triggering in the antagonist protocol now has more than 19 follicles, she may or may not have severe OHSS. But what's the positive predictive value? It's approximately 30%. So out of 100 women that have more than 19 follicles, 30 of the 100 women will have severe OHSS. But this is not very fascinating. But what is really fascinating is the negative predictive value. And this is in these 2,500 patients. A patient that was below the 19 threshold, that patient had 12 follicles, 14, 16, 18 follicles, 99.5% of that population did not develop severe OHSS. So the negative predictive value is very high. In other words, a patient that responds normally has 10, 12, 14 follicles, you don't need to do agonist triggering, you don't need to do freeze-all because that patient is simply not at risk. Mind you, OHSS occurrence is of course not purely a threshold phenomenon. So we've modeled the risk. Of course, it does make a difference if you have 20 follicles, 30 or 40 follicles when you trigger. And this is what we've tried to model here. But what is correct and consistent also with other data in the literature, that is that the red zone, so to speak, starts somewhere around the 18 to 19 follicles where the risk starts to increase. So now it's easy. So we have antagonist stimulation. We identify the patient with our rule of 19 follicles. Now we go for agonist trigger, freeze all, and then we do a frozen thought embryo transfer. So there's many publications on that. So we've done a feasibility trial in 2007, claimed this is nicely feasible. We've done follow-up studies, multicentric, and looked at the occurrence of live birth rate, occurrences of OHSS. But the question is now, is it really safe? Also in the real hardcore high responders. And again, I'm talking about an agonist trigger and freeze all. So firstly, what I've modeled many years ago already was we come from long agonists, 3% of patients, so 30 to 40,000 have severe OHSS. Switching to antagonist trigger with HCG, half the incidence, 1.5, so 10 to 20 in 1,000 go to hospital. And then we said, well, if we apply our rule of 19 to all these patients, and if agonist triggering is 100% efficacious, so there's no case of severe OHSS after agonist triggering freeze all, excuse me, we should get the incidence of severe OHSS down to 4 in 1,000. So we come from 3 to 4 in 100. And by applying all that knowledge that we generated in the last 15 years, we should go down to only 0.4. So this would be 4 in 1,000 patients that would still go to hospital. So nothing is 100%. But then, of course, also is agonist triggering and freeze all 100% efficacious in preventing OHSS? And the answer is, well, firstly, let me say this. So this was my prediction many years ago. And you know what? I believe this is what we see in the data, because this is here from SART data. This is the American Registry of IVF. What you see is where hyperstimulation was recorded in 5 per 1,000 cycles, moderate in 4, severe in 1. So I do believe that indeed what we have built on in the last 10, 15 years in terms of making ovarian stimulation safer has come to the real world. Now, the problem is nothing is 100%, even not agonist trigger and freeze-all, because we reported in 2011 the first index case where we said we had agonist triggers, but that patient was severely ill and she had to be hospitalized. So we published this in Fertility Sterility in 2011, and I remember at that time people were bashing me, and I received letters and I received sarcastic comments in other review articles where people say, well, we don't think this was a real OHSS case. That patient had bleeding from the ovaries and this and that. But I insisted, because I've seen the file. I didn't see the patient in my center. It was a multicentric study. But I insisted from everything, all the medical information, no, that patient had to be classified as a severe OHSS. And here we go. In the years coming, more and more people reported, yes, even if we do agonist trigger and freeze-all, severe OHSS can still occur. Fatemi, Gurbus, Ling, and then even Fernandez Sanchez on the ESTER trial program. And this is quite intriguing, because what you see here is modern day trials will already factor in that some patients do hyperrespond and that agonist triggering and freeze-all can be an option. So it's amazing to see. The next speaker is going to talk you through that trial at greatest depth, but I'm only looking at one specific element here. This is the protocol of the ESTER trial. ESTER trial was a huge randomized trial, ovarian stimulation, antagonist protocol, and now we look at the triggering aspect. So what you see here is if women were hyperresponding, this is 25-35 follicles larger than 12 millimeter, and they could be triggered with agonist. And only in the very severe cases, more than 35 follicles, the cycle was cancelled. So in that trial, patients mostly received HCG trigger, but already it was factored in, if a high response occurs, let's do a secondary prevention. And what we see in that trial, that with individualized follicle delta stimulation and with conventional follicle alpha stimulation, yeah, we see, despite these safety measures, canceling in extreme hyperresponse cases and in the intermediate agonist trigger, we see hospitalization due to OHSS with a total of 8 cases in this trial program. So this is where we are with safety. So I do believe we have made enormous steps forward in getting ovarian stimulation much, much safer, but nothing is 100%. And so safety continues to be an issue. But safety is not the only issue, because we as doctors say, well, the patient didn't die, she didn't go to hospital. Well, everything's fine. But this is not the end of story, because the patient has a perspective, and that has something to do with how does that all feel. And I was quite amazed to see that even today, we fall short on understanding patient tolerability of a hyperresponse and continuing to OPU and freeze-all and all that. So we measure the safety issue well. We have all the data that I just shared with you, but we forgot a little bit to ask, how does that all feel for you? What is your patient experience around having a hyperresponse and then just doing the wild thing and just go for it? You just take out all these oocytes and freeze. And I think very good data also come here from the ESTER-1 trial. So this is unpublished, this is data on file, but what you see in the ESTER-1 trial, what happened was that these patients again received antagonist stimulation, folliotropin delta, individualized dose versus standard dose. And I'm only alluding here to a tolerability assessment in that trial. I have to apologize, this is not an abstract as ASRM, so this is still unpublished. This is data on file. So what the patients had to do is, first, body measurements were taken throughout the trial, screening and at different time steps during ovarian stimulation and into luteal phase even, end of trial. And then you see abdominal discomfort. So how do you measure abdominal discomfort? And there's only one way. You ask the patient, and that patient fills out what is called a visual analog scale. So you have 0 to 100 or 0 to 10, and you ask the patient, so how severe is your discomfort? And the patient will tell you on these occasions what you see end of stimulation and on day of transfer. The patient was asked, how do you feel? So we have data from prospectively collected data from approximately 1,300 women. So we know everything of these women. We know their body weight changes, we know their oocyte numbers, and we know now how they feel. And so this is what we saw. So it's a bit of a convoluted figure, but let me talk you through this. So if we look at the end of stimulation, this is on the right here, the visual analog scale. So this goes from I feel no pain at all to I die. And this would be what you see here, 100. With 100, patient would say I jump out of the window. 0, I feel nothing. So the patient is less than or equal to 7 oocytes, so the VS score is only 13. And then we see how that increases. And then if you have more than 25 oocytes, you already have a pain scale of 25 at the end of stimulation. Now that increases further to the time of embryo transfer. And what we see is a mean increase of 4.3 units on the scale per 10 more oocytes. Now, one may argue, is that a lot or not? I expected it to be worse, I have to confess. So I said, well, in a way, it's not that bad as I expected it to be, but still there is, as expected, a clear and measurable and statistically significant association between discomfort and the number of oocytes that you have. But what is more intriguing is, of course, the adverse drug reactions, ADRs, and OHSS, of course, make a huge difference when we look at oocyte numbers. An adverse drug reaction would not only be the discomfort, a subjective thing, but an objective thing. Patient would say, well, I do have severe belly pain, regardless of what she's crossing on her visual analog scale and the likes. And this is, of course, going dramatically up when you have many oocytes. So the conclusion for this is OHSS and hyperresponse primary prevention is key. But how do we predict hyperresponse? And I've only 2 more minutes left before I hand over to Professor Lamarca. So let me quickly, just with a little time that I have left, emphasize one thing. And this is when we do prediction modeling, we can predict whatever we wish. At the end of the day, we need to have a model that we use, but we need to calibrate and we need to validate that. And a lot of the next lecture is going to be around the insight generated from the very first time a huge modeling exercise with calibration validation has been performed. But let me just make one final comment in the little time that I have left, is that we try in ovarian stimulation to control variation. Every patient is different AFC, different AMH, different age and all that. And that, of course, leads to variation in outcome that we try to control when we individualize. So we say every patient is individually different, and now we tailor the treatment to these differences. And we've done a good deal of work on the antral follicle count, just to learn that the antral follicle count is not the optimal predictor when it comes to predicting ovarian stimulation response. This is data from my center. This is a prospective trial, 212 patients. And here you see the AFC on a regression line to the follicles larger than millimeter on day of HCG. And you see, I mean, it's really scattering out. The R-square is only 25%. So only 25% of the variation in response we can explain by the variation in AFC between patients. So not very good. But this is what it is, because this is not that we cannot do ultrasound here in Lübeck. It is what other people have also found. Because if you look at the ARTHE data, this is the megacell trial, you see the AFC plotted against the number of oocytes retrieved, and you can see with a similar AFC endowment, you can have completely different ovarian responses, from poor response, less than 3 oocytes, to a hyper response. So you see it's really, the curve is flattened out. And this is not the case for AMH, and this is what I'm showing you here. This is again megacell trial data. What you see here with AMH, the curve is not flat like this, but now it's really spreading out. So with increasing AMH levels in patients, you increase your response much more reliably. We do know that AMH can vary. There's a beautiful paper by Professor Lamarca with the title, How Much Does AMH Really Vary in Women? And a lot of what is here, just the bullet points, you'll also find in the paper. So we do know that, for example, OCP, etc., reduces AMH a little, but then there's not much of an ethnic difference. PCO women have higher, smoking can reduce, and all that. So this you must take into account. But after all, AMH is most likely the most stable proxy of the ovarian reserve. Another thing that I also want to just quickly touch on is the issue of body weight. And this is something that has been overseen in the initial developments of the gonadotropins, when we talk about folitropin alpha, folitropin beta, but something that we have seen in the context of chorefolitropin, this is Elonova, and what we again have seen for folitropin delta, and this is the distributional volume of a woman, how much kilo she weighs, is a major impact on the exposure of that woman to the drug, and that relates then, of course, into the response of that woman to the ovarian stimulation. And when we talk about controlling variation, AMH does perform best. This is what we've seen in the trials pre-ESTER trial for developing folitropin delta algorithm. This is something that we have seen in our own data in the Lübeck ovarian response trial, that AMH, regardless if it's poor response or hyper response, is the key factor. It is always beating all the other biomarkers that we have. So, as I said before, when we do the exercise of trying to identify ex ante from the start, who is going to be at risk of OHSS, of discomfort, of exploding with the ovaries, we need the data, we need to code predictors, we need to build a model, specify the model, we need to calibrate that, and then we need to validate that, and then we must understand what does implementation really mean for practice. And with that, I hope I could set the scene for the next two speakers who will now educate us on the latest insights on how that really works. And this is ESTER trial and beyond. We have ESTER 2 and so on, and auxiliary analysis. And with that, again, I'm sending my best regards to my colleagues in the Ukraine and to my fellow speakers. I thank you for listening to me, and I hope I could share some interesting insight with you. Thank you.
Thank you very much for your fantastic presentation, as usually. Really interesting, really practical. And now I have great pleasure and great honor to present the next presentation, Professor Antonio Lamarca, Professor of Obstetrics and Gynecology at the Department of Medical and Surgical Science for Mother and Child and Adults, University of Modena, Reggio Emilia, Italia. The presentation will be about folitropin delta. Folitropin delta, the answer for actual questions of modern ART approach. We know Professor Antonio Lamarca as a specialist of laparoscopic and hysteroscopic surgical procedures. He has a huge number of publications, more than 160 articles, and his main interest is ovarian stimulation protocols, personalization of these protocols, ovarian reserve, ovarian response. So now I think we will listen very interesting and practical presentation concerning the use of this new gonadotrophin, folitropin delta. Please, Professor Antonio Lamarca, your presentation. We are waiting.
Yes. Thank you very much for your very kind introduction, and sorry for my voice today. I'm going to share my screen. Okay. Can you see my slides? Yeah? Okay. Thank you. So, first of all, let me thank the scientific committee of this Congress and the Ferring Company for the very kind invitation. Well, we're going to talk about ovarian response and how to control ovarian response to gonadotropin stimulation. So again, let's start from the real life data. If we look at our own activity based on the last 1800 IVF cycles, you see here the curve of distribution of retrieved oocytes according to our own activity, to our own experience. 20% of women had in some way hyper response, while only 10% had poor response and 70% had normal ovarian response. So in this graph, you can see both the two extremes of ovarian response, which in reality are important because the extremes of ovarian response are associated to some modification in the live birth in IVF cycles. Mainly poor response is associated to significant reduction in the rate of success in IVF, but also hyperresponse is associated to a relative but significant reduction in the fresh live birth rate. Most importantly, hyperresponse is associated, as George said, to an exponential increase into the risk of ovarian hyperstimulation syndrome. So that's why, very simply, clinicians do not like to have the extremes of ovarian response in the IVF practice. And this is the reason why we want to personalize the treatment in IVF. When personalizing treatment in IVF, our main objective is to increase the proportion of patients, of women with a normal and safe ovarian response, while possibly decreasing the two extremes. But if we want to manipulate ovarian response in IVF cycles, first of all, we have to understand what is going to affect, to influence ovarian response to gonadotrophin stimulation. Of course, patients' characteristics, including the number of antral follicles, their sensitivity, their ability to respond to gonadotrophin stimulation. But for sure, we cannot change patients' characteristics. So we just can try to modify the treatment. And we now know, George said, that different type of pituitary suppression may change ovarian response, as well as different types of gonadotropin may lead to a different type of ovarian response. But still, the most important variable here is the dose of gonadotrophins, mainly the FSH statin dose, the dose of gonadotrophins given for the first 5 to 6 days of ovarian stimulation. And this is what I have in my mind. I mean, you have here the curve of distribution of retrieved oocytes in the MERIT trial and in the MEGASET trial. In these two trials, women have been treated with a starting dose of 225 units and 150 units respectively. And it is quite clear we have here two different curves of distribution of retrieved oocytes, despite the women had a very similar age in both the two trials. When we are going to use a dose of 150 units, the curve of distribution of retrieved oocytes is completely shifted to the left, which means that we are going to have an increasing number of women with a suboptimal or a low ovarian response. On the contrary, if you're going to use 225 units, you're going to increase the proportion of women with a high response. This is just to say that some women in reality need a low dose, while others need a high dose of gonadotrophins. Women need a personalized dose of gonadotrophins. And as George said, we now have good tools to predict ovarian response, antral follicle count, and mainly AMH, which are strongly related to the number of antral follicles available at that moment for ovarian stimulation. The higher the AMH, the higher the ovarian reserve, the higher the risk of hyperresponse and ovarian hyperstimulation syndrome. So just by measuring these two markers, you may deploy the strategy for ovarian stimulation which is appropriate for your patients. And we have quite recently showed this concept in a trial in which we compared women with a fixed dose of gonadotrophins against women with a personalized dose of FSH. And we showed that when the dose of FSH is individualized, there was a significant increase in the proportion of women with a good, normal, and safe ovarian response. Folitropin delta. Folitropin delta is a new gonadotrophin, is a recombinant gonadotrophin, which has been obtained in a cell line of human origin. Because of this, the glycosylation profile is much more similar to human endogenous FSH and is quite different from other recombinant FSH into the market. And you can see here the glycosylation sites for folitropin delta in red, which are completely different from what found in folitropin alpha. The consequence of this is a new or different pharmacokinetics and dynamics between different formulation. In particular, folitropin delta here, illustrated by the blue line, seems to be more powerful when compared to folitropin alpha. Serum FSH is higher when women are treated with folitropin delta versus folitropin alpha, and expectedly estradiol production is higher as well. Most importantly, the cohort, the number of growing follicles when women are exposed to 11 days of folitropin delta treatment seems to be higher when compared to folitropin alpha. Folitropin delta has been an objective of interesting trials. This is the phase 2 trial, which has been published on fertility and sterility in 2014. It's a very important trial because the objective here was to study the dose-response relationship existing between folitropin delta and ovarian response. So healthy women have been included, and they were treated with a standard fixed dose of 150 units, or they were treated with 5 different doses of Recovelo, folitropin delta. And women were divided in women with low MH or high MH. And it's very interesting to see that in women with low MH, the red line here, the higher the dose of Recovel, the higher the number of retrieved oocytes. But this was much more evident for women with high MH. And so according to this dose-response relationship, researchers from Ferring had the ability to calculate their own algorithm to personalize the dose of folitropin delta. As George said, the folitropin delta must be chosen according to AMH and body weight. To give you the idea of the role of body weight in affecting the selection of the most appropriate dose of folitropin delta, you have here an example. You have here a woman with a body weight ranging from 48 to 55 kilos and treated with a low dose of folitropin delta. Well, the number of retrieved oocytes expected here is 7.4. If the woman would have a body weight of 69 or 70 or 80 kilos, there was a reduction in the number of oocytes may be expected. So this is very important, I think, especially when you are using low doses of FSH. In my clinical practice, especially when the dose of FSH is not the maximal one, well, you have to look at body weight. Body weight may be very, very important because it is influencing the volume of distribution of the drug. AMH is a continuous variable. So why don't we use AMH as a continuous variable? That's the basis for the continuous dosing regimen proposed by the Ferring company. you can see here increasing values for AMH and the decreasing in the dose of litropin delta per kilo. So by measuring AMH and by knowing the body weight of your patients, you may very easily calculate the suggested dose for litropin delta. The objective here is to possibly normalize the ovarian response to gonadotrophin stimulation. The objective is to possibly increase the proportion of women with a good, normal, and safe number of retrieved oocytes. And this concept and the Ferring formula have been tested in the ISTE trial. The ISTE trial is one of the largest trials we have in the IVF world, and we have more than 1,300 patients included and divided into two groups. One group was treated with a fixed dose of litropin alpha with generation antagonist control. The other group was treated with a fixed dose of litropin delta selected on the basis of AMH and body weight. The main objective here, so the primary outcome, was the ongoing pregnancy rate, which was similar in the two groups, but this was expected. It was designed as a non-inferiority trial, so expectedly no differences in the implantation rate. But let's look at ovarian response. Well, in the ISTE trial, it was shown that giving a personalized dose of litropin delta is associated with a significant increase in the proportion of women with normal and safe ovarian response. And if we look at patients divided according to the two AMH strata, so women with a low to normal ovarian reserve, or women with a high ovarian reserve, we can see again that giving the litropin delta, the personalized dose of litropin delta, was associated with significant reduction in women with poor response. And on the other side of the spectrum, we have a reduction in the proportion of women with high response, so a significant reduction in women at risk of OHSS. As a consequence, there was a significant decrease in those women requiring interventions such as said, generation agonist triggering, for example, or cancellation of cycle, because of the risk of ovarian hyperstimulation syndrome. I very much find interesting this graph. This is reporting the need of intervention to prevent OHSS according to basal AMH, and it is quite clear here that especially women with an AMH higher than 20 pmol per L, which is more or less 3 nanogram per ml, especially those women really need a personalized dose of litropin delta, especially in those women giving a personalized dose of FSH is associated to a significant reduction into the risk of hyperresponse and ovarian hyperstimulation syndrome. Not only, it seems only that those women with high MH may have benefits in terms of success rate. This is again a post hoc analysis of the ISTE trial. Again, the blue line is for litropin delta. The gray line is for the fixed dose of litropin alpha, and you have here the risk of OHSS and the ongoing pregnancy rate. Again, for women with a higher AMH, so for women with a very good ovarian reserve, the personalization of dose of FSH is associated on one side to a reduction into the risk of OHSS, on the other side to a possible increase in the ongoing pregnancy rate after the fresh embryo transfer. One of the more frequent questions we receive is related to the variability in AMH. In recent years, well, some variability for AMH has been recognized. This is particularly true for women with high basal AMH levels. And so clinicians very often, they ask whether this variability may have an impact on the predictability of ovarian response and on our ability to personalize the dose of FSH on the basis of a DMH. And this is the answer. Again, here Scott Nelson could elaborate data coming from all the three ESTA trials, and he could calculate the within subject variability of AMH, which was found to be 23%, and this may be considered acceptable for a hormone. They calculated that the time-related decline was small for AMH, it means 6% decrease per year. Most importantly, women with low AMH, so with an AMH level lower than 15 pmol/L, which is more or less 2 nanogram per ml, well, 93% would receive the same gonadotrophin dose despite this little variability in AMH. On the opposite side, we have women with a high AMH. Well, 80% of them will receive an individualized dose within plus minus 0.5 microgram variability in the folitropin dose. In the end, 95% of women are predicted to obtain an oocyte yield that does not vary beyond 1 oocyte count, which means that the recognized variability in AMH in the end seems not to be clinically influent, clinically relevant. So, dear colleagues, let me conclude with few take-home messages. In assisted reproduction technologies, individualized ovarian stimulation therapy is the starting point for achieving an adequate oocyte retrieval to ensure a balanced efficacy and safety profile. Individualization is based on ovarian response prediction. AMH is among the most accurate and reliable markers of ovarian reserve. The new proposal is to introduce a personalized dosing regimen for FSH based on a standardized approach. When compared with the conventional FSH dosing, the individualized folitropin delta dosing regimen based on pre-treatment serum AMH and body weight, first, maintained success rates while reducing OHSS and or preventive intervention. Second, increase the proportion of women with a target ovarian response of 8 to 14 oocytes. The folitropin delta algorithm-based dosing regimen is a new and innovative approach that offers reproductive endocrinologists the opportunity to individualize healthcare in IVF. Thank you very much for your attention.
Thank you very much. It was really interesting. We have a lot of questions, but we will wait in our section of questions and answers, and we'll ask you all these questions. There is a really big interest of auditorium to your presentation, but we should move. And I have honor and pleasure to present the next presentation, Dr. Fabio Cruz. He will do the presentation about his practical experience, folitropin delta in clinical practice, IVIRMA clinical experience. Dr. Fabio Cruz he's a specialist in reproductive medicine in EV Valencia. So he has big practical experience and really a lot of patients. And now I hope we will hear maybe most of answers to most of our questions which we have. So please, dear Dr. Fabio.
Well, good morning. It's a pleasure to be here with you, sharing our experience with the Congress from Ukraine. Thank you for the brilliant presentations from Professor Lamarca and Professor Griesinger. And I would like to be today the link between all these great scientific data and users. I will watch the link between the two previous presentations and you, which are attending to this Congress, who will be using this molecule in the end of the day. I was part of the second trial, the phase 2 trial, and the ESTER trial as well. From those 1,300, 100 was mine, so I was part of the thing. Quite happy to be part of it. And I was desiring this trial to finish and to have this molecule to use in my everyday patient. My feeling was quite interesting during the trials, and I wanted to use, but sometimes we feel like, well, what it's supposed to be will really work in my IVF clinic, in my population. And that's what I'm trying to say right now. So let's share my screen. Here we have it. Right. And great. So can you see? Fine. Great. So I was already introduced. I'm working in EVRMA in Valencia, one of the biggest clinics from this group, and we were part of the previous studies. Those are my disclaimers and disclosures. And well, let's talk about my first year of experience with this molecule. We have been using in Spain for a little bit more than 2 years already, the Fallopian Delta, but I prefer to talk about the first year because it seems much more closer to the experience of somebody that will start right now. So it was an interesting moment. All these patients were my personal patients, only 63 cases, but 63 cycles, 58 pickups, very variable number of oocytes ranging, I'll explain it later. And the average number of oocytes was about 10. And that's the first thing that matches a lot with the ESTER trial. So we can really target our oocyte yield. We use the patients with the AMH from 3 picomoles per liter, which is very low responders, to 71, which are very wild responders. And age very different, from 24 to 44, which are aged, again, different from the patients inside of the trial. So it is using for everyday patient, not only patient that fulfills the requirements of a randomized control trial, and different body weights as well. It matters a lot, as previously explained, the body weight matters a lot. So just some graphical information about the different number of oocytes we have been gathering. 24, like the maximum we had, and 3 oocytes with the minimum we had. We had patients with low MH, of course we have a lot of these. The average number of oocytes we already told about 10, and half of our patients were within the target. Everybody wants their patients to have a good number of oocytes, but not excessive, not to have risk of OHSS. So sometimes we can do that. Usually we can reduce high responders to normal responders, but it's very, very complicated to increase the response of somebody with only 3 picomoles per liter of AMH. So the low responders remain a very complicated thing to solve. And that's why we had most of them below the target. We had different ages from 24 to 44, and of course, 44-year-old patient, the prognosis is not as good as the others, but there are patients that sometimes they try to do an IVF and they have to be around. We have to test this molecule in every tool that we have to help them as well. And the body weight was very diverse as well. This is according to the number of oocytes. So there is no, it's not linked the body weight with the final outcome number of oocytes because it was personalized by the algorithm. And the final graphic is telling what the studies tell us. In my personal use, in my personal patients, we didn't see the patients with a very high anti-malarian levels having hyper-response. The line was not very different from the beginning to the end of this graphic. Of course, the first maybe 5-6 patients with a very low anti-malarian, well, yes, of course, these patients might have always a low response, but not the other extreme. They could be prevented, the hyperstimulation, in the very end. So again, not a very linked relationship between age and oocyte number. And finally, the outcome in pregnancy rates were quite amazing. I was surprised. It was a little bit higher than the outcomes inside of the trial. I was quite happy to see that 59% of the patients had an ongoing pregnancy after the first single embryo transfer. And some patients were waiting for PGTA and had no embryo for transfer after this. So if you look only for embryo transfer, 70% of pregnancy rates were quite amazed. Maybe lucky, maybe the patient selection was different, but I was glad to see that the results were not inferior than the results with every kind of philotropins, and we're quite happy to have this experience. But now I prefer to talk about some clinical cases and explain how can we use in different patients, in different situations, and different patients as well. There are a lot of variety, normal responders, which are more stable, high responders, extreme high responders, let's say PCOS patients, and low responders, which are always very tricky. So the normal responders, we can measure, we can calculate, and some might say that every tool, every strategy will fit a normal responder. But well, we can fit it better. This case, let's call her Maria. It's the most common name in Spain. Let's call patient number 1 Maria. She's 34 years old with 53 kilograms. She comes for an IVF because only a male factor. Well, the baseline characteristics is highlighted here, the anti-ovarian, about 18 picomoles per liter. Good one, not low, not excessively high. And which is the dose that you would choose for that patient? I really wish we could do a polling question you can answer and then do it later, but because of timing, I might say that probably most of you will choose different opinions, different answers. And well, I have chosen to personalize because I already had the algorithm, and we treated this patient with 8.3 micrograms of folitropin delta. And after 10 days, I could trigger with HCG because no risk of OHS was seen. And the outcome was 11 oocytes. Of course, no HSS was achieved with this number of oocytes, with this measured approach. And the patient was happily pregnant after the first single embryo transfer. Healthy baby was born because this was my first patient of them all 2 years ago. And she still had 2 more blastocysts frozen. What I'm trying to tell you with this patient is that to do a measured approach, not to stimulate as high as she can do, to maximize IVF outcome, was enough to be measured, to have a baby born and more blastocysts frozen for the future. Maybe if you do the strongest stimulation as we can do, we could have maybe 1 or 2 more blastocysts frozen, but for what? If the outcome is really good enough with this approach. The second patient, well, let's talk about high responders right now. But not PCOS, but high responders or potential high responders. And for example, let's call Susanna, patient number 2, with 33 years old and 55 kilograms, coming for a tubal fracture. So one of the best prognosis patients in our clinic. And the anti-Müllerian levels was around 37.2 picomoles per liter. Well, that patient, would we behave differently for her compared to the first one? If we have to choose ourselves the dose, we have to start to think and give an option. If you want to use the algorithm, it's way easier, and we have a very powerful tool to choose the dose for us. That patient came here after her first IVF in another clinic. This IVF, well, she was not very happy, not because it didn't work, because it's maybe luck. Not every IVF works in the first, but they started to simulate with 150 units, as probably most of you would have chosen. And then the stimulation was slow, and the doctors at the clinic decided to increase the dose to make it faster because it seems that it's not working. At the end of the day, they needed to decrease again, to take a step back, and it was too late because after 13 days, the outcome was 31 oocytes retrieved, and this patient unfortunately suffered of mild and moderate OHSS. not hospitalization, so maybe, as Professor Griesinger explained us, maybe not a notified case in the hospital, but it's still there. Moderate HSS with lots of pain and freezing embryos, freeze-all to transfer later. And she didn't get pregnant after the first transfer, and the 2 other blastocysts didn't survive after thawing. Not every clinic have, some of you might be thinking that, well, my clinic, when I freeze and thaw the embryos, they're fine. The probability to lose an embryo is very low, but it's never zero. And not every clinic is as good as yours. Maybe some of us might have problems with the vitrification. Well, this patient came to me, of course, asking to be pregnant, but mainly asking not to have OHSS again. And in this case, how should we behave right now? Decrease the dose, maintain the dose, or use this algorithm to find the best dose. This patient was maybe not the first one. The first one was the previous, but one of the first I used, and seemed for me the best patient to start using the algorithm. So is it built to avoid extremes? And I want to avoid an extreme right here, right now. And with the algorithm became with 6 micrograms of phototropium delta, one of the lowest doses that we can eventually give to the patient. And after 12 days, she is a slow responder anyway. We didn't need to change the dose in any moment with a steady doses from the beginning through the end. I could trigger with HCG with no fear because it didn't seem to have a high number of oocytes. 15 oocytes were retrieved, no HSS at all, and she could have a fresh transfer in this case. And she was happily pregnant, and well, it was one of my first patients. We already have a live birth, and with a different strategy, we could change from avoiding OHSS, avoiding freeze-all, and avoiding a lot of not very good outcome. Let's talk about extreme high responders right now, PCOS, or patients which had in the past OHSS, severe ones. Let's call Anna. With 33 years old again, 59 kilograms, PCOS is one of the causes of infertility. Of course, not only PCOS. Of course, we had a male factor in this case to start with IVF straight. And 71 picomoles per liter. It was very high antimilarian level. If I can recall, it was one of the highest I've ever treated. And, well, we don't fear this kind of ovaries, but we respect them a lot. And how can we deal with them? Well, it was very clear for me since I got to know this algorithm that the best way was to individualize. And it's even lower than the lowest dose we could ever give in the ESTER trial. Because in the ESTER trial, we couldn't include PCOS patients. But in real life, yes, they are there. So with 5.3 micrograms of phototropium delta, after 11 days, I'm not very comfortably, but I triggered with HCG because I believed everything was right, even being a PCOS patient. But 14 oocytes were retrieved, 12 mature, no HSS, and again a fresh embryo transfer. She unfortunately didn't get pregnant at the first time, but 3 more blastocysts were frozen, and the following month, without any stimulation, because she had frozen embryos, she got pregnant. And she still has some more for the future. So it was a history with a happy ending of a patient that had a very high risk of developing OHSS. If I remember one of the first expositions, if you have the number of oocytes, number of follicles very high and similarly very high, the likelihood to develop OHSS is quite high, and we could avoid with this approach. The next patient is a PCOS again. Let's call her Isabel, 36 years old, 61 kilograms, and 58.9, almost 60 picomoles per liter. Again, very high antimilarian, more than 40 antral follicles counted in the baseline ultrasound. And well, how can we deal with that patient again? Again, if you might ask, you might say 100, 150. There will be different opinions, even people that would stimulate strongly and deal since the beginning with the freeze-all. But for this patient, again, prefer to use the algorithm and seek 5.6 micrograms of folitropin delta. And after 9 days, we only achieved 3 oocytes. It was not what we expected at all. We expected high response, or maybe reducing the excessive of the response and having an optimal response. And how come a patient with the anti-malarian that I measured, with the weight that I measured, everything that I was measuring since the beginning, and in the end, we have less oocytes than we desired. It's not working, the algorithm. Human body is not a machine, but not every patient in the world that will respond the way as we expect. Every menstrual cycle is different. This patient, unfortunately, didn't get pregnant with the only embryo she got, not pregnant again. And what should we do next? Forget about the algorithm and stimulate in a strong fashion way, or still be careful. For this patient, the patient was not very happy with my strategy, but I prefer to be conservative and to be avoiding problems for her health, as OHSS, for example, and maintaining the very same approach. If it failed again, the patient would probably search for another clinic, but fortunately, it did work. And after 10 days, one more than the previous cycle, we triggered with ACG, and 12 oocytes were retrieved. Precisely the same medication, the same protocol, the same dose, the same patient, 2 months later. The difference was that human body can respond different sometimes, and I'm calling this case, which is a real case, just to remember that sometimes it's not going to work the way we believe, but it's not going to work anyway. It's not that we can control 100% of the outcome of the IVF. Even if you use the most powerful algorithm in the world, sometimes it might happen like this. And it doesn't mean that it's not working. It means that patients are alive and they're people and they can vary. So the second time, the outcome was really what we expected, not very high, but a good response. And I got an ongoing pregnancy and more embryos frozen for the following babies that she will have. It's not working. Okay, let's talk about low responders right now. It's very complicated to talk about low responders. There is no approach that will cure that problem. Maybe we can kind of cure or reduce a lot, as we have been seeing, the high responders, but not the low. What can we do for them? Let's call Hema. With 40 years old, but usually high responders have higher age as well. Not always, but it's very linked. 61 kilograms. And she comes here because she had low responders in a previous IVF. She got a low response, and she still wants to try harder. 5.1 picomoles per liter, not the lowest have I ever seen, but yeah, low responder, and 5 and follicles counted in the follicle count. Well, what should we do? Stimulate very aggressively because she's a low responder, or some scientific schools would maybe stimulate in a mild fashion way, because if we cannot have more than 5 oocytes, why stimulating so strongly? It's not easy to choose, and probably you are thinking about being mild because we don't need to be aggressive. There are not a lot of follicles there, and some might be thinking, well, let's be aggressive to extract the maximum what we can from these ovaries. And when this patient was previously stimulated with 450 units of recombinant FSH, which is probably the highest dose that most of we would give for the patient. I personally don't give more than 375, but it will be acceptable to use 450, depending on the weight. And after 12 days, 3 oocytes, 3 mature, 1 blastocyst transfer, and the patient was even pregnant, but unfortunately she had a miscarriage in the 6th week. 40 years old, probably embryo euploidy problem. But anyway, when she comes here, what I consider knowing her previous story, well, I would consider to individualize again and to give her the algorithm of the folitropin delta with 12 micrograms. 12 micrograms, if you don't know, if you haven't participated in the ESTRA trial, which was the highest dose that the algorithm would give you for the first trial. It was the first one, the highest one. So after 11 days, the patient was triggered with GnRH, but not because she needed to be triggered with GnRH, because in our facility, in our clinic, we usually give GnRH every time we're not transferring the embryo. We wouldn't transfer the embryo because PGT was planned, and 3 oocytes were retrieved. 1 blastocyst was biopsied, and we could find a good embryo, and she was pregnant, and we had a live birth. What I'm trying to deliver here is that 12 micrograms of follicle delta is not precisely 450 units of FSH. It's not, we are not here to make conversion, but I can tell you it's way less. And with this measured approach, again, we were not sparing medication. We're not giving much more medication than the patient can really absorb, can really use. There is a theory, another profession told me once, a comparison analogy, that if you have in your soil a couple of seeds, 3 seeds, if you water a lot, only 3 plants will grow. It will only make a difference if you have 20 seeds. You have to water more, you have to care more about it. So it's to give the medication she needs, not less, not much, not more. Well, talking about low responders again, let's call Pilar, 42 years old, starting to be even tougher to stimulate, 63 kilograms. While she comes here with 4.7 picomoles per liter of antimalarian, 4 to 6 follicle in different counts. And again, what should we do? Well, since the beginning, because the patient came to me at the first time, we applied again the algorithm and 12 micrograms of follicle delta. We, in the end of the day, we had only 2 mature oocytes. Well, we didn't expect much more, but well, maybe a little bit better. She got an aneuploid embryo, no embryo transfer, and she was willing to try again. She was not happy with this first outcome and not ready for egg donation, which is really popular here in Spain, but she was not ready. She wanted to try again. And what should we do right now? Give more dose, try to reconsider. And we did what the protocol says. As I was part of the ESTRA trial, I was used to follow the rules, let's say rules. There are no straight rules, of course, but in the trials, we could increase the dose by 50% if in the first outcome was not what you expected by having a low response. And that's what we did. And we have a little bit more, a little bit better response. Of course, this patient will never shift from 3 oocytes to 13. No, because it's a limit in their ovaries. But we have from 3 to 5 oocytes, and we could make the biopsy of 2 embryos and 1 more, and one of them was fortunately euploid, and the patient got pregnant. And we could modify a little bit more this response. It was really necessary to increase the dose. We will never know. Maybe, like the high responder previously, the same approach will deliver a better response. But in these low responders, we can modify the dose. We can increase the dose when we don't see a good response since the beginning. And to finalize, pretty much the same case, very similar. Lourdes, 41 years old, 80 kilograms, heavier than the majority of the previous patients. And let's go quickly through that one. 5.1 picomoles per liter and stimulated with 12 micrograms. Again, the highest dose that the algorithm delivered to you at the first time. And we didn't even finish the cycle because nothing was growing. Nothing was growing. And we decided to do the cycle again. And this particular patient had, from previous cycle, more medication. And we combined HMG that the patient already had in her possession with the follicle delta. Instead of increasing the dose of the follicle delta, we add the medication because, well, it's, I work in a private clinic, the patient needs to purchase the medication with their own out-of-the-pocket money. And we took advantage of this patient that had already some HMG. And we combined these two medications to have more powerful stimulation, and it was successful in the end. We mean successful, we get more than zero response or monofollicular response. We had 5 oocytes, 4 of them mature, and again, a couple of embryos could have been studied with PGTA. 1 was good enough to be an ongoing pregnancy. So it's similar case than the previous one, and we could just increase the dose or increase the power of the stimulation, in this case, with a mixed protocol. And what I'm trying to, some people might ask if, what if since the beginning we could know in advance that that patient might need more medication and convert the second IVF as her first. It is something that we are asking a lot, people who have great experience with Phototropin Delta, especially the group from Erasmus Rotterdam. Pauline is studying precisely now how to try to increase the dose for low responders since the beginning. We are working on this to try to avoid these failed cycles, to do a second one, increasing the dose. And maybe in the future, we can calculate a higher dose to start from the first cycle. But those are real cases. I'm not telling what might happen in the future. I'm telling what happened already with my patients. And just to finish, I would like to talk to you the strength or the advantages of this molecule, that approach. It's not only the molecule alone, it's the FSH plus the strategy of using with the algorithm in my patients, what we have seen here in our group. Well, for the first IVF, for naive patients, it's important because we don't have a comparison with previous cycles, and we can use the algorithm to help us find the best dose since the beginning without previous comparisons, and we can target the oocyte yield, not very low, not very high, and we can unify criteria. If you work in a very big clinic with lots of colleagues, we can try to unify the way we do IVF. Of course, we have protocols, we share the same vision, the same way to form IVF, but sometimes it's not the same. And for, say, under parentheses, naive IVF specialists, if I was starting to do IVF right now, I would be very happy to have this algorithm to help me decide the best dose for my patient. And I'm teaching my fellows to use that approach when you're not sure the way you're going to use, and you can be guided by something much more powerful than my opinion. For high responders, it's definitely, I would say, the best profile to use this algorithm, to use this approach. For the high responders, we have been seeing through the publications that was shown in the beginning, it does reduce the risk of OHSS, of preventive measures to develop OHSS, of high response itself. It can avoid freezing now to have to transfer later and allow us to do a fresh embryo transfer. Why is it so important to do a fresh embryo transfer? It depends. In my clinic, we do a lot of frozen embryo transfers, and the vitrification programs works very well, but maybe it's not the same for everybody else in the world. And eventually, to reduce the excess of surplus embryos frozen. It might not be an issue in some cultures, in some countries, but it can be an issue for others. To have 10 embryos, probably this family will be built without using the 10 embryos, and some embryos will be there forever. And what do we do? Depending on the country, law, and environment, it could be donated to other couples or not, or donated to science, or just eliminated. Well, something to think about, but nobody desires to have excess of embryos created. For poor responders, well, nothing is good for poor responders, but what I'm trying to say is here in the graphic, there is a theory telling us that mild stimulation is good for low responders because they will respond low anyway. And some people say that we should maximize the dose to give, to push harder, so we have the best that they can have. And maybe this algorithm or this approach will deliver the amount that she needs, not too less, not too high. That is the argument behind using the algorithm for low responders. And some things that I found in my use, or when I was talking in different countries, especially big countries, not precisely in the case of Spain, but for distant patients that they need to come to your clinic to do the IVF, and they don't live nearby, to use a protocol where we select the dose in the beginning and we don't change the dose through all cycle, which is the case of the Folitropin Delta fixed dose algorithm, make things easier to require less ultrasound monitoring. So why do we make this monitoring? To make sure everything is going well, to sometimes, depending on your practice, to introduce antagonist, and to confirm that I will maintain the dose or increase or decrease. If I trust that the dose will never be touched, I need to see less that patient. For obesity, well, actually, nothing is great for obesity, but the algorithm to choose the dose was actually the first thing that we looked at the patient's weight. Once I was giving a lecture, I believe in Australia, and I was asking people in a polling question, how many of you weight your patients always before an IVF? And most of the people said yes. And now, how many of you use that parameter to modify your dose selection? And the majority said, well, actually, I don't remember. I weigh the patient because she comes in and we weigh the patient always, but I don't always look at the weight to decide the dose I will give. And some look at the body weight, some look at the body mass index, which is not the case here. Body weight is much more linked. Anyway, it's just the way sorry, I'm really sorry, it's just something that happened in the screen. Is it, okay, is it working again? Right. Well, and just to finish obesity, we have to avoid, of course, health risks for the patient. We cannot just start simulating a patient with obesity without telling her the risks of undergoing a pregnancy and a virus simulation with obesity. Patient for the subsequent cycle, we can take advantage of the previous cycle and try to get back to the target, avoiding especially high response. And just the final highlights that we're using human recombinant FSH, we're talking about quality. We're personalizing, as we have been seeing in the previous presentations, we can target and predict the response of our patients, and everything else we have been seeing with those algorithms to reduce OHSS, maximize fresh embryo transfer opportunities. We don't need to adjust the dose, so we can even see less the patient, not because we care less about her, but because we don't need to monitorize so much. Thank you very much. That was my experience with this Folitropin Delta, and I'll be glad to hear any questions that you might ask.
Thank you very much. Very, very interesting and very, very practical presentation. We have a lot of answers to our questions. You anticipate a lot of our questions and answer to them. But we have quite a lot of questions from our auditory. And maybe I will start as moderator with my own question. Most of doctors, when we are talking about Recovel, ask, why microgram and not international unity? Would you answer, please? Or maybe
Yes.
Professor Griesinger will be able to answer.
Well, if you allow this, George Griesinger speaking, and giving the answer. So You must be aware that folitropin delta is a human type FSH molecule. So all the other FSH preparations on the market come from a Chinese hamster ovary cell and not from a human cell. And folitropin delta is the only one which is available on the market, which comes from a human cell. And that has implications for the pharmacokinetics and pharmacodynamics, because a human cell can modify the glycosylation of the molecule to a much greater extent than what we know from the Chinese hamster ovary cells. So we've seen this in folitropin delta. I've been one of the investigators for a phase 2 trial on another human FSH molecule, which is not available on the market for ovarian stimulation. But what we've seen in both instances is that since that molecule comes from a human cell and an animal cell, the PK/PD is dramatically different. It's also that it appears to be way more potent, so to speak, when you use the conventional bioassay to determine its potency, which is you inject intraperitoneally into rats the compound, and this is how the IU standard has been developed. So since we see that no longer this conventional Steelman polyassay, as it's called, can be used, we must leave the IU reference system, and we must, in today's modern medicine, now allude to the actual weight of the compound to express precisely its biological activity. And this is why we see for folitropin delta a microgram and not an IU coding.
Thank you very much. I have read one of explanation about that. This international unity was created in mid-50 and was measured by measuring the appearance of estrus in rates, in laboratory animals, with using one specific dosage. But with this, folitropin delta was not the direct correlation between the units, biological activity, and micrograms of folitropin. So maybe this is one of explanation that there is no linear relationship.
Yeah, well, it's even going beyond that. So when you look at the original Steelman polyassay, what was done was rats were injected, or still are, intraperitoneally, and then you measure the weight of the ovaries, how much that increases with a given dose. And this is how you set your international unit standards on the bioactivity of the Chinese hamster ovary-derived or urine-derived FSH preparations. But now, since we have an FSH molecule, which comes from a human cell, it does not act in the same way in a rat as it does in a human. And so we have measured this quite precisely in the context of another compound, and it's approximately a 1:2 ratio. So if you use the microgram human FSH, as you have determined it should be active by IU, you have double the effect, or you would need half the dose for the same effect. So, and that tells you that, well, these molecules act differently in a rat than in a human. And in a human, they would be much stronger in effect if it was dosed as what we know from the effect from the rat in terms of IU.
Okay, thank you very much. And we have the question about also activity of Recovel. This is maybe the question to Professor Griesinger and Professor Lamarca. In instruction to Recovel is mentioned that the therapeutic effect is more high in comparing with folitropin alpha. You have mentioned that it is twice. Is it always twice, or it is, how to say, different numbers, maybe.
Yes. So folitropin delta is being compared to folitropin alpha in vitro studies and in vivo studies. And it seems that folitropin delta may act differently from folitropin alpha, also when looking at granulosa cell in vitro model. It seems that the activation of aromatase, estradiol production, has a different curve when compared to folitropin alpha. But this is not unexpected, I think, since folitropin delta having different glycosylation sites may probably have a different interaction with the FSH receptor. When moving to in vivo model, which means patients, folitropin delta has always been compared to 150 units of folitropin alpha. And now there are new studies already published in which, in some way, authors tried to understand what could be the conversion factor when talking about units or micrograms. And it seems that 10 micrograms of folitropin delta are acting as 150 units of folitropin alpha. But this is an upcoming story and still many things to do.
Thank you very much. We have one more question to Professor Lamarco. Why in Esther study, in one group of patients was fixed dose of folitropin alpha and another group of patients used personalized dose of folitropin delta?
Yes, the objective of the trial was to investigate whether a formula can elaborate, can calculate the right dose of FSH. And by definition, the right dose of FSH is a dose of FSH which does not need any change during ovarian stimulation. On the contrary, the common practice was to give a fixed dose of FSH, we may say 150 units, and then you, clinicians, adjust the dose according to ovarian stimulation. So a new strategy was compared to the common clinical practice.
Thank you very much. One more question, maybe to Dr. Fabio Cruz. What to do if on Recovel stimulation on 5-6 day we can see too much follicles? Because you have shown in your clinical cases that sometimes you have an expected low response, but maybe sometime you have seen unexpected high response. Even with standardization, with calculation of optimal dosing, etc.
Great question. I don't remember having a response way higher than expected. I would say, and it's just the user view, not the view of the algorithm itself, is that the algorithm might be conservative. So when it runs out of the target, it goes a little bit less and less times we have high response in X-ray response. What we do when we have in our clinical practice a response higher than usual, nowadays in a lot of studies are telling us that costing and lowering the dose is not the key. The key is looking after avoiding the hyperstimulation itself and triggering, of course, with GnRH and trying to avoid problems for the patient in the end. I never changed myself the dose of the initially selected by the algorithm, but everybody's free to make the modifications in their own simulation, but usually it's not required.
Thank you very much. Thank you. We have one more question about immunogenicity, about immune influence. It seems to me that in study Esther-2, there was information about that, but maybe you can answer this question. Is there some influence to immune system with folitropin delta?
Well, the Esther trial they made in the Esther-1 and the Esther-2. With the Esther-2 was the patients that didn't get pregnant with the first trial and did another simulation with the same protocol, with the same folitropin. And there is an immunological study comparing if there is immunogenicity higher or less comparing to the folitropin alpha, and it was the same. It was not higher. I don't have slides right here right now to show, but it's under the results. And there's a publication from the data from the Esther trial from Dr. Bosch that shows the immunogenicity from folitropin delta, which is not superior than the previous one.
Дякую. І ми маємо
Thank you, and we have another question.
Do you have, maybe somebody have experience to use folitropin delta in long agonist protocols? Or you don't use at all long agonist protocol now?
No, I have never used. I have just personally, actually, this folitropin was built to be used at the antagonist protocol. I was maybe I'm played by the book too much because I was part of the studies, and I don't disrespect the way it was built for to use, not using myself the dose, not selecting myself the dose, but respecting the algorithm and to use inside of antagonist protocols.
Well,
Professor,
can I add something, please?
Of course.
Yeah. So, folitropin delta is a gonadotrophin. So you can use this molecule to stimulate ovary. What Ferring proposed and what Ferring tested is the use according to the general HIV antagonist protocol with a formula. But now the molecule is in our hand, and so we can make experience and new experiences with this molecule. So theoretically, you can use folitropin delta with a long agonist. You can use folitropin delta for intrauterine insemination, so without any GnRH analogs, or you can use folitropin delta with, I don't know, progestin primed ovarian stimulation or what else. The concept here is very clear, at least to me. If you are going to use a dose of 18 or 20 micrograms of folitropin delta, you are applying maximal ovarian stimulation. If you have women with surely poor ovarian reserve, well, you stay always on a safe side when talking about ovarian hyperstimulation syndrome. So you can choose to go for long agonist protocol. You can go for a maximal folitropin delta ovarian stimulation. The basis here is to correctly predict ovarian response. If you know what kind of patient is sitting in front of you, well, you have a very wide spectrum of possibilities. But let's come to the science again. Of course, we need trials, and at least to my knowledge, there are now trials investigating the use of folitropin delta according to a long GnRH agonist protocol.
Thank you. And one more practical question. Maybe you have some experience, somebody have some experience to use folitropin delta in duostim protocol, two stimulation in same cycle.
I did it twice. Actually, it's Antonio said before, it is a folitropin. It's an SFSH we can use in the way we want. As I was programmed to use in the trial. I keep going on in the majority of the cases, but as you have seen, I've used once with mixing with HMG, for example, which was not the way it was initially designed. And I had used twice in those, and if you recall, I had 2 patients with 44 years old, low responders in my initial cases. And yes, I used in the double simulation in dual steam. Actually, one was pretty much the dual steam, the classic dual steam. The other was pretty much more the Shanghai one, but of course, both of them in luteal phase and follicular phase, with the results totally similar to any other follicle.
Yeah.
Thank you. We have one more question. If you have a patient with low ovarian response but good IMH level, in this case, your opinion, maybe Recovel will be better than other gonadotrophin as option for stimulation?
I'm not sure I did understand, but talking about the patient with a good antimalarian, so predicted
IMH normal,
good response.
and response in previous cycle was not good, like low sensitivity to FSH or maybe not good dosage.
Having a response to one simulation doesn't really mean the patient might have a problem or sensitivity. One of the cases was showing a patient with PCOS with a very, very high response, predicted response, and we had a low response with only 3 oocytes. And by using the very same protocol again, it did happen well. So yes, I believe Reproduction delta and the selection dose by the algorithm can fit that patient, can even fit better than our random decision. Yeah, yes, I do. I believe it can be a good way.
Well, personally, every time we have in our clinic a patient with a good ovarian reserve but a poor ovarian response, the first thing we do is to review the cycle, because we want to understand whether everything was okay with ovarian stimulation, monitoring, what was the duration of ovarian stimulation, who was the doctor performing the oocyte retrieval. And according to my own experience, sometimes you find something there. Sometimes you find the reason for this unexpected poor response in not a good clinical practice. I do not think that sometimes the changing drugs or protocols may change the story. Sometimes what the patient needs is a good ovarian stimulation cycle.
Very much. One more question. Question concern on obesity. If there is some precautions with stimulation with folitropin delta in obese women, or only hyperstimulation is the main concern, or maybe there is some specific risk? Please, Professor Griesinger.
Yes. So we have produced a poster at last year's ESHRE conference. So we started early with folitropin delta to integrate that into our practice. And so we've been interested especially in aspects of external validity of ESTA1 trial. And this is what you always have in a phase 3 trial, is cutoffs of your population. So for example, in terms of cycle regularity, I do remember irregular cycles were allowed. But then in the real world, we see massively obese women, we see women with plus minus irregular cycles, we see women who smoke heavily, and we see all combinations of being obese, smoking, having PCOS or not, and all that. So what we did was we were looking specifically in women with irregular cycles, very high AMH, and very high or very low body weight, to see, and then again, these women are typically not the one that we have in a phase 3 trial. And we were interested if, for example, the algorithm predicting a good oocyte numbers would still work in a woman who is very high MH and who is obese. And the short answer to that is yes, it did work. So we do not have an awful lot of patients there. We shared our data with a group in Holland, Joop Laven, and they did specifically PCOS women, irregular cycles, and they said yes. Also there, we do see normal responses. We've been worried, to be frank, that in a woman with very high MH, irregular cycle, and a high body weight, that these women would be underexposed. And they would produce a monofollicular growth, 2 or 3 oocytes, and not the 10, 15 oocytes that we wish to have for a good IVF outcome. But we did not observe that. So we tend to think that the algorithm even works in more extreme cases in terms of regularity, PCOS, and body weight.
And what was the highest body mass index in your study?
I cannot replicate this just like that, but I urge you to look up the poster. Neumann Kai is the first author, posted last year's ESHRE. But believe me, here in Northern Germany, we do have some large women. So you can be sure there have been some women in there. So I'm not that much interested in body mass index, but in body weight as a proxy for distributional volume and diluting down the drug.
Массе тела, absolutely. Thank you very much. And one more question, maybe to Dr. Fabio. Question concerned to combination of folitropin delta and urinary FSH. You have shown that you add 150 units, but maybe necessary to start from less dosage, 75 unit or 50 unit or 100 unit. Which is your experience of combination? And when is necessary to combine?
It was a case, actually, it was represented there. Of course, when we add an HMG or LH or whatever mixed protocols, we usually do these starting with 75 and then giving more. But it depends. In Spain, it's very usual to provide mixed protocols. In the beginning, I was showing a first-year experience. In the first year, I was in a transition between using FSH the way it was built for, but in the second year, and now I'm mixing sometimes with this. What we lose when we mix protocols with HMG, because HMG have FSH power as well, we lose the predictability of the algorithm. So if we have a patient that is potential high responder, we dose by the algorithm and we add anything else, we are risking having a high response. If we're talking about low responders, I see no problem at all by adding more 75 or adding different. But again, we're losing the beauty of the algorithm to select the best dose and trust this dose until the end. But of course, it is an FSH, it is HMG, we can mix them, we can not play with them, not play in a not safe way, but we can make experiments, and it would way better if we do those experiments under a trial and record the results to compare and to really know the other, not just using freely. But the short answer for this question is that it's way more usual to mix with only 75 rather than 150. It was a special case.
Very much, very interesting. And maybe the last question, because our time is a little bit short. Most of practical cases concern on fresh embryo transfer, but actually most of clinics working in segmentation of cycle. in your practical life, what is the proportion of fresh and frozen cycles? Because in our clinic, actually around 80% of cycles are frozen and only 15–20% is fresh. Maybe with Recovel will be different, but now situation is like that. What is your feeling and idea about that?
Similar.
Please, Professor Griesinger.
Sorry, the question was for Professor Griesinger or for me? But we can, well, it's quite similar. 85% of our cycles frozen to be transferred later. But the reason is not the HSS, of course not. We deal much more with low responders than high responders. The reason why we do segmentation is basically PGT. So the results will be the same if we transfer fresh or not of the ovarian stimulation, of the oocyte yield, of what we want, which is the targets in the patient. But when we aim fresh, when we aim to transfer fresh, it is extra special to avoid hyperstimulation and to target better. So it is true. I work with a population way older than average. Probably if you work in the same city where I work, but in the public hospital, which faces the younger patients, and they are always aiming to transfer fresh, it will be highly recommended to use a tool to avoid OHSS. It was mandatory. For me, it helps to target anyway, and it helps a lot to avoid OHSS. But for the vast majority, we don't transfer fresh, but it's not a reason why not using this FSH. It's an FSH anyway, and one of the cases, or maybe two, they were triggered with GnRH, and again, not because they were hyper-responding, but because we didn't use HCG at all when we are not planning to transfer. It's not necessary anyway. So we can use with dual trigger, we can use with different ways the phototropic delta, and transferring or not.
Yeah, Professor Antonio.
George, do you want to add something?
Well, I guess very, very brief. I'm just being the devil's advocate. I wonder how come that some clinics have 70–80% freeze-all in their practices. I want to scrutinize what would be the medical indication for that.
Yeah.
It is my understanding that we need a freeze-all for distinct abnormalities of the endometrium of the uterus, of rare disorders of the patient, like a systemic disease. We may discuss progesterone elevation. Then we have the issue of hyperresponse preventing OHSS. And then the very rare case where we need PGT for monogenic disorder, translocation, and all that. So, but all that should not summarize beyond 30%, which we see in the Brussels data, for example, 30% freeze, or in our center, approximately 25% of patients do not make it to a fresh transfer. Now, we may discuss forever if PGDA is a good thing to do after a STAR trial, after an ESTEEM trial, and all that, or maybe this is something that may harm the patient on top of freezing and doing a frozen thought transfer and all that. And then also convoluting all that with the issue of that we do not know how to best transfer an embryo in a frozen thought cycle and what health implications maybe an artificial cycle may have and all that. I would scrutinize what has been said here if we should go for that. And I would really play that Recovel is helping us, maybe more patients to go what they want. And this is do IVF and get pregnant on that transfer.
Yeah, I completely agree. I mean, let's do not think to PGTA for one moment, okay? So we are talking about IVF. In IVF, in our own clinic, the rate of segmentation, so of freeze-all, is 30–40%. And I'm not happy when this rate is going to increase, because the first objective of our patients is to receive the fresh embryo transfer. If you look at this story, if you look at the IVF cycle from the patient perspective, the patient is happy to receive the oocyte retrieval, and after 5 days, the embryo transfer. Especially now in this period, in the COVID era, where movement within a country, well, is not sometimes is not allowed. Well, you may understand that receiving the fresh embryo transfer is the priority. And when you are talking about fresh embryo transfer, the prevention of hyperresponse is mandatory. So for Linzopin delta and all formulas behind the personalization of the therapy are very welcome. Audio.
No, it's fine. Just for adding, I fully agree. All these speakers. Yes, and just fully agree. And just one bad is because of patient selection. So if I see a population that for an excessive age, or for maybe lots of patients coming from lots of failed cycles in public institutions, when they come here, there are more reasons why we are not asking everybody forever PGT or not. But if we take away PGT once, the numbers will be completely similar to the numbers we are talking about 20–30% of segmentation, and the priority is a fresh transfer. That's why the strategy of the Recovel is a great one for IVF.
Ще раз дякую шановним професорам.
Thanks you, dear professor, once more.
Fantastic question and answer session, fantastic presentation. Hope this corona crisis will finish one day and we will be able to meet by personally and not by this internet facilities. So I hope it will be very soon. Шановні колеги, я хочу...
Dear colleagues, I would like to say thank you to everybody who was present in this session. Regarding viewers, I would like to give greetings and thank you to Ferring Pharmaceuticals for such a wonderful opportunity that we finally have answers to the questions, and finally we will have a new instrument that would allow us to even better, even more individualized and personalized care to have for the patient, and to have a more personalized approach to the stimulation, and to have even better results than we had before and even more safe. I say thank you to all of you, and I greet you. I wish you health and stay safe. Till the next time.
I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be.
Як користуватися попередньо наповненим шприцом Recovel? Вітаємо вас на нашому уроці щодо введення препарату Recovel за допомогою попередньо наповненого шприца Recovel. Recovel – це засіб для лікування безпліддя, який вам призначив ваш лікар. Він, скоріш за все, вже розповів вам про необхідну вам дозу та тривалість лікування. Шприц доступний в 3 різних дозуваннях, і, можливо, лікар призначив вам 1 або кілька таких шприців. Перед початком введення переконайтеся, що ви уважно ознайомилися з інструкцією з використання, яку ви отримали разом із попередньо заповненим шприцом Рековель. Це відео містить інструкції для кожного етапу процесу введення. Відео можна в будь-який момент поставити на паузу. Завжди використовуйте цей препарат у точній відповідності до вказівок вашого лікаря, не змінюючи призначену ним дозу. Якщо у вас виникли сумніви, проконсультуйтеся з вашим лікарем. Якщо у вас виникли питання щодо лікування або власне ліків, зверніться до лікаря, медсестри або спеціалізованої клініки. Перед початком переконайтеся, що у вас є всі необхідні матеріали та чиста поверхня, наприклад, стіл або стільниця. Це складові попередньо наповненого шприца Рековель. За необхідності призупиніть відео. Перед використанням попередньо наповненого шприца Рековель вимийте руки з милом та витріть їх насухо чистим рушником. Зніміть кришку шприца та впевніться, що препарат у картриджі є прозорим і не містить сторонніх включень. Не використовуйте шприц, якщо препарат не є абсолютно прозорим. Зніміть захисну плівку з нової голки і встановіть голку на тримач картриджа. Зніміть з голки зовнішню і внутрішню кришки і відкладіть зовнішню кришку в сторону. Перед першим використанням попередньо наповненого шприца Рековель обов'язково заповніть його, щоб видалити повітряні бульбашки, які можуть утворюватися всередині картриджа. Це необхідно робити лише перед першим використанням шприца. Для заповнення спершу поверніть регулятор дози за годинниковою стрілкою, поки символ краплі не опиниться навпроти індикатора дози. Потім переверніть шприц голкою вгору і легонько постукайте по картриджу, щоб перемістити бульбашки. Тримаючи шприц голкою вгору, натисніть кнопку введення, поки навпроти індикатора дози не опиниться цифра 0. На кінчику голки повинна з'явитися крапелька рідини. Це означає, що ваш шприц Рековель готовий до використання. Якщо крапля не з'явилася, повторіть процедуру заповнення до 5 разів. Якщо рідина так і не з'явилася, встановіть нову голку і повторіть заповнення. Ваш лікар або медсестра підкажуть вам індивідуальну добову дозу Рековель. Переконайтеся, що у віконці дози видно 0, а потім поверніть регулятор дози за годинниковою стрілкою, доки встановлена лікарем доза не опиниться навпроти індикатора дози. Кожна цифра дорівнює 1 мікрограму, а кожна риска між двома цифрами – 0,33 мікрограма. Дозу можна збільшити або зменшити без втрати препарату, повертаючи регулятор дози в будь-якому напрямку. Тепер ви готові до ін'єкції. Рековель призначений для введення безпосередньо в шкіру, підшкірно, у ділянці внизу живота. Важливо щодня змінювати точне місце введення, щоб зменшити ризик виникнення шкірних реакцій, наприклад, почервоніння або подразнення. Очистіть місце ін'єкції, протерши невелику ділянку живота спиртовою серветкою, і дайте ділянці висохнути. Не торкайтеся цієї ділянки до ін'єкції. Для введення акуратно прищипніть шкіру навколо продезінфікованої ділянки великим і вказівним пальцем і вставте голку прямо в прищеплену складку шкіри. Тепер покладіть великий палець на кнопку для ін'єкції. Натисніть її до кінця і утримуйте. Коли у віконці навпроти індикатора дози з'явиться 0, зачекайте 5 секунд і повільно витягніть голку зі шкіри. Ваша щоденна ін'єкція Рековель завершена. Якщо на місці уколу з'явилася кров, злегка притисніть до нього ватний тампон. Після ін'єкції обережно закрийте голку зовнішньою захисною кришкою і відкрутіть голку проти годинникової стрілки. Утилізуйте голку відповідно до вказівок, наданих вашим лікарем, або згідно з описом в інструкції щодо використання. Не забувайте, що голку не можна викидати з побутовими відходами. Закрийте шприц кришкою шприца. Не зберігайте шприц із встановленою голкою. Після першого використання попередньо наповнений шприц Рековель слід зберігати за кімнатної температури, що не перевищує 25 градусів за Цельсієм, максимум протягом 28 днів. Перед першим використанням шприц слід зберігати в холодильнику за температури 2-8 градусів за Цельсієм. Для отримання додаткової інформації щодо зберігання ознайомтеся з інструкцією з використання. Утилізуйте використані шприци у відповідності з місцевими правилами управління відходами. Ваш лікар або медсестра розкажуть вам про способи утилізації використаних шприців. Зауважте, що в шприці може залишитися певна кількість рідини, і це нормально. Щоб ввести призначену вам добову дозу Рековель, вам може знадобитися більше одного шприца. Якщо ви не можете встановити на шприці повну дозу, це означає, що в шприці недостатньо препарату. У цьому випадку вам знадобиться ввести дробну дозу, тобто частину за допомогою шприца, який ви використовуєте зараз, а решту використовуючи новий шприц. Наприклад, якщо призначена добова доза Рековель становить 8,66 мікрограма, а у вас виходить встановити тільки 2,66 мікрограма, вам доведеться ввести іншу дозу за допомогою іншого шприца. Перед введенням запишіть дозу, на якій зупинився старий шприц. Потім введіть 2,66 мікрограма. Обчислити дозу, що залишилася, легко, віднявши дозу, яку ви вже ввели від загальної добової дози. Потім візьміть новий шприц, вставте голку і заповніть шприц, як вам пояснили раніше. Потім ви встановіть дозу 6 мікрограмів та введіть решту дози препарату. Не забудьте змінити місце ін'єкції перед кожним введенням препарату. Якщо вам потрібні додаткові приклади розрахунків дробної дози, ознайомтеся з інструкцією з використання. Ось і все. Тепер ви готові розпочати лікування. Збережіть це відео, щоб за необхідності переглянути його ще раз під час лікування. Обов'язково збережіть інструкцію з використання. І якщо у вас виникнуть додаткові запитання, пов'язані зі шприцом Рековель або способом введення препарату, зверніться до свого лікаря чи медсестри.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it? I start early and stay late. Squeeze the most out of every day. There's no one quite like me. I do things my own way. Watch me work it. I will never be predictable. But my fertility treatment should be.
Як користуватися попередньо наповненим шприцом Рековель? Вітаємо вас на нашому уроці щодо введення препарату Рековель за допомогою попередньо наповненого шприца Рековель. Рековель – це засіб для лікування безпліддя, який вам призначив ваш лікар. Він, скоріш за все, вже розповів вам про необхідну вам дозу та тривалість лікування. Шприц доступний в 3 різних дозуваннях, і, можливо, лікар призначив вам 1 або кілька таких шприців. Перед початком введення переконайтеся, що ви уважно ознайомилися з інструкцією з використання, яку ви отримали разом із попередньо заповненим шприцом Рековель. Це відео містить інструкції для кожного етапу процесу введення. Відео можна в будь-який момент поставити на паузу. Завжди використовуйте цей препарат у точній відповідності до вказівок вашого лікаря, не змінюючи призначену ним дозу. Якщо у вас виникли сумніви, проконсультуйтеся з вашим лікарем. Якщо у вас виникли питання щодо лікування або власне ліків, зверніться до лікаря, медсестри або спеціалізованої клініки. Перед початком переконайтеся, що у вас є всі необхідні матеріали та чиста поверхня, наприклад, стіл або стільниця. Це складові попередньо наповненого шприца Рековель. За необхідності призупиніть відео. Перед використанням попередньо наповненого шприца Рековель вимийте руки з милом та витріть їх насухо чистим рушником. Зніміть кришку шприца та впевніться, що препарат у картриджі є прозорим і не містить сторонніх включень. Не використовуйте шприц, якщо препарат не є абсолютно прозорим. Зніміть захисну плівку з нової голки і встановіть голку на тримач картриджа. Зніміть з голки зовнішню і внутрішню кришки і відкладіть зовнішню кришку в сторону. Перед першим використанням попередньо наповненого шприца Рековель обов'язково заповніть його, щоб видалити повітряні бульбашки, які можуть утворюватися всередині картриджа. Це необхідно робити лише перед першим використанням шприца. Для заповнення спершу поверніть регулятор дози за годинниковою стрілкою, поки символ краплі не опиниться навпроти індикатора дози. Потім переверніть шприц голкою вгору і легонько постукайте по картриджу, щоб перемістити бульбашки. Тримаючи шприц голкою вгору, натисніть кнопку введення, поки навпроти індикатора дози не опиниться цифра 0. На кінчику голки повинна з'явитися крапелька рідини. Це означає, що ваш шприц Рековель готовий до використання. Якщо крапля не з'явилася, повторіть процедуру заповнення до 5 разів. Якщо рідина так і не з'явилася, встановіть нову голку і повторіть заповнення. Ваш лікар або медсестра підкажуть вам індивідуальну добову дозу Рековель. Переконайтеся, що у віконці дози видно 0, а потім поверніть регулятор дози за годинниковою стрілкою, доки встановлена лікарем доза не опиниться навпроти індикатора дози. Кожна цифра дорівнює 1 мікрограму, а кожна риска між двома цифрами – 0,33 мікрограма. Дозу можна збільшити або зменшити без втрати препарату, повертаючи регулятор дози в будь-якому напрямку. Тепер ви готові до ін'єкції. Рековель призначений для введення безпосередньо в шкіру, підшкірно, у ділянці внизу живота. Важливо щодня змінювати точне місце введення, щоб зменшити ризик виникнення шкірних реакцій, наприклад, почервоніння або подразнення. Очистіть місце ін'єкції, протерши невелику ділянку живота спиртовою серветкою, і дайте ділянці висохнути. Не торкайтеся цієї ділянки до ін'єкції. Для введення акуратно прищипніть шкіру навколо продезінфікованої ділянки великим і вказівним пальцем і вставте голку прямо в прищеплену складку шкіри. Тепер покладіть великий палець на кнопку для ін'єкції. Натисніть її до кінця і утримуйте. Коли у віконці навпроти індикатора дози з'явиться 0, зачекайте 5 секунд і повільно витягніть голку зі шкіри. Ваша щоденна ін'єкція Рековель завершена. Якщо на місці уколу з'явилася кров, злегка притисніть до нього ватний тампон. Після ін'єкції обережно закрийте голку зовнішньою захисною кришкою і відкрутіть голку проти годинникової стрілки. Утилізуйте голку відповідно до вказівок, наданих вашим лікарем, або згідно з описом в інструкції щодо використання. Не забувайте, що голку не можна викидати з побутовими відходами. Закрийте шприц кришкою шприца. Не зберігайте шприц із встановленою голкою. Після першого використання попередньо наповнений шприц Рековель слід зберігати за кімнатної температури, що не перевищує 25 градусів за Цельсієм, максимум протягом 28 днів. Перед першим використанням шприц слід зберігати в холодильнику за температури 2-8 градусів за Цельсієм. Для отримання додаткової інформації щодо зберігання ознайомтеся з інструкцією з використання. Утилізуйте використані шприци у відповідності з місцевими правилами управління відходами. Ваш лікар або медсестра розкажуть вам про способи утилізації використаних шприців. Зауважте, що в шприці може залишитися певна кількість рідини, і це нормально. Щоб ввести призначену вам добову дозу Рековель, вам може знадобитися більше одного шприца. Якщо ви не можете встановити на шприці повну дозу, це означає, що в шприці недостатньо препарату. У цьому випадку вам знадобиться ввести дробну дозу, тобто частину за допомогою шприца, який ви використовуєте зараз, а решту використовуючи новий шприц. Наприклад, якщо призначена добова доза Рековель становить 8,66 мікрограма, а у вас виходить встановити тільки 2,66 мікрограма, вам доведеться ввести іншу дозу за допомогою іншого шприца. Перед введенням запишіть дозу, на якій зупинився старий шприц. Потім введіть 2,66 мікрограма. Обчислити дозу, що залишилася, легко, віднявши дозу, яку ви вже ввели від загальної добової дози. Потім візьміть новий шприц, вставте голку і заповніть шприц, як вам пояснили раніше. Потім ви встановіть дозу 6 мікрограмів та введіть решту дози препарату. Не забудьте змінити місце ін'єкції перед кожним введенням препарату. Якщо вам потрібні додаткові приклади розрахунків дробної дози, ознайомтеся з інструкцією з використання. Ось і все. Тепер ви готові розпочати лікування. Збережіть це відео, щоб за необхідності переглянути його ще раз під час лікування. Обов'язково збережіть інструкцію з використання. І якщо у вас виникнуть додаткові запитання, пов'язані зі шприцом Рековель або способом введення препарату, зверніться до свого лікаря чи медсестри.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it? This is is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it? This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it? This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it? This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it? This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference, create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it? This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it? This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?
Доброго дня, дорогі колеги.
Hello, dear colleagues. It's a pleasure for us to start the next session of the Ukrainian Reproductive Medicine Congress, the 25th Congress. And this session is supported by Merck, the recognized leader in reproductology for over 350 years old. And we will talk about the controlled ovarian stimulation.
Дорогі колеги,
Dear colleagues, I would like to give the floor now to Carlo Alvigi, who will talk about the law of the negotiation, the law responder, risk stratification and perspective. He is a well-known expert in reproductology. So, Professor Carlo Alvigi is from Naples. Welcome, and we will be happy to hear from you the latest advances in reproductive medicine.
Very much for your introduction. I think that now we can start with the talk, and I do hope that you can hear me well. And my greetings from the south of Italy in the moment. And so I'm so happy to have the possibility to attend this. If at the moment we can really talk about personalization of treatments, how can we match patients and protocols for having a cost-effective approach to controlled ovarian stimulation. In this area, I will spend some words about the possible role of pharmacogenomics for even more personalizing treatment nowadays and in the next future better. And I will spend some words about the role of LH in controlled ovarian stimulation, which is a crucial part in my idea in personalizing treatment, because we need to understand which subgroup of patients can benefit from this approach. So let's go very fast on the first point. You know the relevance that anti-Mullerian hormone had in the last years in our clinical practice. So what is important to know about anti-Mullerian hormone is that it is produced by primary up to dominant follicles. Only really dominant follicles overcoming 10-15 millimeters do not produce anti-Mullerian hormone. But the vast majority of growing follicles produce anti-Mullerian hormone. This is very important because this is representative of the follicular reserve in an independent way of the pituitary axis. So you can dose this hormone in any single stage of ovulatory cycles, independently of the presence of a dominant follicle. This is very important in the clinical practice. And let me give you an example I really like to propose. If we think about anti-Mullerian hormone, we have to think about a sort of bank account. It gives this kind of information. For example, how much money we have in the bank and how much time we have to spend this money. So this is important for counseling purposes because we need to talk with the patients, we need to talk with the couples in the perspective of counseling, and understanding something about the ovarian reserve is very important. But please let me tell you something that is crucial for me. This is a quantitative information, how much and how much time, but it doesn't give information about quality, because the quality of the oocytes and the quality of embryos and blastocysts depends basically on the age of the patient. The thing that we can explore better is the rate of aneuploidies. The rate of aneuploidies is related to age. It changes year by year, and it is only in a very weak way related to ovarian reserve. The ovarian reserve is basically independent of the whole. Two different concepts. So what can we say with anti-Mullerian hormone? It is very effective in predicting the number of eggs. This is something that I would like to show you. So if we have a couple and we have to do a good counseling, knowing approximatively or in a very predictive way how many eggs we expect from that patient is crucial in the clinical practice. And I will explain later the reason why. So let's move on the other side. The other side is a functional biomarker which is represented by antral follicle count. The antral follicle count is related to the possibility of counting follicles in the first 5 days of the menstrual cycles. And we basically count the follicles between 2 and 9 millimeters. Why should we consider this kind of functional biomarker? Because all the follicle population are in equilibrium each other. So the more you have to imagine as a pyramid structure, so the more is the number of primordial follicles, the more is the number in proportion of primary follicles, the more is the number of secondary preantral follicles. So if we have 10, for instance, antral follicles at the beginning of the cycle, it means that in proportion, all the sections of the follicular reserve are in equilibrium. So good antral follicle count means good ovarian reserve. So what is the difference between anti-Mullerian hormone and antral follicle count. They are both very effective in predicting and counseling, but at least in my opinion, because this is consistent with my clinical practice, coming back to the example I gave before, if anti-Mullerian hormone is representative of the bank account, the antifollicular count is also representative of this, but it also tells how much money we can spend on that amount, which in the clinical practice is even a more consistent and practical information. So if I have 10 antral follicles, I know that if the sensitivity of the ovary is good, I will probably have 8, 9 follicles at the maturation stage, and probably 7, 8, and even oocytes. So I think that if we have to take a decision in a specific moment, the antral follicular count in the clinical practice can be even more practical than anti-Mullerian hormone, which is probably better for counseling purpose. What is the problem of antral follicular count? The problem is that there is a huge variability in the studies, there is a huge variability among centers, because the system of measuring can be a little bit different. So information about anti-Mullerian hormone seems to be more consistent among centers. Antral follicular count has a larger variability. But this is not a problem, because what is important is not literature. It is good for trials, for studying, but what is important is that in your own center, you have a good interreliability among operators. So if you have internal tubes and you are confident with your system, you can create internally a very good system of antral follicular count. Obviously, the same is for anti-Mullerian hormone. So I cannot say at the moment that one is better or the other. I can say that the best method is the one you are more confident with. The only thing I think is that it is not so useful, in my opinion, and it is not cost effective to do both. Because you spend money, patients spend money, the hospital probably on large numbers spend money for have an information that you can probably have from even only one of the two. So what I think in the next future will be very, very crucial is that we have to move from subjective to objective. That's the reason why in the last years, to cope with the problem of interoperators variability, the automized 3D acquisition models and systems are growing. So I do encourage in the clinical practice and even in research, I do encourage to develop in the next future this kind of approach for antral follicle count. But the question is, how can we spend this in the clinical practice? So let's move to the idea of counseling. In terms of counseling, this meta-analysis that has been replicated in the last, this information has been proven even more recently, we can say that anti-Mullerian hormone and antral follicular count are equivalent in predicting poor ovarian response. So if our aim is to tell the couple that the number of eggs will be below 5, that the patient will be a poor responder, the antral follicular count and anti-Mullerian hormone are equivalent. And they are also equivalent in predicting exceeding ovarian response, meaning the risk in predicting the risk of ovarian hyperstimulation syndrome. But what happened in the last years, and I think that is a crucial information, is that we moved from the idea that anti-Mullerian hormone and antral follicular count are only good for counseling to the idea that they can be helpful for choosing protocol in a decision-making way. So the same hormones, the same functional information from AFC can be used for matching patients and protocol. And so in the last years, the literature stratified patients in 3 categories. The first is patient with a very high anti-Mullerian hormone or high antral follicle count, In these cases, we can use this kind of indicators for designing stimulation, where the key word in this case is safety. When we have this kind of values, we have to consider safety, meaning prevention of ovarian hyperstimulation syndrome, as main goal. If we have a very low ovarian reserve with less than 5 antral follicles, or below 1.2 in terms of MH, in this case, the keyword, the philosophy is cost effective, because we cannot create new follicles. The only things that we can do is to stimulate the patients in a very cost effective way, also managing risk of cancellation, frustration, stimulation burdens, psychological stress, and unuseful costs. And what is the key word in case of patient with a good ovarian reserve? Optimizing. And in my opinion, optimizing means to have the ideal number of eggs for that patient, for any given patient. And the ideal number is the number that we need for having at least one euploid blastocyst. So please calculate the expected rate of aneuploidies for any given age, calculate the rate of blastulation for any given age, and you can have an idea of the number of eggs you need. You can personalize in the stimulation for this kind of aim. So just a few words on patient with a very high AMH or antral follicle count. In these patients, the question is, can we personalize the treatment? And this is something that has been in the past object of a study, that is the Optimist trial. Trial is the first trial that tried to personalize the starting dose of FSH gonotrophins in general according to the ovarian reserve. So two parallel studies were performed in a patient with poor ovarian reserve, low ovarian reserve, a patient with high ovarian reserve. Now we are talking of patient with high anti-Mullerian hormone, in this case high antral follicle count, and patients were randomized to receive two standard starting dose, 100 and 150. So let's have a look to the results. So you can see that patients with high ovarian reserve treated with 100 as a starting dose had a lower incidence of OHSS. But please note something, that if we have a look to the poor response, it was significantly higher in this group, and even the cases of insufficient growth were significantly higher. So I appreciate in this study this concept that we can personalize the starting dose according to the anti-Mullerian hormone, but in my opinion, the limit of the study is that this dose is too low, because you run the risk of having iatrogenic poor ovarian response or iatrogenic insufficient response. So probably the compromising is in the middle, even 12, 25 international unit more can probably prevent. But anyway, I have to recognize that at least for hyper responders, this kind of approach with markers of ovarian reserve for deciding the starting dose makes sense. What about for responders? The other part of the Optimist trials was dedicated to patients that had very low antral follicle count, and patients were divided in patients with follicles between 0 and 7 and follicles between 8 and 10. So let's focus on this group. Please note that patients were randomized to receive two starting doses, 150 and 450. So very high, and probably for this patient, too low dose. But let's have a look to the result in this case. You can see that no difference in terms of pregnancy, and here strange definition of a cumulative life birth rate was proposed, which is not the one proposed by the Escher. Is a cumulative life birth rate considering 3-4 fresh cycles transfers, with another concept. But anyway, authors did not find any difference. But if you have a look to the results, again, the insufficient growth was very high in patients received 150. What does it mean? It means that, at least in my opinion, this study is not able, in my opinion, to give the conclusion it gives, that a personalized approach is not of benefit. Because I think that many weak points are in the study. The first, in my opinion, is that the dose of 150 is too high. The Escher in recent guidelines declared that it makes no sense giving more than 300. So probably 450 is probably even bad and can, in my opinion, make the prognosis worsen, because probably it also even inhibits the growth of follicles, in my experience, and probably it could have affected the cost analysis, because you cannot say that it's not cost effective when you give a too high dose in one of the two groups. And another point is that the cancellation rate in the standard group is higher versus individualized, and this is under-evaluated. So a lot of problems in terms of heterogeneity in protocols and regimen was also present in the trial, and no separate data for patients having 2 follicles at the annual follicle count or 8-10 follicles were specified. So I think that I proposed this study to tell you that, in my opinion, this study is not sufficient to conclude that it makes not sense personalizing the starting dose according to the antral follicle count. But I would like to spend the last minutes in my talk in discussing something related to good prognosis. This is a very important point, because I think that in this patient we have to think about the possibility of personalizing treatment in the future, even by pharmacogenomic approach. And this is the concept of, that in my opinion is very important, of ovarian sensitivity to FSH. Let me give you an example that sometimes is even more relevant than explanation. Here we have 2 patients, same age, same hormonal profile, BMI is also similar. The antral follicle count is different. The starting dose in these 2 patients was probably the same, but you can see here that the first patient had only 30% of antral follicles growing and reaching maturity. So the final number of measured follicles and probably oocyte is 5, 6. The other patients had 80% of follicles growing. So again, the final number of measured follicles is 5, 6. So in terms of prognosis, they are probably the same. They are suboptimal responders, because in both cases they had between 4 and 9 follicles, measured follicles, and probably oocyte. But in my opinion, these 2 patients had a different profile of response, because this response was normal, because this patient used 80% of her follicles. In this case, the ovarian response, in my opinion, is hypo, meaning hyposensitivity to standard doses of immunotherapies. So probably increasing the FSH dose in this patient in the next cycle or adding LH makes sense, because only 30% of her potential has been used in the first stimulation. No sense in this patient increasing the dose in the second cycle, because she had her potential totally utilized. So probably the best thing to do in this patient, if required, is accumulating eggs in 2 consecutive cycles or in the same cycle as do a stim. So same number of eggs, but 2 different approaches for modifying prognosis. And so can we understand before, can we have information about the sensitivity of the ovary of this patient? And we recently performed a meta-analysis to try to understand if some characteristic of the patient can predict the sensitivity. And what we discovered in this meta-analysis, what we proposed, is that patients that have a very common polymorphism in the FSH receptor that is characterized by presence of serine instead of asparagine in position 680, carriers of this very common polymorphism requires higher doses of gonotrophins for having the same number of oocytes, or with similar doses, they have a lower number of oocytes. In the wild-type patients, the number of eggs is higher. In carriers of the polymorphism, the number of eggs is lower. And the two kind of patients have the same antifollicular count in the ovarian reserve. So we have genetic markers that can lead us to understand this. If the patient will have this kind of profile or this kind of profile. So if the patient is carrier of the polymorphism, probably we need 75 international unit more. That has been recently proven by a very nice trial by Renato Fantini that demonstrated that giving 300 international units of FSH or 225 in all patients, we overcome this polymorphism, and probably we will not have the situation of hyposensitivity. The only problem is that if we give too much FSH in patients that are wild type, we run the risk of moving too much progesterone, because it is crucial to understand that the progesterone rise is not related to LH or ACG. Progesterone rise is an FSH-dependent phenomenon. If we give too much FSH, we lead the system to produce too much progesterone during controlled ovarian stimulation. So in my opinion, probably 225 is a very good starting dose for all patients, because we optimize the number of eggs, or just because we push and we overcome the eventual presence of inhibitory polymorphism in the receptor. But if we give too much FSH, patient wild type, if the ovarian reserve is very good or the system responds too much, we run the risk of moving too much progesterone. So probably pharmacogenomics will help us in the future in deciding when we can have the maximum response with the lower dose and when we have to avoid to give too much in patients that have susceptibility for progesterone rise. And I spent the last 2 minutes of my talk for giving you some information about the LH. Up to now, the use of LH, recombinant LH in particular, has been studied in general population or in poor responders according to Bologna criteria. What we did in last years, we tried to understand if some subgroups of patients can benefit from LH, patients that are different from classical responders. They are low prognosis patients for different reasons. For instance, according to Poseidon classification for low prognosis patients, group 1 and group 2 are patients with hyperresponse, meaning hyposensitivity to FSH, the kind of a patient I presented in the example, only having 30% of follicles growing. And there are patients, for instance, in group 4, meaning above 35 years, but not responders above 40, 41. Patients between 35 and 39 with still a good ovarian response that can be probably a target for this kind of therapy. We tried to stratify papers according to Poseidon subgroups. This is what we realized. And so what I can give you as information is that if you analyze studies giving recombinant LH in patients classified as hyperresponders, meaning that had suboptimal ovarian response despite a good ovarian reserve in the previous cycle, you can see that the implantation and the ongoing pregnancy rate are improved by recombinant LH. And also, if we analyze not poor responders, but patients between 35 and 39 years of age with acceptable ovarian reserve, even in this patient, the supplementation with recombinant LH improved implantation rate, and in a recent meta-analysis, even ongoing pregnancy rate. So these are my conclusions. Please, IMH and IFH are effective and equivalent in predicting poor and hyper response. So you can use one of the two for counseling purpose. But if you want to use it for matching patient and protocols, they are very useful in my opinion. And the only study dedicated to this is the Optimist, but I presented this study to say that it's a very good study from one side, but you have to read it in a very critical way, understanding that at least in poor responders, probably starting those do not reflect what we do in the clinical practice. Hyperresponse is a phenomenon, meaning that patients have a resistance to standard doses of organoclotting. They have hyposensitivity, and probably it can be defined before by using very easy genetic testing for understanding if we need to give 150 or if we need to give 225. Because probably in some patients 225 or even 300 is too risky for progesterone rise. And LH supplementation is, according to recent systematic review and meta-analysis, is effective in patients with hyperresponse in the cycle or during the ongoing cycles that are consistent with groups 1 and 2 Poseidon. In group 2 Poseidon, meaning a patient above 35, but the evidence is only present in literature in patients between 35 and 40 years of age. Thank you for your attention. And if I can ask you, if there are questions, I can receive the questions now because I should be in another meeting at 1 o'clock. Thank you very much.
Thank you for this very interesting presentation for the effective combination of theory and practice. We have a question indeed. We know that you have limited time, so dear colleagues, now we can ask questions to Professor Alvigio, and then we will have further discussions during the allocated discussion time. So the first question we have got: to assess the risk of polymorphism in receptor genes. This is a new topic. Can you assess the number of patients who face this issue, and when do we have to test them?
Thank you very much. This is something that is not in the clinical practice. We just did association trial. There are two possible approaches, in my opinion. One approach, let me talk about good prognosis patient with a good ovarian reserve. One approach will be not using pharmacogenomic, but starting with 150 and in a sort of a step-up protocol. So if you see that in the first 5-6 days of stimulation, follicles are moving in the right way, the estradiol is not growing much, you can continue. You have the presence that the follicle output rate, meaning the percentage of growing follicles, 5-6 days is lower, or estradiol is lower, you are still in time for increasing and still having a synchronicity among follicles. Another possibility is starting with the 225, and if you have too much follicles growing, the estradiol very high and the progesterone rise, you can have a freeze-all procedures, but it is complicated to do it in all centers in a very cost-effective way. If you test the polymorphism, the cost of such a kind of polymorphism nowadays is very low, but you should have a dedicated laboratory that gives you the information. I suggest if you have to do it in all good prognosis patients before stimulation, because this is the only sense it has is to understand before is giving under 50 or more. And please note that in many countries at the moment, there are carrier screening programs before IVF, like in USA and whatever. So if you have a carrier screening in NGS, adding only this information has no cost. Probably you can put together with cystic fibrosis, put together with. So if the system is compliant in this, I think that in the future, it will be very easy to add some information of receptor for liver fused in NGS carrier screening program for IVF.
Чудово, щиро дякуємо вам за запитання.
Thank you very much for the question. We have one more question from the audience. On what do you think? What do you think on the effectiveness of AMH and AFC? Whether they are the only markers we choose for the dose in the stimulation protocol, or other factors when these are recurrent patients? It's not the first cycle.
Can you repeat? Sorry.
I mean, how I understood the question, that the question was related to the patients who are going to have second, third, and all the further stimulations. Would you recommend here to consider IMH and antral follicle count as those markers? Based on this, you would decide the starting dosage of the gonadotropins, or you would consider something else?
No, in my opinion, is very important, both. But in my clinical practice, I always decide the starting dose just looking at the follicles. What I strongly suggest is to have a look to the ovary on the second day of the cycle. You are still in time, or just in the interface between luteal and follicular phase, and have a look to the size of the follicles, the synchronicity of the follicles, number of antral follicles overcoming 5 millimeters. And it is, in my opinion, the best way to decide the starting dose. Because if you have asynchronicity, meaning 9 millimeters and 3 millimeters, probably you should avoid too high doses. But if you have smaller follicles, so in my opinion, the most important information is from antral follicle count. And IMH is able to predict the provine response in huge numbers of patients, but is less able to predict the number of follicles you will have during that stimulation. I'm really sorry, they are calling me from the LH World Congress we are having together, and they cannot start if I don't go. So if you have any other question, you can write me by email and I will reply, but I'm really sorry, I need to go.
Thank you so much. Yes, we have several more questions, but we will send them to you over and get it back. Thanks for joining us. Дорогі колеги,
Dear colleagues, we continue.
Дорогі колеги,
So, dear colleagues, we continue this session, officially supported by Maxerona and Sanofarm. And Hanna Zaychenko, MD, medical doctor, and Doctor of Medical Sciences. She is the chair of the department in Bohomolets Medical Institute. She is the author of many papers, and she will talk about the unity and struggle of the opposites. Are all gonadotropins similar? It's a pleasure for me to welcome you, and it's great that we have finally the clinicians and the pharmacologists meeting. Dear colleagues, we all are aware about the individual peculiarities of your patients. You know very well their metabolic profile, the genomic profile, the microbiome. You studied this very well. But me, I'm a pharmacologist. I know medicines very well, and they know that modern reproductologists find it difficult to navigate in the variety of drugs presented in the market. You need to know both the originals and the generics, the pro drugs, the blockbusters, and the phyto drugs and the nano drugs. And in particular, today I would like to talk about the biological drugs. Biological drugs, they're probably the most complicated drugs we now have in the clinical practice of reproductology. So what is so special in this group of drugs? Why are they different? Why do we talk about the originals and biosimilars? And what is special in the biological drugs? What should be known by modern reproductologists so that these drugs would be used with the maximum benefit for the patients. So, apologies, I will switch into Russian because that is easier for me and I will be able to express myself better. So, low molecular synthetic drugs, dear colleagues, you know them very well because they have a good structure, even though there are the different molecules, just like in the chemical drugs, there are also these monocyclic structures, but still, the drugs produced with the regular chemical synthesis, they are significantly more simple in their construction. They have a lower molecular mass, while the biological drugs, or even the biotechnological, which are even more complicated, well, they have a more complicated structure than a trivial chemical drugs. That is why today we can give a clear definition to this group of drugs. So, biological drugs. Their active pharmaceutical ingredient is the molecule obtained from a living organism. Apologies. Miss Anna, can you please share your slides? Yeah, of course. Can you see it? No, share your screen. It should be working. I don't know. It is open here. We can only see you. We do not see your slides. Oh, really? Apologies. Let me try again. Yeah, it is working now. Is it working? Okay. Apologies. Yes. Perfect. It's full screen now. Can you see it now? Yes, thank you. So, apologies. I will just briefly show the slides from the beginning. So, modern day physician has to deal with many different drugs, and it includes biotechnological drugs as well. So my task is to show what is typical for these drugs. These are simple synthetic drugs which have a simpler structure and lower molecular weight, when biological drugs are significantly more complicated. That is why there is a peculiarity of this group which I would like to point to. So, the biologic drugs are drugs which, as an active pharmaceutical ingredient, have molecules obtained from living organisms. They cannot be synthesized chemically. These drugs can have analogs, just like synthetic drugs have an original molecule and generic. The biologic or biotechnological drugs, they also have original and biosimilar drugs, which, and generic is not a proper name, the biosimilar is a proper name. They might be called biosimilar or the bioanalog. or in the American classification, they use the follow-on biologics, FOBs. So why today, why is it important to understand the difference in these drugs? Because in the last 10 years, we have seen a drastic expansion in the market of biosimilars. If we only had 0.02 of these copies in 2006, in 2016 we have 2% of biosimilars, so 100% more, because patents expire and many companies are trying to manufacture their own biosimilars, sometimes copying the well-known drugs, or sometimes finding their own way to make these molecules. But the market is going to expand, so we have to be ready, we have to understand the difference. That is a very important competence of modern-day reproductologists. Let us look at the foundational differences. In simple, synthetic, chemical drugs, they have a typical described structure that can be easily recreated in the synthesis. They have a very similar biological activity. And an important point here, these drugs, the generics which are copied from the originals, they do not undergo the complicated preclinical technological examination. Why? They already can take a prepared synthesis model and they just extrapolate the features of the original molecule. And there's a difficulty here. It's not always that the generic version has full therapeutical features of the originals. That is why for these drugs there is the bioequivalence study, pharmaceutical bioequivalence or therapeutical bioequivalence. If that stage is passed, then the drug can say that, yeah, we are the same. We're equivalent because we took this path. And usually the generics are cheaper, 40 to 50% cheaper than the original molecules. Things happen. Sometimes pricing varies and the generics are not really different from original drugs in price. This also happens. But the main task of the generics is to provide cheaper regimens using the drugs without R&D investment, so it makes the generics more available and affordable. But we need to remember which of these drugs took the path of proving efficacy and which didn't. If we talk about biotechnological drugs, these are complicated, living complicated ingredients that are heterogenic and difficult to describe. They are similar but not identical. The biological activity is not known for sure. We always need to study it de novo. And what's important, the main thing in its mechanism of action, we can only see it when the drug is in the system, in the body. And a simple pharmacokinetic study is not enough to describe the behavior of this drug in the system, and they are not enough. For biosimilars, we have to add another study module to get the registration approval. It shows that it's difficult to confirm the similarity in the action. That is why the experts require that additional module. Only if it's provided, you can register a biosimilar on the market. If we look at the well-known gonadotropin drugs, which are well-known, they have been in use for quite some time. I can say that starting from simple drugs, which we manufactured, for example, from urine, after that we had some drastic development, and in the last 20 years we have a true era of biotechnological molecules, because we are not using primitive old technologies. We are receiving recombinant gonadotropins, which are maximally approached to the molecule of gonadotropin and of human gonadotropin, and this is the key feature of this drug. Starting from 1995, when the first recombinant FSH was obtained, we can say that today there are folitropins alpha, delta available for the reproductologists. We have the combinations. We have recombinant LH or ACG, and we also have the choreofolitropin alpha. And today you've heard that now we have folitropin delta to help us. And this was not the final line in the evolution of these drugs. Very soon we will have the folitropin epsilon, quite soon, but it's not going to happen today yet. So the appearance of recombinant gonadotropins has significantly decreased the main problem of these drugs, the ovarian hyperstimulation syndrome. Dear colleagues, you know very, very well that these drugs make our job easier. What is so special in the manufacturing of these drugs? I have added a few slides just last moment because previous presenters did not really dive into that aspect, and I would like to present to you the proper way. How are they manufactured? Where are the critical points, and what is different? Why are there variations? In the manufacturing of biotechnological drugs, what's important? Well, of course, it has to be a highly modern, highly technological manufacturing. You know that biotechnology is the highest, is the top class in pharmaceuticals, because these are cellular technologies that ensure the viability of the cellular material and proper purification. It, of course, is significantly more costly than the average pharmaceutical manufacturing. So you need to have a reliable producer cell, the cell that's going to develop the molecule of this or that protein. You also need a vector that will transfer the DNA. Usually it's a virus which transfers new DNA into the cell, which will clone the molecule we need. Also, it's very important to understand that in the process of biotechnological manufacturing, it's critically important to undergo the industrial fermentation process. We need to purify the protein we obtained from all other proteins and other fragments of the producing cell. We need to receive a very pure substance which later would become a drug. And then the reproductologist would inject this hormone, this protein, this hormonal polypeptide product into the human body. So the manufacturing of biotechnological drugs, well, of course they have similar processes, but we have to understand that every specific manufacturer has its own technology, its own equipment, its own purity, and its own industrial secrets in the biotechnological manufacturing. And the final product is always a combination of the technological aspects and purification aspects and standardization. And at the end, these critical points, which are there in every manufacturer, they define the efficacy, safety, and quality of the biological drug. Of course, the producers, the producing cells are the key here. How is the drug manufactured? It's very important that the well-studied cells are used. Perfectly, they have to be in the manufacturer's own bank and not procured from different suppliers, because then it would be difficult to understand why the final product varies in efficacy. If the company has its own bank of cells, its own technology, which is improving year to year, then of course it is the most prospective approach, because the company who has a long story, when it has its own producers and cell banks, it can provide a stable series of drugs that would not vary from series to series, and they will ensure stable quality. And also, what's important, that these cell lines, which can be that they can be different, and also the trophic environment can be different, the purification cycles and technological tools to achieve the final result, they all can vary in different manufacturers. And today I've heard a very surprising idea that if we use a cell line from let's say well-studied hamster cells, we can never be sure that the final product is a molecule obtained from a hamster. Yeah, of course, the original culture was the cell, and they choose the cells specifically. For example, some antibiotics production, they only use bacteriological, they use primitive cultures. But for complicated molecules, indeed, they take cells from living organisms. But you cannot say that this drug is produced from hamsters, because then, do we say that folitropin delta is produced from humans? No, we cannot say that they're not produced from the organism. But anyway, that is why there can be variations in the isomers, in the stability of protein molecules, and the links and glycosylation sections, in the binding features, in the way that they bind to receptors, and this can change the features of these molecules due to differences in manufacturing. That is why the final protein stability can be different. There might be other isoforms, there might be additional substances emerging, and that defines different immunogenicity. And of course it changes the activity, the efficacy of the drug. It might vary from lot to lot, and in your very, very precise work, you have to rely on drugs which are definitely never gonna fail. And of course, the many years of experience of Merck with their own cell bank and technological process, it is very important. I would like to draw your attention to one more component in the quality of biotechnological drugs. Well, there are good manufacturing practices, very reliable practice, but besides that, you need to preserve this drug, and they are like a crystal vase. They are fragile. They have to be stored properly. In some situations, also the cold chain is required. And only if you have the optimal conditions for the drugs, for example, in the 2 to 8 range, then we can be sure that the drugs are proper and reliable. And now it's really bad that we have some internet pharmacy, some shady suppliers, when you cannot really be sure in the quality of this drug. We have to talk about GDP, good distribution practice. If there is no proper practices in the supply and storage, then yeah, the efficacy of the drug can really vary. Also, what's an important thing that differentiates biotechnological drugs from synthetic drugs, it's immunogenicity. This is the possibility to cause the immune response. It also is about the production of antibodies to the protein product. The higher is the purity, the lower is the risk of allergic antibodies, and the less there will be antibodies which inactivate the biotechnological drug. And it's very, very dangerous when in the beginning, when you start the productive technology, you use a product with a high immunogenicity level. It can end badly not only for the patient, but it can also block further IVF attempts, because unfortunately the level of antibodies to, for example, FSG would be so high, FSH would be so high that the drug would be inactivated without even becoming active. That is why in all the developed countries there are very, very strict requirements to biosimilars and biological drugs in general. And, well, seemingly, in the United States, they have insurance medicine and they want to minimize the costs through biosimilars. But, nevertheless, not a single FSH biosimilar is not registered in the United States. They, up until today, they prefer to use purely the original folitropin alpha GNA. Let us look at the differences in the biotechnological drugs. It is clear that we might have the original drug, the innovator. There might be also another company which looks for its own path. It might be not, say, folitropin alpha, but some other folitropin. The company chooses its own way to get this technology, and maybe they even get a drug that is going to be different in its features, in its quality, and the most important, in the indications. And then, essentially, the drug might be even better than the innovator. It is rare, but there are such examples in the history of pharmacology. Most often, the companies, they just follow the leader. You know, like the Lenin icebreaker, breaks the ice and others just follow their trail. The companies just try to replicate another drug that has been already developed and shown good results in the clinical practice. And then they want to research the way to manufacture it with preserving the best features, and then they will have the same indications in the leaflet, same pharmacological features, and then this biosimilar only has to prove in the clinical conditions that it is clinically equivalent. And then they are considered a similar drug. And then the regulator, looking at the clinical equivalence study, can say that, yeah, this drug can be used, there can be a therapeutical switching between these molecules. There are also the Me Too drugs, which do not strictly correspond to the original. There's a change in the technology, and this is a product which has not yet been widely proven in clinical studies, and we can, and they can say that, yeah, Me Too, we're also clinically effective. And unfortunately for these drugs, when there's lack of evidence, they cannot really be considered similar. But they are there in the market. And you have to know that for these drugs, in only 1 or 2 clinical studies with a limited population of patients, well, it's not a good evidence. So it might take a long time to deal with these drugs to understand whether they are actually effective and safe. But formally, they are allowed on the market. Today, I want to talk only about the drugs which have proven and provided very good evidence that they are really biosimilars. So are all the folitropins similar? No, there is the original gonal, which we have been using from 1995, and there are two copies in Europe, which we call biosimilars. This is Ovalip that came out in 2014. It has not been registered yet in the country. And there's also Bemfola. It's also folitropin alpha, only alpha, and it uses a similar technology. It copies the path of gonal. Now let us see what was found in the multifocal comparison studies of the original gonal and Bemfola. We have seen that the Bemfola, formally, looking at the figures which I have presented, and the final endpoint, the healthy birth, it's equivalent to gonal in efficacy. Even though there is the difference in the percentage rate, the statistical difference, well, we are researchers, you know. We don't just look at the number, we have to understand that the figures have to be statistically significant. So we have to understand that Bemfola at the similar efficacy, unfortunately, has shown twice bigger ovarian hyperstimulation syndrome. So you see, the efficacy is comparable, but the safety profile is different. So there is something wrong in the biosimilar. While if we look economically, it turns out that the use of original gonal F leads to saving. I just want to make it clear. Pharmacoeconomics, it's not about the cost of the pack. We need to look at endpoints. If you calculate the costs invested in the birth of one baby, it shows that gonal can save 9 to 17% to different clinics. So what else can be different in recombinant folitropins? They can be alpha or beta or delta or epsilon. What is the difference? So alpha folitropins, just like beta, just like the folitropin alpha, they manufacture through recombinant DNA technology and they use one producent, the Chinese hamster cells. And they are identical to human sequences, and there is also the mass calibration and recalculation ratio into international units for alpha, and then you can provide personification for every patient. Beta folitropin is also manufactured using the recombinant DNA technology, using also these Chinese hamster cells, showing the different glycosation profile as compared to folitropin alpha. And unfortunately, it's only dosed in international units. So the specifics of the manufacturing influence the dosing. The folitropin has similar pharmacological features, but through the addition of the carboxypeptide beta subunit, the duration of effect is extended, and it is now dosed only in milligrams, 100 or 150, and it depends on the mass. Today we have heard a big and fantastic and very interesting symposium on the new folitropin delta. This is a product of recombinant technologies of the culture cells from fetal retinal layer of humans, and the producent is a cell which is not producing FSH in our body, but this cell indeed has been obtained from the fetal tissue, and it was quite difficult. The company has shown a complicated path due to some ethical issues when they developed this technology, but we cannot say for sure that that drug has been produced from humans. No, God forbid. We know that this is just the way to describe the cell line which is used to produce FSH, and the drug has not been validated to IU. It's dosed in micrograms depending on the body mass and AMH quantity. The dose is selected in the beginning of the treatment and for the whole course of the stimulation without the possibility of adjustment. It's good, and it's a good thing, but it's a new thing. We need some time to understand whether this is very, very important. The FSH is the most important hormone for the reproductive system. Let us look at what is different in gonadotropins. You know that they all have equivalent alpha subunit, and beta subunit is highly specific for every hormone. And also the glycosation sequences are typical. Due to them, these hormones have different isoforms. So they can be different through the glycosation. The branches can be different. But you might ask, why do we need to know that? But you see, for women of fertile age, say, for them, only two branched gonadotropins are typical for the folitropin alpha, while for the folitropin delta we see 4 branches of glycosylation. So 2 branched hormones are kind of similar for women of fertile age, while this 4 branched hormone is more typical in the menopause. Why is it like that? Why has the nature meant it like that? I don't know. I can only redirect it to you. Whether it matters, I think it matters, because the reproductive potentials of young women or women closer to the menopause is very different, and the hormonal differences might be important. Also, the cellization, how can it be different? What does it mean? There are differences in the number of sections which bind the hormone to the receptor. We know that we need to make sure that the hormone is bound. As for the receptors, there are the polymorphisms. So for the Caucasian women and Asian women, the differences, the genetic differences in the condition of the receptors can cause the difference in the sensitivity to folitropins. So different folitropins can have different efficacy depending on the genetic predisposition, and these studies have already been published in the specialized journals. Dear colleagues, I would like to remind you that even though folitropins alpha, beta, and delta have the same amino acid sequence, and they're different only in its glycosylation, the final product can be closer to the hormones in younger fertile women or the menopausal women. So what is the difference in folitropin alpha, and how is it different from folitropin delta? You can see that alpha has 2 branches of glycosylation, and delta, which is produced from a different cell line and different selection criteria, they have some pharmacological features where you cannot adjust the dose. There is no personification, and while for folitropin alpha you can have individual dose adjustment. The registration study, ESTER-1, I have looked at it closely. It was planned as the one without any preference to the company which provides, and the company providing the new folitropin delta wanted to show that as compared to widely applied folitropin alpha, the efficacy is the same. So it was not in the design of the study. They didn't measure whether there was any additional benefit. So the result of the study only shows that it is similar in efficacy. While I was also surprised that they have used the delta in one dose, because this is the way they manufacture the drug, while in the folitropin alpha, digonal, which they used to compare, and they had to use it considering the personification, because the leaflet, in the indications, they have the personification. Also, there's the EMA warning. The folipin delta has certain differences in molecular structure, in the nature of the original material, and the manufacturing process, but it's not considered a new active ingredient, even though but the technology is different. So this black square shows that we have to have more safety studies. So it's important for us that the product requires additional immunogenicity and safety monitoring. This is a warning from the European Medical Agency that the new folitropin must be studied further. The clinical practice where they use only certain recruited patients and the real clinical practice, they are different. We will still need a few years to figure out which folitropin is going to be more applicable in this or that situation. But the 25 years old story of confirmed efficacy, and there's no audio feed.
Дорогі колеги, ми маємо технічні несправності.
Dear colleagues, unfortunately there are some technical difficulties with the feed. We are trying to resolve it and we'll get back to you shortly. Ms. Ganna, are you here with us?
Ми перепідключаємося.
In the meantime, while we reconnect, let us watch a video.
Уважаемые коллеги,
Dear colleagues, apologies for these technical hiccups. Professor Zaychenko is back again with us, and she continues. Yeah, I'm almost over, dear colleagues. The first thing I wanted to underline, that randomized clinical studies these are the refined conditions for new drugs. Inaudible. Ganna Vladimirovna, apologies, the audio quality is very low. Apologies, there's low quality of your audio. We cannot hear you. We understand that this is your last slide. Let me just focus your attention that even though the follicle-tropping drugs are similar, they also have their differences, which can be crucial for the birth of new lives. So we need to understand them and to consider them to achieve the best results. Thank you for your attention. Thank you so much. And apologies for any technical hiccups. We have a question. So, the glycosation profile for folitropin alpha and delta varies because this is a recombinant drug. We have the affinity closer to the menopausal hormone. But how does it affect the clinical efficacy for the drug? What does it mean for us, for practical reproductologists? Let me say that we are now in the process of the clinical use of the new folitropin, and we will see the difference. I will see the difference in the outcome. So let me rephrase the question. What is the difference in the hormonal status and the fertile potential of a younger woman and the menopausal woman? The menopausal woman she might look young, but you know that the closer a woman is to the menopause, the lower is the chance. Why is that? Because even in the natural hormones, there are differences in the glycosation. Perhaps this is the natural way to change the reproductive function of women. Same is in drugs, even though they are almost the same, but this glycosation profile unfortunately makes it kind of looking more to the menopausal. I don't have the data whether it's good or bad, but I will collect all the data and present them to you next time we meet. Thank you. It's a very useful experience for us. And we continue. So the third and the last talk in this section.
Дорогі колеги, ми повертаємося.
Dear colleagues, we get back to the studio, and the third and the last lecture here is me, and I'm presenting, and I appreciate Merck and Sinopharm for the invitation. For me, it's always about analyzing the results. It's always about analyzing what can be improved, considering also the remote, the distant results. And in my experience of working with folitropin alpha, the drugs which we know, and appreciate, let me share my presentation from quantity to quality, the personalization and specific features in treating low responders.
Коли ми говоримо про цілі репродукції,
When we are speaking of the objective of the reproduction techniques and that we are as the IVR specialist put in front of ourselves, this is the achievable pregnancy. It doesn't matter that the patient comes from 5 to 8 years, coming from different data, different studies, to the moment when she, for the first time, was a reproductologist. She talks to gynecologists at best, she talks to the neighbors and other experts. We understand what's the start that she has, but as soon as she opens the doors of a reproductology clinic and she expects the results to achieved as fast as possible, and we face the fact that positioning of the segmented cycle, it's not the expectation that the patient expects really, because we make such a decision to maximize our own chances and results of the treatment. The other part of reproduction is the minimization of the number of the failed trials, and each one of you knows that independently on the recommendations that we use, and speaking of the size and volume of the test for each patient, speaking about the world or Ukrainian recommendation, we are trying to do as many as possible. We're trying to answer the question that we can try to predict getting out of the patient's history and by testing. And as a result, we have better results, usually at the first attempts for treatment by assistive reproductive technology. The next thing is that lowering the rate of multi-child birth or pregnancy, and we use it in our daily practice, and we are convincing our patients that selective one embryo transfer is the best practice to achieve the birth of a healthy child, which is provision of the safety of this usage of the implementation. And we have a safe protocol with antagonists on with agonists as a trigger, and we know how to provide a full safety for our reproductive patient. And also, this is the help to as many patients as possible. We've talked a lot during all of our meeting today or in other sessions on the standardization and personification of the treatment. Each and every approach has its own pros and cons, and if we are speaking of standardization, we have to understand based on what factors do we place ourselves and what is our main instrument here. We're mostly mentioning the controlled ovarian stimulation and not speaking of the natural cycles. Or we do understand that if we want to receive the optimal number of the ovaries, we have a good instrument, which is our drug, stimulation drug. And based on different algorithms, we use different parameters that we are regarding as the main parameters of, which is proven anti-mood hormone, and each and every one of us, it's not like international recommendations based on that we can make something of our own. I just sharing my own clinical recommendation in the calculation of the initial dose of stimulation medicine, getting out from the standardized approach. And it's how do we see a finished cycle of assisted reproductive technologies by reproductologists itself? After they conduct a full-scale lab test, we are conducting oral stimulation, and objectives of the stimulation is the receival of the optimal number and optimal quality of oocytes. And then we have to work together with the clinical lab, with the conservation and receival of the optimal number and the possible type of embryo transfer that patient is expecting for so long. We are continuing by the screening and other markers that we have to maximize our chances to receive a pregnancy. Optimally is that the receival is to conduct a cryocycle, not moving one cryocycle, but still in a capacity to do additional testing and understanding the clinical case and support for the patient as a whole. How do we communicate with the patient on psycho-emotional style, and what do we have in the vision of our patient? She understands that she has to have the treatment admitted and to receive injections, and we know of and we share the experience of how it's supposed to be done. We explain the factoids that we are expecting to receive eggs. In her understanding, those are all perfect, wonderful. She looks like Linda Evangelista. She looks like a model and all of that. We have to explain for long why the number of the embryos in the final stage does not equals the number of ready eggs that we have received. But the patient understands that in the end results, then she expects is that at least you have one healthy child. But many of you, and we all have the experience that from one stimulation, we're just expecting to receive at least some of a few healthy kids. The question is only in time. Those are results delayed from 5 or more, even 10 years, essentially. This is what we are speaking about, the young patient with the good responder. There's also a different group of patients. This is patient older and with a poor or low response, with whom we can't have the optimal number and quality of oocytes or eggs. Then we build our discussion psycho-emotionally based on the fact that we have to receive an oocyte, at least one. We will do our best to receive the embryo. This is the expectedly to be an embryo of a good quality. We can't not really guarantee, but this is how the patient actually sees it. And we finish all of that with the live birth. Is it always happen like that? Does it always happen like that? If we're mentioning the standardization, that what are the parameters that we can actually standardize our patients? The main and the first parameter is actually the age of the patient. And mostly when we're reading through the clinical trials, judging the results, we see the group of patients that are actually separated by the age. Usually it's younger age, middle reproductive age, or age over 35, or sometimes have 40 plus. This is the level of anti-Muller hormone and the number of antral follicles. Those are the markers based on which we can standardize their approaches. But the most of our patients will be patients that would always have the preliminary own treatment programs results, and those markers and those representatives actually moves us to the fact that from the standardized approach we have to think on the individualized approach. We always evaluate the preliminary stimulation protocols. I have to mention that the tactics probably will be different depending on the fact whether it was me who conducted the stimulation cycle for this patient or was it a different doctor. But in any case, we will try to evaluate the results and individualize our approaches to the patient. There are different factors like the type of infertility, the presence or the absence of endometriosis. We understand that there's a male factor. We also have here to optimize and to receive that the bigger number of the oocytes if we have the choice, and this is genetically also the input. This is what we mentioned before, not for a long time, but I hope to speak with you during today's lecture, that if we have a good responder and expecting her to have the wonderful result, but result doesn't really follow up and follow through, then we have to change our clinical approach and the management of such patient. Accordingly, if you're mentioning the effectiveness of the stimulation protocol, it's defined by the overall dose of the medicines used, the number of received oocytes and embryos, the overall probability of reaching pregnancy and live birth, and also two additional parameters that are also we include into our clinical practice in our constant monitoring of in our clinic, which is the follicle ovarian index and the productiveness of the follicles. And why is it so important to mention them? Because each and every oocyte is actually important. And if you are to evaluate the follicular indexes in normal, and this is the publication in the literature, the number of received follicles as the result of the controlled ovarian stimulation is over than 50% from the ones that we've seen on the beginning of the ultrasound, and evaluate them as the overall number of antral follicles. And the lower index is in case of the number of such follicles as a result of conductive controlled overall stimulation is less than 50% regarding to the number that we've seen on the ultrasound at the beginning of the stimulation cycle. In the pathogenesis, we can have a few different factors, which is the lower dose of gonadotropins at the beginning phase. But we do understand by having the standardization based on the approach of the age evaluation, AMH, and number of intral follicles, we are picking the most optimal dose of stimulation medicine. This can be additional exogenous or internal influence on the how the stimulation actually happens. Can be asynchronity of the follicular growth or any technical issues that are connected to the input of trigger or the methodology of the pickup. And other parameters are, for example, the productiveness of the follicle. So that the fourth parameter that can be evaluated based on the number of intral follicles, from 3 to 8 millimeters as the number of follicles on the ultrasound diagnostic to the number of pre-ovulatory follicles before the trigger is done, and it's supposed to be over 50%. We are, as a reproductologists, we don't really think that our fate is defined by stars or anything else, but then more and more with the development of genetics and with understanding of that the reproduction is any other field of medicine or healthcare cannot go together hand in hand with genetics. We understand that many things in our fate are actually defined by genes. And when we are mentioning about the genes that are control the central endocrine regulation, and we are always mentioning about the products and hormones, gonadotropin releasing hormone, which is LH and FSH, and other types of hormones that are maybe less important. But we didn't remember the fact, because we didn't have the data yet, on the importance of receptors on this central endocrine regulation. And so we also have such an important player in the game, LH, GnRH receptors, which is important in clinical practice. And we will speak more on that today, because the follicle maturation number of the cells that we have at the end of the controlled ovarian stimulation, it's understandable that this is actually happening in the previous menstrual cycle because of the androgenic function that are forming the pool of follicles that will actually go through their growth in the next follicular phase. And here what's important is the influence of LH and activity and its influence on the LH receptors. And in early follicular phase, it's important the FSH recruitment of follicles that will become our dominant follicles, and then will produce for us an real eggs. And the end of the follicular phase, it's important the influence of both hormones, LH, follicular hormone, and their adequate cooperation with their dedicated receptors. Like a year ago, they had a study on the clinical efficiency and need on the evaluation of the genetic variations of the markers of gonadotropins, and they have conducted the first systematic review and meta-analysis that actually states the fact that in women and patients of the ART that has the support and homozygotic presence of the polymorphisms of genes to gonadotropins to FSH or LH, those patients, they have much more gonadotropins usage. They are less sensitive to the many medicines like gonadotropins that we give. They produce less oocytes. So the pharmacogenomic approach here is a really prominent strategy, using which we can actually improve the clinical treatment of the paired or couples with infertility. A group of studies show that they're trying to predict the live birth rate for the patients that are homozygotic carriers of the gene, and their live birth rate is comparatively much lower than the overall population of the patients without this mutation. Now, we have the congenitive LG receptors pathology. This is probably the hyper-response reason, and you have the comparison here. How much bigger dosage of the dose they need to have the optimal number here, and resultiveness in the number of oocytes in the controlled ovarian stimulation. Also, we have proved the association of the polymorphisms of gonadotropin-releasing hormone with some different population. We are speaking mostly about the Asian population, in which if they see the patient of the Asian phenotype, we know that the number of oocytes in this population will never be higher than 20, in comparison to the fact that in our European population, for some groups of patients, and regular response or normal response, this is just the standardized result. And so the frequency of polycystic ovary syndrome, so we have in the European population much more than before. And it's usually conducted with polymorphisms of receptor genes. So what are the results and specifics of controlled ovarian stimulation for such patients? The level of follicle-stimulating hormone at the beginning of menstrual cycle is much higher in homozygotic carriers of the mutation of endogenic gonadotropins. For them, it's also, they have a longer menstrual cycle. They don't find a connection between polymorphisms, the FSH, and ovarian disability, and Ford index and follicular ovarian index less than 60% is found in the homozygotic carrier, so the receptor FSH and LH. The frequency of receival the radioocytes is 60% and less. You also have it in this population of patients, and also there are publications on the lower blastulation and all of those groups. So who is recommended to have a test on the state of gene receptors, which is the polycystic ovaries, and the patients, they have specifically, speaking of the practical healthcare system, this is especially the patient that they have inadequate results in the previous controlled ovarian stimulation cycle. So the foreign follicular ovarian index was less than 50, and the maturity of the ovaries that we have received, they don't have any other additional factor. We understand that there is trigger, other days of stimulation if during the fact that we have controlled all the other stages, this is the maturity of oocytes are still low. What to do if you have a confirmed polymorphisms? For carriers of homozygotic FSH carriers, it's an indication to prescribe it in a higher dose to the standardized dose or the preliminary given effective dose plus 75 or 150 international units. For the carriers of homozygotic actually factors and receptor, we need to LH medicine included. If they have 221, it's like Verhoeris medicine. So that the carriers of homozygotic stage of we have to increase the number of FSH medicine 100 to 150 units. You have to mention that if we are planning the work of our ER, OR, and the visits of the patient, that the longevity of the stimulation homozygotic stage of the FSH and OH, usually it's prolonged from 1 to 3 days. Also, what is recommended, an additional control of the maturity of the follicles by the level estradiol. Not everybody is using this parameter actually, but if we are expecting to have a mature and quality-based oocyte, the level of estradiol for the one dominant follicle is supposed to be more than 60 millimeters, supposed to be higher than 100 milligrams per milliliter. And this type of this trigger doesn't really play such a big role. We just spoken about the pathogenesis of an optimal response if we have such a low beginning dose of gonadotropins, and if this is genetic influence and we understand what kind of methods and changes can actually be used if this is asynchronity or asynchronic maturation of follicles. For the fact to avoid such a maturation, we actually propose and we have to follow the rules of the beginning of stimulation on the second or third day of menstrual cycle.
Проконтролювати відсутність дріючого
and control the maturity of the follicle. And we can also use this approach in the randomized stimulation, and more which we use in our practice. And here we place the absence of the maturing follicle. If you're visualizing the follicle more than 14 millimeters during the first ultrasound, which is the 5th to 7th days of the stimulation, you need to delay the start of agonisms before the main cohort of follicles will reach 14 millimeters or the estradiol 15 picometers per milliliter. So we have to also see the usage of LH medicines to conduct care in such cycles and avoiding asynchronic maturation of the follicles. If we are mentioning about the main criteria of this successive ART, then the number of received oocytes and their quality directly connected to the frequency of the live birth rate. And we have many publications that the more oocytes we receive, and the higher the incidence of live birth rates to every group of patients. And we do understand that the group of patients, they are different. Those are young patients, there are also patients, aged patients, so the number of aeuploidy blastocytes are lowering. And this is the other group of patients actually that are expecting from us the result, and where we can't promise the result, but we can understand that the chances and chances are lower, the risks are higher. And still, regarding the clinical strategies that we have, we need to do, and we have a decision. We can propose the alternative as the combined programs or the combined egg donor, but this is not the topic of our today's meeting. And if we are mentioning the stratification of patients based on this bad prognosis or negative prognosis, this is young patient with the good prognosis, or we have one tactic of the management. This is the young patient with the lower prognosis, and so the patient aged with a good prognosis or the worst prognosis are completely different. And here we have to use the personalized actually approach here. And accordingly, here for some people actually one oocyte would be actually wonderful in the aeuploidy embryo, and for some patients there's a big number of oocytes doesn't actually lead to clinical pregnancy. So how many oocytes do you need to optimize the level of live birth rates? And you can see the publication in which you have the cumulative percentage of live birth rate depending on the number of oocytes received. And here the maximum number that is stated, which is more than 15 oocytes, and the cumulative number of live birth rate, which is 61% on 1,100 patients. How does this cumulative percentage of the pregnancies actually happen? This is the possibility to get the result after the conduct of a few transfers, embryo transfers, or it was either fresh or preserved or freeze material. We actually have to calculate the number of pregnancies that has actually happened and occurred. Why does the every oocyte is important? You can see the publication of the use of recombinant FSH that comes and leads to the achievement of big number of oocyte and allows us to prescribe more more medicine like MAH, and using the FSH allows us to lower the number of side effects and everything. So that the question is, this is the approach that we mentioned before. So what is the number of oocytes is optimal to receive actually multi-life birth rate? So that the few children from one stimulation cycle, this is the practice that we have used all over the world, that the one first cycle was the optimal or a higher cohort of the received oocytes actually shows the concept of 2 in 1. We have one stimulation, a few transfers, and big cumulative stage of actually having pregnancy. There's so many publications how the max number of oocytes got in the controlled stimulation. They have like under 20 or just slightly over 20. This is the Spanish group on ACOBO. Here the group of patients is the normal gonadotropic responders, and you can still see here the number of the oocytes, which is 43, and if you have it with the compared with previous studies, if you have 67% of the pregnancies, the cumulative test if you have 15 oocytes and if you have 43 oocytes, the cumulative live birth rate, the percentage is actually 97.3%. Why is it important? Because frequently we had a discussion regarding the fact that the more eggs we have, the lower the quality of them and the lower the potential of having an actually good quality embryo. To actually cancel or support this theory or such an approach, we have conducted our own tests and trials to understand that there is a causation correlation with the number of oocytes and the biological effectiveness. And you can see here that in the first group, they received from 1 to a number of eggs. There was 500 cycles, 12 to something oocytes, 226 oocytes, and so on. And so the more than 31 oocytes was the regular mean number 39, which was 310 cycles. We haven't found out in any really statistical big difference. What was interesting for us and where we have pointed our attention mostly, which is the percentage of embryos used or transferred or freezed on the third, fifth, and sixth day. And speaking about the effectiveness, the least effective group was speaking of the number of the used embryo, which was the groups from 1 to 11 eggs, and the groups from 12 to up to 30 oocytes of the used embryo rate was mostly identical. What has changed? Something has changed. The percentage of the matured oocytes that we used, but from 80 to 78% or something. So, in the biggest cohort, the selected oocytes, they had a higher selection. But yet again, this meaning on those number of cycles are not really statistically significant. If you are to speak on the effectiveness and expectation that the patient has, if the patient has a number of the eggs, we can actually prognose the results of her treatment cycle. For us ourselves, we compare the patients where we have 8 oocytes and 12 oocytes as well. And you can see here the clinical case of the pregnancy was statistically good, even though it wasn't a big number. It was still higher in cumulative pregnancy rates from the 12 oocytes, just because there's a better selection of the embryo was still higher. If you are to mention the dosages, and what is the top effective starting dose of FSH, we remember today during the day that the fact that the effective top dosage is supposed to be considered 300 international units, just because a young responder will produce the biggest number of mature oocyte using this dosage. If it's a low responder, then this will be ineffective, and so the number of oocytes will not be actually different from the ones before. If we are mentioning about the prognosis, then FV reproductologists have conducted his field of work, and the responsibility has actually moved to the embryologist's point of view. For us, it's also important to evaluate the quality of oocytes for eggs, and we categorize them for a few categories, just for us to be able to evaluate the efficiency and to make a prognosis and what can be actually promised to the patient. And they usually communicate after they have a number of oocytes received. So the Q1 is the morphologically ready and mature oocytes. Q2 is with the small morphological changes, and the oocyte with the meaningful changes. You can see the details on the screen. Those are the oocytes in the Q3 category. Why is it important for clinical approach? We've marked those oocytes and we've evaluated clinical efficiency, moving from the used groups, and the patients and the used oocytes were separated to two groups, which is the oocytes Q1 and Q2. And you can see here the number of survivability of this number of oocytes is connected to the 120 oocytes. It happened to be 92%. The percentage of fertilization is 82. Day 3 embryo quality was 44, and the high quality blastocyte is 56, and the overall fertilization rate is 56%. The percentage of the oocytes are used in the Q3 there was much better, which was is or supposed to be. As for today, we are deselecting such oocytes. If we want to have if we have this material done and the possibility of using the clinical pregnancy, then the best is to prognose the morphological qualitative oocytes. If you're speaking about the statistics statements and the world has, then so to evaluate the potential clinical results calculated for one oocyte, the American Association of Reproductive Medicine and Healthcare evaluates such potential as the 4.5% to 12%. So if a patient has one oocyte, then the chance that she has for pregnancy from 4.5 to 12%, so that every single oocyte, if in correct pregnancy management, if you actually increase the chances for 12%, this is a wonderful case here. It's also important to mention neonatal processes after you have a big number of oocytes. And this publication actually shows those results in freeze-all cycles, and as a result, they haven't found a higher risk of negative results for newborns in the controlled ovarian stimulation cycles with the receival of a big number of oocytes. Also, in chances of receival at least one euploidic embryo in the controlled ovarian stimulation cycle is much lower with higher age of the patient, but much higher with every additional embryo which is connected to every singular oocyte. Another publication that tells us on how many oocytes can be too much oocytes, right? And if not in many people from international colleagues actually published the factor of getting more than 30 or 40 oocytes, then I think that every one of us has faced the patients like that. And so it's important to speak of, it's important to analyze it together. And there, as a result, the clinical pregnancy and level of black birth rates is growing with the growing number of the oocytes, and this is why getting the more embryos from one stimulation of the cycle also increases the chance of cryoconservation and the transfer of the frozen embryos and lowers the number of the needs on the stimulation for the patient. But still, you need to understand to make a decision on the stimulation dose of the medicine, not to make it, for example, like as a blunt thing, and to have the understand the risks of that there's an OHSS chances. And the data analysis on the association between the ovarian stimulation and the level of the loss of pregnancy or miscarriages, there is a connection between the low response of the ovarian stimulation and the higher risk of miscarriage. Similarly, as in our test we had, when the lowest number of embryos were used, so that the more embryos you have received, it doesn't influence the level of the pregnancy loss or miscarriages. What are the negative facts can be connected to the having big cohort of follicles? That doesn't sound that I'm promoting to have a big cohort of the follicles. I just want to mention the fact that we are mentioning that we have that in our practice. It's our life, and we have to understand all the benefits and risks, and because the risks is the pain and discomfort after the procedure with the big cohort of follicles, which is the high levels of estradiol, which is connected to the higher risk of thromboembolic complications development, which is the higher risk of the bleedings after the procedure, of pickup of the follicles, and the big size of ovaries can be in higher frequency, can lead to the thing is the change in form of the ovaries and tubes. Speaking of the approach to oral stimulation, I'd just like to get back to the Esther study that we mentioned before in our previous sections. And individualization, personalization based on the characteristics of the patient can actually optimize the effectiveness of the treatment and has the similar efficiency compared with the regular stimulation. Esther trial had two groups of patients stimulated by folliotropin delta and folliotropin alpha. They have included patients from 18 to 40 years of age, but if you are to mention about the personalization of the treatment of folliotropin alpha, then the patients of over than 30 years of age, from 30 to 15, we understand that the criteria posted on this is the patients of the higher age group that was the lower response and potential. Those patients, they had more than 40%, so that for this group of patients, folliotropin alpha was used in suboptimal dosages, and the use result can be different if this is the comparison that if you would conduct the personalization, take into account the age and the number of ventral follicles on stimulator hormone for this group of patients, then the clinical effectiveness and the difference would be higher for 50%. This group of patients has they have to have the personalized approach done and all that. If you are mentioning the hyper response to using the recombinant LH, then in deficit of LH, those are the patients. What kind of patient are that? The patient with the insufficient secretion or the activity of gonadotropin-releasing hormone, or any violation of such hormone. This deficit can actually be congenital or acquired. The reasons of the complicated deficit can actually be hypogonadotropic hypogonadism or secretion problems, which can be connected with the high spread of the mutation of the receptors, what we mentioned before. If you're mentioning about the source of OH, the source of OH can be recombination medicines and also the urinal gonadotropin. It has an OH molecule and it's much purified and it has a higher efficiency. And as a source of OH, the activity matters. If you're mentioning the physiological influences, speaking of the luteinization hormone, then OH supports the maturity of maturation and it almost not acquired in the stimulatium. It doesn't have suppression action on receptors and stimulates the formation of androgens, and it also suppresses the apoptosis and haplorefertic effect. When the gonadotropin supports the development of the placentation, has a longer removing sites, and it has the expression of the receptors, and it includes the progesterone receptors and has apoptic activity. And if a lower number of OH actually influences on reproductive activity, gonadotropic hormones has a lower number of follicles, and at the same time the recombinant FOH can be not enough to start the development of follicles, then maybe it's important to give this into our protocols that support the implantation indicators by adding the recombinant LH to recombinant FSH into the protocols with antagonists. And we have conduct of 200 something cycles of 140 patients for all the patients. We had used the perforaris, and you can see statistically it's supportive. A number of embryos also supported the implantation. And when do you have to add recombinant OH? They're not stopping in many publications. The correct answer that we have all supported before, this is the use of recombinant from the first day of stimulation, and this is the proven effectiveness and efficiency as for today. Also, we have from the patients of the older reproductive age, the adding of the recombinant OH has actually improves the clinical pregnancy to 36%. Other tests that I would like to speak with you today, which is the trial, the case report, which is the usage of getting from the Registry of German Reproductive Medicine experience the perforaris usage drugs. 3 years multi-center, the objective which is to evaluate to what group of patients those German doctors have prescribed perforaris. Those were the perfect patient with the low response, with the low OH, and they were in older reproductive age. The median dose of the stimulation of medicine was 181, and the mean treatment age was 10 days, 10.8 days. So we see here how results of the treatment are so much higher incidence of the clinical pregnancy rate. And this efficiency has actually been in both groups of patients before 35 and over 35. It's also effective to add the recombinant NH with the low response women and the controlled viral stimulation. It's also one type of trials that actually shows us this kind of results. And improvement of a number of the pregnancy rates in 30%. Why recombinant OH and FSH? 2 to 1. This is physiological, getting from the potential of our sex hormones, and we have the influence in the fact that it doesn't happen the preliminary follicular ovulation before the time. So this is why it has a positive response, which is the patient with older reproductive age, patients with suboptimal low response to the stimulation in the previous cycle. This is the insufficient number in the stimulation in the current cycle. So in this case, we will be using an OH from the moment of visualization of the insufficient response, so that, as we've mentioned before, that we mentioned about asynchronic growth or slow growth, the low basal level of OH, less than 1.2 milliliters per liter. The possible certification possibilities. You have a group of patients that we've just spoken about and the recommendation on the standardization dosage of usage of recombinant FSH factor or together with the recombinant NH, and also in what time, when do we have to stimulate. This is to optimize and to have an effective number of the oocytes. So as the result of today's lecture, it's important to differentiate each patient to pick a standardized approach to the individualized OVAR approach. We are picking the strategy based on the important factors as the antimullary hormone, the number of ventral follicles, but we have to have the results of the previous treatment cycles and all the additional information that we can actually have. We would like to have molecular hormonal markers supposed to be included in the screening process of some categories, and the genetical sequencing and the capabilities of the markers that we have right now that we don't know of. There's so much future perspective. The top approach of the many other approaches will allow us to optimize the response of controlled ovarian stimulation. Thank you so much all for your attention, and we will get to the questions and answers part.
Just a second, dear colleagues. Let me just... Yeah, on behalf of the organizers, there's also a request. Now is the time when you can ask the questions. And let me open this group. I will respond to the questions. So all your questions on this session number 5 can be asked right now. We still have 20 minutes. We are kind of outside our time limitation, but we can now use it for the Q&A. We have a question. Tell us please whether you use LH plus FSH only in patients over 35, and do you have experience of its application with the ovarian polycystic syndrome? Yes, we have the experience of using recombinant FSH and LH in different age groups. Well, most, and definitely it's not the first stimulation of a patient. These are patients in whom in the previous stimulation cycle with only FSG, with the recombinant FSG was suboptimal. After additional tests, we don't check for the polymorphism in all the patients, because yeah, it still is experimental, and also it's very costly test. But we assess the clinical efficacy, the result of the previous treatment, and then in the amended protocol for the next stimulation, we add the LH if the response in the previous cycle was suboptimal. And also these are patients with polycystic ovaries. We have the experience of using LH in these patients, and then the stimulation with jointly FSH and LH is very effective in them. Next question. If you do this, then starting on which day? So if in this patient the previous stimulation was suboptimal, the decision to add LH in the stimulation cycle would be from the first day. If this is the patient in whom during the first ultrasound we see the out-of-phase growth, if it's the patient with the average, the medium level of the AMH about, say, 31, years old with the AMH 2.8, and we have started the stimulation with the dose of 200 IU or 225. Then we expect to see the growth of about 10 to 12 ventral follicles on day 5 or 6 of the stimulation, but then as a result we see only one follicle sized 15 millimeters and another cohort of 8 or 9 millimeters. So if there's a discrepancy over 4 millimeters, then we add to this patient, we add the LH from the day when we have found this result of the ovarian stimulation. But at the time when we will give the next ultrasound examination is short, like in 48 hours we invite her again for the next ultrasound to assess her ovarian status. Next question. What is the maximum dose of gonadotropins that can be used in stimulation? Here I fully support the opinion that has already been given in the presentation. The maximum the dose is 300 international units to start the stimulation. And even if we assess the group of patients in whom we primarily recommended the lower effective dose, but they have a potential polymorphism. Even though we didn't do the sequenation, but we can look at it clinically, then still the 300 international units is the maximum dosage. In young patients with PCOS, with normal BMI, what is the starting dose? The minimal effective starting dose that I have used is 150. I never, I don't like the 100 dose. I had this experience some time ago, but I'm rather thinking in the optimal quantity of the oocytes obtained. So if the patient with PCOS and normal BMI, if we give her a very low starting dose, then we will get a minimum growth further. So there's a practice, there's the recommendation that we start with the lower dose, the 100 IU and the step-up protocol, but still we recruit usually between the 4th and the 9th day. So if we have not started with that, if we haven't launched the recruiting process, then it will be too late to do it later. Then we can only continue growing the follicles that started growing. So if the starting dose is a little bit higher, not super high, but but a little bit higher, like 150. Then the next step, the step down is possible. Even though usually we have the tactics that we can effectively manage a patient on one stimulation dose, but also there are the step down protocols, especially for patients with polycystic ovaries, when we already figure out the main pool of growing follicles, but we never do the step down on the same day we prescribe antagonists, because on day 10 of the stimulation we can see that the follicles which were already growing and we would expect them to be mature when we trigger, they would be not useful due to the lower initial doses of FSH and antagonists. Do you see the need for step-up when you use LH drugs? Yes, this is one of the mechanisms. Mechanisms to do the step-up. For example, for aged patients, or usually when they are kind of 34 or 35. If a patient has started stimulation with 225 units, then we have invited her to the ultrasound, and then we see like 4, 5, 6 follicles growing, and they are kind of 8, 9, 10, up until 10 millimeters. And for these patients, we can take a decision to add pergoveris. Then, if we would analyze that stimulation protocol which the patient brought with her, and then the decision about starting would be pergoveris from day one. But if it's our patient and we just didn't decide on day one because that was the first stimulation cycle, then we add LH when we saw that it needs to be added. Next question. When we apply oral contraceptives, LH can go down significantly. Would you recommend the systemic application of FSH plus LH if previously oral contraceptives were taken? Well, I would respond to this question depending on the age of the patient and the duration of oral contraceptives intake before the planned ovarian stimulation. If it's a young patient and she didn't take the oral contraceptives for a long time, from my experience, it's not really a critical reduction in the LH caused by the oral contraceptives. It would not influence the decision of the beginning of the stimulation, and the main drug. For this group of patients, I would not start the stimulation with the combination. I would use recombinant FSH. But if it's a different group of patients, if it's like a more mature an elder group with a year after the OCs, I would check the basal LH, and depending on the basal LH level, I would decide if I use the combination from the beginning or not. Thank you, dear colleagues, for your questions. This is it so far. Even though now we were supposed to take a break, but we are kind of using this time. We still have like 2 minutes for the Q&A. If you have questions to ask.
Є ще запитання в іншій групі, вибачте, бачу.
Oh, there is another question. Does the quality of eggs depend on the dose and type of gonadotropins? That's a good question. Thank you. We have conducted a study on the quality and quantity of eggs. And, well, how can we assess the quality? We can only assess the morphological criteria of the oocytes. And as of now, we can assess the euploidy, but I want to unveil a secret that we have an undergoing project on the assessment of the euploidy of oocytes depending on the different types of gonadotropins and types of stimulation protocols we prescribe. And I'm looking forward to getting the result of it. We have only just started that project, but that is very, very important because we understand that the level of euploidy of the oocyte varies, and this is a prognostic factor, and it's very important for achieving clinical pregnancy. So yeah, from my prior experience, I would say that recombinant FSH is the most effective in terms of the quantity and quality of getting mature quality eggs. This study was conducted assessing the follicle ovarial index and the ratio of morphological parameters like Q1 plus Q2 as related to Q3. So the best drug for this stimulation is a recombinant FSH for any group of patients.
Ще одне запитання, колеги. Чи вважаєте ви, що чим довше...
Another question. Dear colleagues, do you think that the longer the stimulation is, the better is the quality of the eggs? That's a good question. No. Stimulation is the period which we control and we can influence it. The stimulation is effective when it lasts for 14 days the most. And now we understand why it can be extended. First and foremost, it can be extended through inadequate starting dose of gonadotropins. It can be extended because of mistakes which the patient commits in terms of the dose, the application of gonadotropins. It can also be related to the polymorphism of the recepting genes, and then it's considered more or less physiological. It can also be achieved through like lower quality drug, but usually the optimal stimulation 9 to 12 days, then that is a good stimulation. So now we are over, our time is out, and I thank you for your activity, and I thank you for, like, when you're present here in the studio, when I talk to most of you online, and with some of the colleagues I could talk offline, it gives you this feeling of life, that life keeps on going. We continue staying in touch, we continue communicating, our activities are restored. So I hope we get back to this pre-lockdown period, or that we open new possibilities so that the patients would come to us, so that they would get fantastic results, and so that Ukrainian reproductive medicine would develop. I wish you all good health, stay healthy. I would like to say thanks to Mark Saroma and Sanofarm for this fantastic session, and see you again.
A moment of joy, a dream come true, all pure love, a tiny breakthrough, or maybe a triumph, a constant struggle, a clash of ideas. We can make a difference, create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life.
Ми розпочинаємо наш щорічний симпозіум Української асоціації репродуктивної медицини. Показує досить великий рівень професіоналізму спікерів.
Обсуждению подвергнуты самые актуальные проблемы современной репродуктологии.
So OVARIAN is one of the best opportunity for Ukrainian embryologists and IVF specialists to share their experience.
Сьогодні свято, на яке зареєструвалось більше 500 делегатів, і це дуже добре.
І мені вельми приємно бути тут, в Буковелі, в Україні. Я кожен год приїжджаю сюди.
Кожного року для нас OVARIAN – це унікальна можливість. Можливість зустрітися, можливість поділитися досвідом.
OVARIAN розвивається, крокує вперед.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera for a minute.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life.
Ми розпочинаємо наш щорічний симпозіум Української асоціації репродуктивної медицини.
Показує досить великий рівень професіоналізму спікерів.
Обсуждению подвергнуты самые актуальные проблемы современной репродуктологии.
So OVARIAN is one of the best opportunity for Ukrainian embryologists and IVF specialists to share their experience.
Сьогодні свято, на яке зареєструвалось більше 500 делегатів, і це дуже добре.
І мені вельми приємно бути тут, у Буковелі, в Україні. Я кожен год приїжджаю сюди.
Кожного року для нас ОВАРіан – це унікальна можливість. Можливість зустрітися, можливість поділитися досвідом.
ОВАРІАN розвивається, крокує вперед.
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life.
Начинайте.
Еще раз добрый, уже, наверное, вечер, дамы и господа.
Hello again, ladies and gentlemen. Good afternoon, or even good evening, perhaps. We start the last one, the last but not the least interesting session of the Congress of the Ukrainian Association of Reproductive Medicine, supported by MSD, and it's called Pregnancy Rate, Focused in Details.
Not the least section of Ukrainian Association of Reproductive Medicine Symposium, which is named Pregnancy Rate, Prognosis in Details. So it organized like the two logical parts. The first part is about the ovarian reserve testing. Are we really using the best ovarian reserve tests? And how do we use it? And what can we do better? So some kind of revising and revisiting on ovarian reserve testing. And the second topic will be about the low ovarian reserve, low ovarian response, and what could we do with such a problem. And this, so everybody knows that it's a huge problem to work and to simulate such kind of patients. So the second topic is about that kind of problem, and what do we really have, what evidence we have for this moment about the low ovarian reserve, and some kind of experimental treatments, some tips and tricks, and the newest and the latest evidence on it. And the first lecture Samuel Ramirez-Santos. He's a scientific coordinator and senior gynecologist in reproductive medicine in EVA Clinic in Lisbon, and a well-known expert with extremely high activity in publications on controlled ovarian stimulation, endometrium, and many other topics on reproductive medicine. And today's topic is revisiting the ovarian reserve tests. Is it better now? Samuel, the floor is yours, please.
Nicola, thank you very much for your very kind introduction. It's a pleasure to be in the last session. Unfortunately, it's more difficult to see how many people are participating, but I'm hoping that you are still here for at least a lot of the lectures that I've heard so far have been very, very interesting. Without wanting to delay more your time, I would like to dig in immediately into the topic that we're going to be talking today, which is regarding ovarian reserve testing. And what is the reason why we have ovarian reserve testing? Well, it actually comes from a sequence of what is normally our consultations. And practically all consultations will start more or less the same. The patient will ask you, well, how likely is it that I will have a child? And you're going to scratch your head because you want to give them a good number, but you're always going to tell them, well, it depends a little bit and quite a lot on the number of eggs you have. And then you show some graphs in which you can see that the eggs are very important for cumulative live birth rates. And then immediately the patient is going to ask you, but how likely or how many eggs am I going to have in my case? And well, this is our normal conversation, and this is normally how we speak with our patients, especially when we're talking about IVF. But in fact, when you really look at the data, it doesn't seem that the amount of eggs that patients have and the predictors that we use to detect how many eggs these patients still have predict fertility. And I'm showing you now the fitted values of a study by Heidman, showing you a comparison between the ages and the fitted values for infertile patients and controls. And did it change? And no, if you see the lines overlap quite a lot, and it seems that the ovarian reserve tests for these patients seem to be very similar, both in AMH and AFC. And Steiner also surprised us, the general population, when she was able to show that regardless of your AMH level, the cumulative probability of conceiving is exactly the same after 1 year. So when we talk about ovarian reserve tests, indeed, it is important that patients know that we're not telling them what is their likelihood of conceiving spontaneously, and that it's not actually a prognosticator of spontaneous conception, that it's actually more a prognosticator of our success. And most importantly, what it actually shows is it mirrors what we know is the depletion of the ovarian function and of follicles that we're going to have. And this image here shows you more or less the confidence interval that one can have and the expected modeling of the amount of eggs that women have throughout their lifespan. And if you compare that, for instance, with the serum AMH levels, you will see that it doesn't actually match entirely, but it does kind of show exactly the same pattern in which the number of eggs will start to decrease at around 35 years old, and that there is quite some leeway. There's actually quite a large interval, not as clean as the one that was proposed by Wallace and Kelsey originally. Now, when we look at the tests that we do, most likely we will be talking about AMH and AFC. These are the ones most currently used at this moment. Very seldom do we use FSH as a very reliable indicator at this moment. And at this point, what is important for us to know is how reliable are these tests throughout the cycle? Will they give us any results different if we repeat them over and over again? And when you assess this, it does seem that both AMH and AFC seem to have a more or less reliable outcome when you go throughout cycle number. Most importantly, AMH even has an added value, which it seems to be very similar regardless of the time of the menstrual cycle that you take it. It also seems that you have results that are very, very similar to that extent regardless if you do it in the menses, around ovulation, or in the luteal phase. So the question is obviously, which is better, to do anti-Mullerian hormone measurements or to do an AFC count? The other way to ask this question is, what works better? Is it our laboratory or is it our eyes? And well, both in antagonists and in agonist cycles, it seems like the AMH has a more reproducible result, and that it's actually better to correlate with response than AFC. Not that it's a huge difference, but it does seem like the blood sample seems to work better than our eyes, especially when we're talking in the higher number of follicles that we're trying to count. One works better than the other. Does that actually mean that there is an excellent test and that it works great? Well, yeah, I'm showing you results both with antral follicle count and with the AMH. And it's important to look at how these numbers vary and to imagine that you're talking to your patient about this. So let's, for instance, imagine that your patient has an AFC of 16 to 19, and she asks you, doctor, what does that mean in the amount of eggs that I'm going to have? Well, if you look at this graph here, you're going to notice that you can tell your patient, well, it's extremely likely that you're going to have on average 10 eggs. However, it's very, very reasonable that you have also 15 or also 5. So if you think from the patient's perspective, although we guide ourselves very frequently with AFC and AMH, I think if you think of it as a patient perspective, these are 3 categories of completely different patients, those with 5 eggs, 10 eggs, or 15 eggs, although the test that you used is equally reasonable to assess and predict within the same level. So unfortunately, both for the case of AMH and AFC, it doesn't seem that it's going to be able to give you a precise number and to predict precisely how many eggs you're going to have. And that can sometimes falsely give us an impression that everything is going to go great. So one of the approaches that has been thought is either to test head-to-head one versus the other, or even to test the possibility of performing both tests and tailoring the stimulation that you perform according to both tests. And I'm showing you the results from both Magnusson and from Lee, the first of which was trying to compare AFC and AMH in terms of the number of eggs within the normal amounts and how many were able to come in within the normal amount of eggs that one would expect, so to avoid poor response and hyper response. And you will see that the numbers are entirely very similar, both for the target oocyte retrieval rate and also for the follicular output rate, regardless if you're a person that uses AFC only or AMH only to dose your stimulation cycles. And the other thing was when you try to use them both. And if you look at the results on the graph that I present you here, you notice that there could be maybe a slightly better outcome if you combine AFC with AMH when you perform in the lower range. So it tendentially helps you to predict poorer respond a little bit better, but it's not really that statistically significant for you to be able to show with great evidence that that is the truth. And overall, it seems that the sum of both measurements doesn't work so much more better than just AFC alone. When you want to decide which is the test that you want to do, you're always going to be able to look and want to see the advantages and the disadvantages of each of these tests. And none of them are perfect. You love, and we love as physicians, the AFC because it is very easy to perform and easy to personalize. Also because we can do it in a couple of seconds and have it done in a non-invasive way and have the result immediately. But AMH seems to be well characterized across all reproductive ages, so we can more easily predict what is the regular amount for a person at a certain age. And it also is more consistent, both between the labs and both between physicians and between cycles when we have the attempt that we're trying to do, which is predict our ovarian response. And thanks to its widespread use, it's thankfully relatively low in costs at this moment. When you look at the disadvantages, there are many disadvantages that I'd like to go over with you. And we would like to see now, after this, these time that have passed, do they still exist? And the results that I'm showing you is an adapted version of a review by Fleming that in 2015 was trying to compare the disadvantages of one test and the other. And I would like to see with you, are these still a reality in 2020 or not? Starting with the AFC, one of the main concerns is that it needed to be carried out in the beginning of the cycle, and that could pose a very important problem. Well, I like to show you the study from Debe et al., in which she assessed sequentially in both times of follicular phase, early and later on, also peri-ovulation and also in the luteal phase, to try and assess indeed how much does the AFC vary. And if you look at this graph, you notice that it doesn't vary that significantly throughout the menstrual cycle as one originally thought. So it seems that with the increments and the improvement of our machines, we're getting better and better at detecting the AFC. However, if even this slight variation of 1 or 2 eggs is a problem for you, there is one way for you to establish what seems to be a steady state antral follicle count, and that is by assessing the eggs that are between, or the follicles that are between 2 to 6 millimeters. Those seem to be very stable throughout the cycle, and it's only the ones that are larger than 6 millimeters that tend to vary between 5 to 7 throughout the cycle. And if you continue to assess maybe AFC throughout different days of the cycle, both peri-ovulatory and late follicular and luteal phase, what you notice when it has to do with predicting response is that the sensitivity and specificity seems to be very similar. So that is why you have ROC curves that seem to go on top of each other regardless of the day that you are measuring. So it seems like the better the results got and our machines got, the better that we were able to predict. And it doesn't anymore need to be compulsory that you perform it in the beginning of the cycle. And there is also another questions that have been made to us, which is, and when we do it in different phases and with different people, will we be getting the same results in terms of ovarian response? And what we notice is when you compare the same patient before, in the beginning of the stimulation and the end of her stimulation, you tendentially get the same response of normal, low, and high ovarian response when you test them. And you also, by the study of Subira, will be able to notice that actually we don't disagree with each other as much as we really think. We actually tend to agree with each other quite a lot with very high kappa or predictability values. So when we look at AFC, it seems that with time, there are some things that are now better and that are not so much of an issue to use. Let's go now to the disadvantages of AMH. Have they been ameliorated or not? Well, the test used to be very labor intensive, and that's one of the things that were described quite a lot. And there was no real standardization across the assays. You could have results of very discrepant level. And the most important, however, was actually the lower threshold, which is you were very difficult at the beginning of the first generations of the test to have actual levels of the very low end, which is the one that concerned us the most. And finally, there was also a strong concern that many potential confounders could artificially push the levels of AMH above and below. Now, when we look at the newer assays and at the newer tests, you're actually seeing that these results are changing quite a lot. First of all, you have higher assays or higher sensitivity assays that are actually capable of noticing even 500 picomole of AMH circulating. So these are very, very low levels, and they're actually able to detect within those with poor response if there is any potential for development or not, which something before was more difficult when we had those assays that just said below 1.1 and really made our life more difficult. And more important is we even also have those that are highly sensitive and also at the same time fully automated, showing us better results than even AFC. And that is one of the things that is going into the advantage of AMH, is that we're actually managing to make the exam easier and less labor intensive. Looking into the confounders, well, at the time that Fleming was proposing that there were a lot of potential confounders, there were many patient characteristics, reproductive factors, and lifestyle factors that made AMH levels vary quite significantly. Let's look a little bit more now with the new data that we have. Well, when it comes to ethnicity, it doesn't seem like Latinas, Black, or Chinese women now have any more abnormal results with the newer results. The BMI that one patient could have indeed does seem to lower AMH, and it's important for you to know that it does have that effect, but it doesn't seem to be lowering the overall live birth rates. Okay? And then when it comes to vitamin D, one of the co-chairs today and co-speakers today, with other groups as well, were able to prove that low vitamin D doesn't seem to affect or to artificially lower AMH results. While subclinical hypothyroidism, which nobody knew about, it actually now seems to be associated with overall lower AMH levels. Coming back to contraceptive use, you will see that it's normalized after 2 months. And this is something that as well, we didn't know how quickly the results would come back to normal. And otherwise, the results are more or less similar to what we had from the past. So the confounders over time have gotten better, contrary to what we thought, and so are the exams now much less labor intensive and more standardized in comparison to each other. There is still, however, some potential confounding that we need to take into consideration when we are assessing a patient exclusively via AMH. What about the question when these values don't agree? Imagine we have a very high AFC and a very low AMH. Who is the one that shows you more true values? Well, the trouble of this problem was actually assessed by Lee in 2014. And what you will notice by this graph is that it seems that as you go from the left to the right, which is assessing AFC, going -6 to 6 to 14 and more than 14, the line doesn't grow as much as it does increase when you look at the different AMH levels. So it seems that when you have discordant values, the truth will be more or less in the middle, but you should rather consider to trust more the AMH level when you have discordant levels, because it seems to predict better, not only the number of oocytes retrieved, but also better the cumulative live birth rate that the patients are going to have. And this is not the only study. More recently, Lingon as well tried to look at normal AMH and FSH levels and to see if the results were completely different or similar. And what he noticed was that the most important prognosticator factor was AMH as well, that the lower your AMH, regardless of normal or elevated levels of FSH, the pregnancy rates and the cancellation rates were higher in this group of patients. So at the end of the day, I'm just another person telling you that the ovarian reserve tests are a little bit better, but they're still not helping us that much. So now what? What is the usefulness of this talk if they think are a little bit better, but we need still these tests all over our life? Well, and throughout our day. Well, it's important for us to know that ovarian reserve tests are a really quite good idea for what we are really, really worried about, which is excessive response and poor response. So that is good news, that it might not be able to tell us if the patient's going to have 7 or 9 eggs, but it's a quite good prognosticator, or these tests are quite good to tell you if the patient is going to have 22 eggs or has a high likelihood of having 1 or 2 eggs. And if you combine this, especially with age, you're going to have a very, very good prognostic factor and potential to be able to see this, as shown by the study of Brew et al. In 2013. Another thing which is important for us to know is that we can't really blame ORTs for everything. So even if the result is different, and even if indeed the patient had less or more potential with her ovarian reserve tests, it is important for us to check that when we look at every single potential variable that could be put into a cycle success, the type of practitioner that did it, the type of drug that you use, if you had various stimulation protocols performed before, various diagnoses, the BMI, all these changes, what you notice is the top part, which is looking at the dosage and the type of protocols, well, it's actually only responsible for around 20% of the variability of a whole cycle. Everything else is responsible for the grand majority of variable results that you find with patients. And it's not just about the stimulation protocol. What can we do instead to predict better the outcome of our patients? Well, there are three possibilities. You could check your forte, you could maybe test receptor variants of FSH and LH, or you could try and do something better, like check other types of serum metabolites. Well, with the AFC and the forte, there is indeed a lot to gain. And what you do by forte is by measuring the AFC or antral follicle count that you have in the beginning of your cycle, and then you put that as a quotient of the total follicles that you have at the end that are larger than 16 millimeters. And for instance, in a normal responder, what you expect is that around 70% of the eggs that are available, or follicles available to stimulate, will eventually have a response that will be adequate to collect the egg. Why is the forte important for you? Because it allows you to distinguish between patients which are expected poor responders, those in which you see a poor response from the beginning and you have a reasonable response to the ovarian stimulation, versus those that are unexpected poor responders, those that had multiple eggs, potential follicles that you could stimulate, but at the end of the day, you notice that your stimulation was only able to get, let's say 40% of the potential eggs that were there in the beginning. Forte will allow you better to know how was your stimulation when you tailored it to your patients. Much better than AMH and AFC to that extent. What about the FSH and LH receptors? We've had a lot of discussion on that, and there are some studies on that topic. First, looking at FSH receptor genotypes, noticing that in some of them, you would require more ampules to have a better response. And you saw the same type of results with different LH genotypes, which certain of them were actually associated to more FSH results or consumption as well. Well, to that extent, I would also like to tell you that FSH and LH gene mutations don't seem to be associated with differences in nor the AMH or the FC. So there would be a strong consideration that you could be missing these results if you wouldn't test for these genetic variations. I would like to talk to you about the new study, however, that Nikos Polizos presented in 2020. It was a very interesting study that tried to compare those that had low, normal, suboptimal, normal, and high response, and assess in these patients if there were differences in the FSH receptor mutations, and they really weren't. So, in fact, none of these SNPs that were tested showed any difference when you looked at response. So, one of the potential arms that we had and that we thought that could maybe help us in this more recent study didn't seem to be associated with a difference. So the last thing that we could consider is to investigate other type of metabolites that we could use during the cycle to tell us, do we have a likelihood of having a better response or not? And I'm showing you a study from the group in Brazil of Borges, and what you notice are some strange numbers here. The numbers are the metabolites that were being measured in the serum, and most of the metabolites, when they are measured by the omics generation, so by these sorts of biomolecular tests, they are given a certain number to be able to assess. And what you notice with the different colors are the mean concentrations associated to poor response in red, normal response in green, and elevated response in blue. And what you will see here is a high response in red and poor response in green. That's what I wanted to say. And what you notice here, indeed, is there are various molecules that you could measure which show robustly the possibility that your stimulation is not going as great as you want. These are still very early days for these type of assessments, But these are things that we need to keep in mind of possible alternatives we could use that could make us help our patients better in the near future. And just as a reminder, the area under the curve for these studies were almost 100%, which is a huge result. And it's a really, really important way to predict the outcomes. But again, it's a small sample and still very early days. So in the terms of take-home messages, I would really consider you not to accelerate or refuse treatment to patients based solely on their ovarian reserve tests. We know that it's not a prognosis of fertility. Patients should be aware of the results, but it's not a reason to go so crazy and to accelerate the results, to accelerate treatment just because of those results. Also, ORTs might be just only a little bit better, but they were really doing their job for what really mattered quite well already, and they really make our life easier to tailor stimulation for our patients. Focus has now changed and deviated from looking at ovarian reserve tests and more as better ovarian response predictors to whether should be done during the cycle, which could maybe help us do adjustments during the cycle. And that was basically the presentation I wanted to hold with you today. Thank you very much.
Thank you very much, Samuel. And so we have a little bit time. You say 15 minutes, so yeah. Everybody. So we can start our discussion, I think, from this point, because at the end of the section we will have 30 minutes of discussion, I think.
Yeah.
Sorry, I need to switch on my video. So, yeah. Okay. So we can start now. I don't know whether Pedagogy is already joined us or not. Maybe not.
No, it seems like he hasn't. So indeed, sorry for that. I did finish.
No. That's okay. let's start. Let's start to discuss, because I think it's even more interesting to discuss. So, of course, we know that we cannot predict ovarian response with very high level of specificity and sensitivity, but you show very nice picture about the many different situations and variations which we can have different BMI, different age, and of course some other difference between two cycles, because sometimes you have the same patient in a very short period of time, 3 months after the previous stimulation, and she could switch from the medium forward to high forward, and we never know what happened with her. What do you think? What can happen in a short period of time in the same patient with the same kind of stimulation, same dose, everything is the same, and the different results of stimulation?
Yeah. So one of the reasons that might concern us per time is that indeed that is happened. So it's possible that you could be concerned that what is happening to you and to your case is that patients are having very different responses due to an acceleration of the depletion of the eggs that you had there. And well, that could be the case, but unfortunately, it's not very common that you have studies showing that the same stimulation cycle is getting worse results and different results. And well, there are some studies actually showing and assessing, comparing 2 stimulation cycles, and you can have very discrepant results without that meaning that there is a problem of the patient. And maybe it's just an issue of that cycle, that the variability wasn't as great as you wanted, or the outcome wasn't as great as you wanted. I personally had a patient that for cancer reasons did 5 cycles in a space of 7 months, and she always did exactly the same stimulation, and she had between 5 eggs and 19 eggs. and she did in every single cycle exactly the same stimulation. So it's not only about stimulation, it's also about the cycle, the duration of the cycle. There are many factors into play. I don't believe that it's just the AMH that went down. It's mostly the forte can be varied. And that is actually the concern that we have. It's that we need to admit that, that ORTs are limited in their response and the information that they give us. And what we need to focus is to look at how we can change our forte and to obtain better results.
Great, thank you. So I can see Professor Panagiotis Drakopoulos joined us.
Hello, Sam.
Hi. And it's a pleasure to see you on our meeting, of Ukrainian Association of Reproductive Medicine. And thank you for opportunity to hear from you on so interesting topic for all of us, of course, low ovarian reserve. This is the most interesting topic, I think, in all reproductive endocrinology. So let me introduce you to our auditorium, Professor Panagiotis Drakopoulos. He's visiting professor and senior fertility specialist. He's working at the Center for Reproductive Medicine in Free University of Brussels in Belgium. And his research focused on poor ovarian responders and strategies to improve outcomes in such patients, and many other topics in reproductive medicine. With numerous articles and extremely high citation indexes on ResearchGate. So, Panagiotis, the floor is yours, and the topic of the lecture, low ovarian reserve, latest evidence on experimental treatments.
Okay.
Ну що ж, дякую, колеги, за таке прекрасне представлення. Щиро радий бути доєднаний до вас, навіть якщо це і віртуально. Сьогодні хотів поговорити з вами про дуже цікаву тему, і ви правильно її назвали. Це низький резерв яєчників, останні дані. І це тема, посправді, яка дуже багато статей має, досліджень і всього іншого що цього, тому вона турбує наші серця і уми. Ось представлення, чи є в мене конфлікт інтересів. Далі. Вам відомо, що низька відповідь, вони все-таки залежать від дуже багатьох факторів. І тут нам відомо, от мій гарний колега Ніколас, опублікував статтю з Брюсселя, він також.
Using the literature for poor responders, asking whether there is any light at the end of the tunnel. And the same year, Estre came with the famous Bologna criteria in order to refine this population and make clinicians be able to perform studies. However, I would say 9 years later, in 2020, we are still wondering whether Bologna criteria were the solution and whether Bologna criteria brought our patients out of the tunnel into the light. And I think that it's not by chance that approximately 50%, even more, 51% of studies performed after the introduction of Bologna criteria did not use them during the phase of the clinical design. Regarding Bologna poor responders, live birth rates have been described to be very low. This is a series coming from my center in Brussels showing live birth rate per cycle of 6%. And okay, one might say that you're not very good doctors, you don't know how to do reproductive medicine in Brussels, that's why you have so bad results. But unfortunately, these results were replicated later by other investigators showing live birth rates that did not go over 10%. But it's not only about fresh live birth rates. If we compare also cumulative live birth rates among different Bologna poor responders, results are different. For instance, this is a study that we did last year, where we compared cumulative live birth rates, so the chances to have a baby either in the fresh or in one of the following frozen cycles among different Bologna criteria populations. So you see pattern 1, 2, and 3 were Bologna poor responders that were old, above 40 years of age, while pattern 4 were young Bologna poor responders, so patients below 40. And if we take a look at the results, we see that pattern 4, so the young Bologna poor responders, had significantly better prognosis, so significantly higher cumulative life death rates compared to the other groups, something that, of course, it's not surprising. So given the limitations existing with Bologna poor responders regarding the prognosis of this population, a group of endocrinologists, the Poseidon group, came in 2016 with a new classification, the so-called Poseidon classification that I'm sure that you know very well. And the advantage of this classification is that it takes into account different parameters that are very important for the clinical prognosis of poor responders. So they take into account age, AMH and AFC, and also the number of oocytes in a previous cycle. And as you may see, based on the Poseidon classification, we have 4 different groups. So group 1 and 2 are patients with normal ovarian reserve markers, so normal AMH, normal AFC, that differ according to age. And as we're going to see later, these are the unexpected poor ovarian responders. While in group 3 and 4, we have patients with low AMH, low AFC, that again differ according to age. And when I first took a look at this publication, I said, why did they choose 35 and not 36 or 37? Well, the reason is quite simple. We know very well that after the age of 35, there is a steep, significant decrease in the euploid probability. So in the probability to have a genetically normal embryo. So this is the main reason why they chose the cutoff of 35. So as we said before, group 3 and 4 are the expected poor ovarian responders, while in group 1 and 2, we have the unexpected or suboptimal responders. And we do care about these patients because they represent approximately 50% of patients that you see in your everyday clinical practice. And it depends, of course, on each county. For instance, in Greece, where I work now, it may be even more than 50% because the mean age at birth at Greece is 32, 33. So we see that we do care about the patients and we need to treat these patients if we do IVF. Anyhow, either we talk for Poseidon group 1 and 2 or 3 and 4, our goal, our aim should be to try to increase the number of eggs. Why? Because we have evidence from this landmark paper by Sunkara from the UK, showing that if we manage to increase the number of oocytes, this has a significant impact on live birth rates. But this also holds true not only about the general IVF population, but also if we take a look at poor responders, you see that there is a significant association between the number of oocytes retrieved and live birth rate per cycle. So let's start now with group 3 and 4, which are the expected poor ovarian responders. And we're going to talk in the next slides regarding different treatment strategies that we can apply to this indeed difficult population. So let's start with the protocol that you should use in an expected poor ovarian responder. Should we go for an agonist, antagonist, or sort of flare-up protocol? Well, we have evidence from this very nice randomized study done 6 years ago, where expected poor ovarian responders were included, and the authors of this study compared the long agonist, the antagonist, and the short flare-up protocol. If we take a look at the results, it seems that if we compare the agonist with the antagonist, there is no significant difference in the number of oocytes retrieved. However, if we compare the agonist with the short flare-up, it seems that the agonist performs a bit better. So the conclusion of this study is that for your expected poor ovarian responders, you could use either the agonist or the antagonist. At the end, the number of eggs that you are going to collect at the time of the pickup will be the same. This is another meta-analysis this time from 2017 from Labalk from the Netherlands, showing that indeed ongoing pregnancy rates are similar between agonists and antagonists. And 2 years ago, we performed in our center another retrospective study in Bologna poor responders, where we evaluated the different downregulation protocols in patients having a stimulation with corticotropin alpha. As you know, corticotropin alpha is a long-acting gonadotropin that sustains follicular development for 1 week. So the patient does just one injection and then does not need other injections for the next 7 days. But I will talk later about this gonadotropin. So in that study, we compared the 3 protocols in Bologna poor responders. And what we found was that live birth rates, fresh live birth rates, and cumulative live birth rates did not differ among the different protocols. So, in fact, these results confirm the results of the previous studies. However, we have this publication from 2018, but it's the only publication where the authors compared the agonist and the antagonist in Poseidon group 3 and 4. So they found no difference in Poseidon group 4. Just to remind you, in group 4 we have poor responders, so patients with expected poor ovarian responders, so patients with low AMH and low AFC that are above 35. And so in that group of patients, it seems that there is no difference. But if we compare the agonist with the antagonist in group 3, so in young expected poor ovarian responders, so in patients below 35, it seems that the agonist results in better live birth rates. However, the rationale behind this finding, I would say, is questionable, and we need more studies in order to see whether these findings hold true, and see if there is a difference between agonist and antagonist. If you want my personal opinion, I don't think so. I don't think that you will find a difference if you compare the 2 protocols in all of Poseidon classifications and groups. Let's now move to stimulation challenges. In challenges that you may encounter when you stimulate your patients. And let's start by the type of gonadotropins. Does the type of gonadotropins play a role? Well, based on the guidelines of ESTRE that were recently published in Human Reproduction Update, it seems, Human Reproduction Open, it seems that there is no strong evidence that one gonadotropin is superior to another. However, we know that corticotropin alpha, as we said before, is a long-acting gonadotropin, and studies performed in normal responders have shown that corticotropin alpha may result in a better follicular recruitment with an increase in the number of oocytes retrieved. And 3 years ago, we evaluated corticotropin alpha in young Bologna poor responders. So when we compare corticotropin alpha with recombinant FSH, we found no difference in ongoing pregnancy rates. However, we found that the number of supplementary frozen embryos was significantly higher in the corticotropin alpha group. So, and this is important because if you have more frozen embryos, then you increase the chance that your patient gonna get pregnant at the end of the IVF cycle. Let's now move to the dose, to the maximal gonadotropin dose that you should use. I would say that things here are quite clear. Please do not go over 300 units per day. In that study, authors compare 300 units per day with 450 and 600, and they found absolutely no difference in fresh live birth rates. If you have a patient with an AFC of 1 or 2, even if you bombardize the ovaries of these patients, unfortunately, you cannot generate oocytes. So please do not use very high doses, because sometimes we see patients treated in other centers with a dose of 600, 700, or 1,000 units per day. Natural cycle IVF. This is another challenge. Should we perform natural cycle IVF in our expected poor ovarian responders? Well, the question is, how can a natural cycle be an option if we all agree that the number of oocytes retrieved is very small. You will have one or maybe two oocytes. And indeed, in that study, the authors found that fresh live birth rates are quite low, irrespective of the age of the patient. So I would say that the conclusion of this study is that the natural cycle is not an option in expected poor ovarian responders. On the other hand, a managed natural cycle could be applied for some Bologna poor responders. And in that study that we did last year in Brussels, we compared managed natural cycle with high dose ovarian stimulation in advanced age Bologna poor responders, so in patients above 40. Just to remind you, in a managed natural cycle, we just give a very small dose of gonadotropins when we have a dominant follicle at 12 millimeters. So, and because we think, maybe it's not true as well, that this small dose of gonadotropins may increase oocyte and embryo quality. So in that study, we compared MNC with high dose ovarian stimulation, and what we found was that ongoing pregnancy rates were similar. Something that also was expected because we talk about advanced age Bologna poor responders. So I think that in your advanced age Bologna poor responders, so if you have a patient of 41 or 42, you can either perform an MNC, a managed natural cycle, or go for a high dose of ovarian stimulation. Maybe an MNC financially would be a better option for your patient. But anyhow, I think that MNC could have a role in specific circumstances. Youssef from Israel, in that very nice non-inferiority SAT, also compared 150 units in an antagonist protocol with 450 in an agonist protocol. As you may see, the sample size was quite large, almost 400 patients included. Again, expected poor ovarian responders. And what they found was that the ongoing pregnancy rates were similar between the mild stimulation approach and the conventional ovarian stimulation approach. So I think that mild stimulation may be an option for, especially for expected poor ovarian responders, also for patients of advanced age, and it's something that is also suggested if you take a look at the guidelines of ACRM regarding poor responders. Dual stimulation. This is another interesting concept. You know very well, I will not go into details, that during a menstrual cycle we may have 2 or even 3 follicular waves. And the story started by Kwang with the famous Shanghai protocol, and was further developed by Ubaldi. So what is this dual stim? So you start your stimulation in an antagonist protocol, you trigger with an agonist, you do your pickup, and a few days later you restart with the same stimulation protocol. So in fact, you have 2 stimulations in a short time interval, and the idea is that if you do 2 stimulations in a short time interval, is that at the end you will increase the total number of oocytes and the total number of embryos. And what was shown by Ubaldi was that if we compare the luteal phase stimulation with follicular phase stimulation, there is no difference in euploidy rates. So that means that if you do these 2 stimulations, at the end you're going to accumulate embryos, and you will have a higher number of genetically normal embryos. And that was shown also by a study done by my good friend Alberto Vaiarelli from Italy. So Alberto Vaiarelli is also the Ubaldi's group, showing that with the dual stim, we increase the percentage of patients with at least 1 euploid embryo, and also the live birth rate. Another question is, should you do ICSI if you have a poor responder? I think this is, in any case, in Greece, but also in Belgium as well, it's quite common. We do have a patient with 1, 2, or 3 oocytes. We do ICSI. Why? Because we're afraid of fertilization failures. And in 2019, we compared fertilization rates, but also fresh live birth rates and cumulative live birth rates that you don't see in this picture in different ovarian response groups. And what we found, at least for poor responders, was that there is absolutely no difference in fertilization rates. So if you have a patient with non-male factor infertility, please do not do ICSI just based on the number of oocytes. ICSI is only for patients with severe male factor infertility. PGS or PGTA, should we perform PGTA in our expected poor ovarian responders? Well, it seems that there is no benefit. Anyhow, the number of patients that are gonna undergo biopsy at the stage of blastocysts, if we talk about a poor ovarian responder, this percentage will be very low. So actually, there is no reason and no indication to perform PGTA, given that it seems that it does not improve live birth rates in expected poor ovarian responders. Let's now move to another big chapter, which is the adjuvant therapies. And I think here there are a lot to be said. And I think there is a very big gap in the literature. And let's start with the androgens. And of course, I will not talk to you about DHEA that maybe you see everywhere in the market. Why? Because DHEA is a pre-androgen that needs to be converted to testosterone in order to act. And although in the beginning we had some case reports, some case series showing a benefit of DHEA, later randomized studies did not show any benefit. In fact, did not show an increase in ovarian markers, ovarian response in poor responders, normal responders, or women with ovarian insufficiency. And furthermore, it seems that DHEA does not increase testosterone in the follicular fluid. This is another very nice opinion paper by Pedro Montoya, published last year, where in this table you may see all the randomized studies. I talk about randomized studies, not retrospective studies or prospective uncontrolled studies. So I talk about randomized studies. If you take a look at these randomized studies and the effect size, you may see that in most of them, the confidence interval includes the one. That means that if you compare the DHEA with the placebo, there is no difference in live birth rate. So in fact, there is no reason to give DHEA to your poor responders. On the other hand, testosterone could be an option, and this is a recent meta-analysis showing that indeed testosterone may increase pregnancy rates in expected poor ovarian responders. But always, when you have a meta-analysis, you need to check for two basic things. First of all is the number of studies. So as you may say here, we have only 5 studies. And secondly, it's the number of patients. So you see here, 272 in one group, 185 in the other group. So how can we have robust evidence if we have such a low number of studies and such a low number of patients? And in all these studies, the duration of testosterone administration did not exceed 21 days. But from a physiological point of view, this is wrong. Why? Because we know that androgens act during the early developmental stages, so in the preantral stage. And if we take into account that these follicles need approximately 2 months to go to the antral stage, if you give testosterone for 10 days or for 20 days, you cannot have a benefit even if there is one. And this is the main reason that my group performs one of the largest studies in Bologna for responders, evaluating testosterone and the role of testosterone. And in our study, we give testosterone for 2 months before starting ovarian stimulation. I think that it will take a while in order to have the final result, because as you know very well, it's not easy at all to recruit patients, and especially for responders that want to get pregnant yesterday. Growth hormone, another adjuvant therapy. and you know very well that we give growth hormone. Personally, I don't give, but the rationale is that growth hormone may increase IGF-1 and IGF-2, and this plays a role, site quality, blah, 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 blah. Again, we have the meta-analysis from the Cochrane group this time, 10 years ago, showing that growth hormone could increase eventually pregnancy rates. Again, not a lot of studies, again, low number of patients per group. And I think it's not by chance that Norman from Australia in 2016 presented the results of a randomized study that was terminated early. This is a limitation of that RCT. But anyhow, after including 130 Bologna pool responders, the authors found no significant difference in live birth rates. That means that growth hormone probably does not offer any benefit in your expected ovarian responders. There is a more recent RCT showing that it's not only that does not offer any benefit in fresh live birth rates, but also if you compare cumulative live birth rates in patients having growth hormone, it seems that there is no difference at all. Let's now move to experimental treatments, and I will talk now about experimental treatments in expected ovarian responders and then in unexpected ovarian responders. It's true that most of these treatments have been evaluated in the expected ovarian responders. And let's start with EVA. EVA is the in vitro activation of follicles, first introduced by Kayamura in 2013. So in a few words, your patient needs to undergo laparoscopy in order to remove her ovaries. And then the ovaries need to be fragmented, so there is a disruption of the hypo signaling. Then these fragments need to be cultured, and the authors use some stimulators. Then we need to perform another laparoscopy in order to put back the ovaries. And the woman needs to undergo IVF. So I would say that it's rather a complicated procedure. And Suzuki in 2015 presented the results of 37 patients with ovarian insufficiency that had undergone EVA, in vitro activation of follicles. And the authors found that the number of patients with oocyte retrieve was 16%, so I would say it's rather good for patients with ovarian insufficiency, and some of them got pregnant and delivered. However, following these publications, we had some concerns that were raised because some other scientific teams found that the development of growing follicles following EVA may be compromised. This is another report, and this made the initial investigators, so Kayamura and the others, to reevaluate the procedure to see that maybe there is a mistake somewhere. And recently, so in 2020, Kayamura published the results of EVA, but made in a drug-free way. So in fact, there is no this stimulation during the culture of the ovarian fragments. So as you may see, he included 11 patients with poor responders, and here is the difference between the first strategy and the second strategy. So the drug-free strategy. In the drug-free strategy, the fragments are returned immediately back to the woman's belly. But again, the woman needs to undergo laparoscopy. And it seems that following drug-free EVA, this may be beneficial for AFC, but also for number of oocyte retrieved. As you may see, Kayamura found an increase in AFC before EVA and after EVA. You see that globally, in general, the numbers are higher, as well as in the number of oocyte retrieved. It seems that patients had more eggs after EVA. But again, we talk about only 11 patients, and I would say that the evidence is very weak. Acupuncture. I see everyday patients in my office saying, "Doctor, can I have acupuncture?" Well, and the answer is clear. Of course, you can have. Okay, it may help you psychologically, but of course, it will not increase the chance to have a baby. This is a meta-analysis from last year showing that acupuncture compared to control offers no benefit. So yes, you can. I mean, you can propose it to your patient just for psychological reasons, that you should clearly tell her that it will probably not increase her life birth rate. PRP. This is another strategy that was let's say introduced in our field from some of my colleagues here in Greece, and we still receive phone calls from all over the world saying, "Do you do PRP in your center?" Well, I need to start by saying that the evidence is again very, very weak, and is based only on some case series, some case reports. For instance, this is a case series from 2019 with three poor ovarian responders, and the authors found that after PRP and a 3-month interval, there was a significant increase in AMH, and some of these patients managed to get pregnant. So I think that for now, absolutely we need more evidence before implementing PRP and before suggesting PRP to our patients. Stem cells, another experimental treatment in expected ovarian responders, and the group from Spain of Antonio Pelletier from IVI did this technique in 17 poor responders. So the idea is that you get bone marrow stem cells, you isolate them, and then you inject them to the ovaries of the patient. So this is the so-called autologous ASCOT, the so-called autologous stem cell ovarian transplantation of bone marrow derived stem cells. And the authors found an increase in AFC of these poor responders, and again, some of them, 5 out of 17 got pregnant, 2 after IVF, and 3 had a natural conception. Again, we talk about 17 poor responders, and we need undeniably, I would say, more evidence before proposing this to our patients. Let's now move. We talk about expected poor ovarian responders, the studies made on expected poor ovarian responders, and of course, Bologna poor responders are expected poor ovarian responders. Let's now move to unexpected poor or suboptimal responders. Just to remind you, we talk about group 1 and 2 based on the Poseidon classification. And in order, before talking about unexpected poor ovarian responders, we need to make the difference between ovarian reserve and ovarian response. I think that you are familiar with this term, the follicular output rate. So what is this follicular output rate? Let's say we have a patient with a good ovarian reserve, an AFC of 15 or 14, that ends with a lower than expected number of preovulatory follicles. So in that case, the response of the patient is rather bad, because the initial ovarian reserve was good, but at the end, we did not manage to get a good number of big follicles. On the other hand, we may have a patient with a low AMH, a low AFC, let's say an AFC of 4, that ends with a low number of preovulatory follicles, but it's expected based on her AFC. So in that case, the response is good because we managed to get all the follicles that initially were existing. So the follicular output rate could be defined as the number of preovulatory follicles divided by AFC multiplied by 100. And follicular output rate is a very good marker for the quality of our response, because in the first case, we have an unexpected or suboptimal poor responder, while in the second case, we have an expected poor prognosis patient, so it's group 3 and 4 that we talked earlier. And why do we care so much about these patients? So we care so much about these patients because, as we said in the beginning, the number of oocytes plays a crucial role. And for instance, if we have a patient with 4 to 9 oocytes, this patient will have significantly better prognosis compared to a patient with 1 to 3 oocytes, and a significantly worse prognosis compared to a patient with 10 to 15 oocytes. And what can be the cause of this unexpected or suboptimal ovarian response? Well, there are different theories. Maybe we did not stimulate enough our patients. Indeed, if we give, for instance, in the place of 150, we give, let's say, 75 units per day, it's normal that probably the response will not be that good. Maybe there are genetic factors. You know that there is now the story of polymorphisms in the receptor of FSH, and it seems that patients that have polymorphisms in the receptor of FSH may respond suboptimally following ovarian stimulation and may need higher doses in order to have a good number of eggs. A third explanation could be a problem of asynchrony in the follicular development, and of course technical issues. For instance, if you have a very fat patient, you may have technical difficulties in retrieving her oocytes, so at the end the number of eggs will not be that good. But anyhow, what we care about is how we can improve the outcome of these patients. And one option, and I think that everybody does, every specialist, if he or she has a patient with a suboptimal response, the second step will be to increase the dose in a second cycle. But this is exactly what we showed 2 years ago. So in that study, we evaluated the second cycle of 160 patients with an initial suboptimal response, and we evaluated the second cycle of patients that, of course, did not get pregnant in the first cycle and had the second IVF cycle performed in time interval of less than 12 months. And all these patients had either the same or a higher dose, initial dose of recombinant FSH. As you may see in the results, there was a significant association between the starting stimulation dose and the number of oocytes retrieved. And in fact, we found that if we increase our initial dose by 50 units, this may result in 1 more egg, something that is very important for this poor prognosis population. Another option, please use more potent gonadotropins. You should use recombinant FSH. And why you should use recombinant FSH? Because we know that recombinant FSH results in more oocytes compared to HMG. This is a meta-analysis from Santi in 2017, showing that indeed the number of oocytes is higher with recombinant FSH compared to HMG. Corifoltropin alpha could be also an option because, as we said before, corifoltropin alpha also results in a higher oocyte yield. So I would say that if you have a patient with an initial suboptimal response, what you can do is either in the second cycle increase the dose or use a more potent gonadotropin, either recombinant FSH or corifoltropin alpha. Dual stimulation. Dual stimulation could also be applied in suboptimal corresponders. For instance, you have a patient with a suboptimal response. You don't need to wait, let's say, 1 month before starting the new cycle. You can just go to the second cycle immediately. I mean, immediately after a few days, in order not to lose time. And let's now move to the experimental treatments of unexpected ovarian responders. We don't have a lot. In fact, what it has been tested is the coenzyme Q10. So that in this, if you know, I mean, just to let you know, the coenzyme Q10 acts as an antioxidant by inhibiting the DNA oxidation. So it acts as a mitochondrial booster, let's say. And we have this randomized study, the only randomized study done in 2018, published in 2018, where the authors evaluated coenzyme Q10 in Poseidon group 3. So in patients with an expected ovarian response that were younger than 35, and they gave coenzyme Q10 for 60 days. As you may see, what they found was that if we give coenzyme Q10 for 60 days before starting stimulation, the number of oocytes retrieved may be higher, and also the number of high-quality embryos is higher as well. So I would like to reach the conclusions of my presentation. I think that Poseidon classification is a step towards the right direction, but of course, although there are many strengths and opportunities, weaknesses and threats do exist. For instance, I'm not sure that all clinicians agree with the Poseidon classification. I would like to have your opinion. And also, we need studies because, okay, it's good to have the classification, but we need also studies in order to test, in order to evaluate different treatment modalities. Actually, we have very, very few studies done in Poseidon for responders, and it's something that we need to take into account, especially because the recruitment of poor responders is by default quite difficult. So I want to see in the future how many studies in Poseidon for responders gonna sort and how many of them gonna show something. So regarding expected poor ovarian responders, I would say please you can use either the agonist or the antagonist protocol. Please do not go over 300 units per day. Mild stimulation may be an option for some patients. We need more evidence for duostim, growth hormone, and testosterone. ICSI should be applied only in case of male factor infertility, and experimental treatments, although they are promising, we need more prospective studies in order to implement them into our clinical practice. Regarding now the unexpected poor ovarian responders, FORT is a very good marker for the quality of our response. The nature of unexpected poor ovarian response merits further investigation. Some of the options that we have is to increase the initial dose, to use more potent gonadotropins like recombinant FSH and coryphoprotein alpha, or maybe go for duostim. And pharmacogenomics may be the future. So in the future, maybe we can do a blood test if the patient has a polymorphism, and then apply the correct dose or the correct gonadotropin. I would like to thank you very, very much for your attention.
Thank you very much. Thank you for your wonderful lecture, and it's extremely important to have such a sheet of paper on the table with 4 squares, expected, unexpected, and age, 4 categories of poor ovarian responders according to Bologna criteria, with the number of options which we could choose to try to do our best with that kind of patients. And now we have time for Q&A section and for discussion. And we have some questions already. And I want to start with very, very, very simple question. It was a little bit surprising to hear from you, Panagiotis, about an ICSI, because it becomes routine to do ICSI for everybody. I don't know how in Brussels, maybe you do a little bit more. But what could you say about your practice?
As I said before, I agree. Unfortunately, we do ICSI for everybody because we are afraid of fertilization failures. Actually, we have also the randomized study from Vietnam showing no benefit of ICSI. In Brussels, we used to do ICSI in poor responders. Now in Greece, also we do ICSI in poor responders, but there is absolutely no evidence. There is no reason to do ICSI. I don't know, maybe we need more studies so that makes clinicians reevaluate why they should not do ICSI. Because also we need to take into account the cost. It's a treatment that costs more than conventional IVF. So at the end, you end an expensive treatment to your patient that does not offer anything.
Sure. We just need to optimize. And of course, we know that ICSI is a really safe procedure, but naturally, nobody usually hits outside with a needle in real life, in natural conditions. So maybe it's better to go more natural. And according to the first lecture and about the possibility to utilize ovarian reserve tests and sensitivity and specificity of the tests. So if we have a big number of maybe unexpected poor ovarian response, or maybe not really poor ovarian response, but suboptimal ovarian response, it's really difficult to understand if we really use properly the ovarian reserve tests. And so if you use it in normal ovarian response patient, it's good, and we can really prognose something.
I don't hear you. I don't hear you.
Yeah, we've stopped hearing you, Mikola.
Okay.
Мы можем это исправить каким-то образом?
Now it's
hearing you again. Yeah.
So, perfect. Can you please, that's a question for both speakers. Can you please talk about what do you think? How our ovarian reserve tests work in real life according to possibility to have somebody, to have a patient with unexpected poor ovarian reserve in real life? Which the number of patients, which percent of patient could be in on our real life situation with unexpected poor ovarian reserve and poor ovarian response, excuse me, poor ovarian response.
So maybe I will start on my side, Draco and Mikola. So as a little bit said in the presentation, the objective of ORT is to exactly tell you how many eggs you're going to have. Unfortunately, that's still not working. It's helping you able to discern the patient that has a very high likelihood of having a poor response and a very high likelihood of having a high response. And what I believe that the tailoring and the bettering of ovarian response has given us, and ovarian stimulation in general, is that we have become more easy, and we have become more used to, when in doubt, using a higher dose. And basically, with the advent of a good vitrification system, and with the advent of robust methods to avoid hyperstimulation, what I believe actually changed in the last 5 years was not the dose or not how we were able to predict response, but our definition of what we do when it is to response. And the majority of physicians now are starting with higher doses. On a personal basis, I believe that I'm not the same physician that I was 5 years ago, and that I now start on basis with higher doses. So more than actually the ovarian response markers, when in doubt, if I have 1.8, I'm much more likely to start with 225 of a dose than I am to start with 150. Is this something that the evidence of the literature says? Well, many will point out to the Optimus trial. I would argue that the Optimus trial still didn't give us the optimal results. The study I would like to see is personalization versus individual versus non-personalization with a higher dose. Starting or giving by default 150 to everyone, we saw in the Optimus trial was not the great strategy. What I would like to see is a study that gave 225 to everyone in an area where we are in the freeze-all session. So my answer would be, I'm starting to give higher doses.
Thank you. And what about you, Panagiotis?
I totally agree with Samuel. I think that also what I choose for my patient is to go for higher doses. And I think that for suboptimal responders, it's not AMH and AFC is not really the issue. As I said before, the reasons for this suboptimal response in most cases are genetic factors, as we said, polymorphisms in the receptor of FSH. technical problems that we may have during a pickup, asynchrony of follicular development. These are the main issues and the main reasons behind the suboptimal response. I don't think that AMH and AFC is a problem. Of course, I mean, if you choose a dose of 150 or more, of course, if you're going to give a dose of 75 to a patient, by definition, this patient will develop a suboptimal response. But in general, for suboptimal response, I think it's not a problem of AMH, and for suboptimal poor response, it's not a problem of AMH and AFC.
Great, thank you. And the next question, what is the best strategy for patients with known asynchrony in the previous cycles?
Okay, it depends now what do you define by asynchrony, but maybe, for instance, there are different strategies that you can apply. For instance, you can use the long agonist protocol in the place of the antagonist. The long agonist protocol results in a better synchrony of your follicles. Another option would be to give estradiol pre-treatment in the luteal phase in order to synchronize the follicular cohort, or what we used to do in Brussels was to give 3 days of antagonist in the beginning of the cycle before starting stimulation. However, all these procedures are quite experimental. Actually, we don't have randomized studies done in poor responders with problems of asynchrony, but in general, these 3 strategies is what we use if we have a patient with follicular asynchrony.
Samuel, what's your opinion on asynchrony?
So the question of asynchrony in this case is indeed something that is really difficult to study, because very few are the centers. For instance, EV, we do that, but very few are the centers that have a database in which they have each individual follicle measured. So the main issue why you don't have RCTs looking at asynchrony is basically that you don't really have a lot of way to identify those patients that previously had asynchrony, unless the physician accurately told them, which many times patients don't recall. So it's something that is really difficult to perform an RCT in that case, because it's not really easy to register. When you assess the strategies like Dracopoulos was talking about, and Panagiotis was presenting those which are the best and most known ones, indeed, I think you lack evidence of all of them, but if I'm forced to choose, I will normally choose the antagonist, because I believe that it has a little bit more information. But again, it's only a little bit more information, unfortunately.
Sure. Thanks. And the next question. When we are using the high dose of FSH, I don't know which dose, but high, more than 300. Is it a possible influence on the outside qualities? Do we have some evidence on that? Or maybe there's no any kind of influence on outside quality with a high dose of FSH?
There is some evidence from Baker. It was a large retrospective study in fertility sterility, I think 2017, where the authors found that there is indeed a negative association between very high doses and oocyte quality. Personally, I don't really find a rationale. I mean, I don't really believe that a very high, when we say about high dose, I think the person who asks is for a dose over 300, I suppose, because okay. But I think that the main reason is not our concerns regarding oocyte quality, but mainly because your patient will have no benefit. Okay, so I think this is the main reason that you should not go over 300 units. But indeed, there is a large prospective study from Baker, if I recall well, showing that there was a negative association. Although this is not, I think, the main reason for not using very high doses.
If I can pipe in from my side, I'm concerned that it could even be a detriment, but is a different one, because tendentially what's going to happen is these patients will be patients with multiple cycles from before. Their previous physician will have tried 300 units, and then if you all of a sudden try 600 and have the same results, you will frustrate the patient even more. So it's a non-beneficial strategy that will contribute more and more to the giving up of the patients. When a patient is of bad prognosis, I think more than trying to bet on taking every single drop of juice that you can have from an orange, maybe you should be looking more and convincing the patient to look at strategies where you can get more eggs at a time. And dual stimming, my belief, helps much more to that case. And it helps you to understand, and patients give up less. And we're seeing that now that we use dual stim more and more, that we tend to see patients become more faithful and to remain in treatments and end up getting pregnant because of that.
Mm-hmm. But I think that the question was a little bit more about not about that patient with, yes, but yes, with in cases with unexpected low force. So we can use we can push a little bit more. We can use a little bit higher doses. Where is the limit? Where is the limit which
300 units.
300 units.
Yes, of course. For instance, if you have a patient, if you start, personally, I do not start with 150. I never start with 150. I always go for 225 or even 250, as Samuel said before. So we have a patient with 225. That's for, and of course, we need to check all the parameters. But let's say that this patient ends with a lower than expected number of follicles or oocytes, if you want. So this patient has a low force. The next step would be to go to 300. Okay, but again, you should not go over 300 in case of unexpected poor ovarian response.
Mm-hmm. Great, thank you. And the next very practical question: how long do you usually prescribe estrogens in case when you needed the estrogens for synchronization of ovarian pool and ovary before stimulation, in cases when you have asynchronic situation in the previous case, in the previous cycle?
Personally, I do not use estrogen. So I said just that there is this option because it has been described in the literature. Personally, I do not use estrogens. I prefer either to go for an antagonist in the beginning of stimulation, or sometimes you can give the pill. You can give at least 2 weeks of pill in order to improve the synchrony. But if you choose to give estrogens, you can give for let's say 5 to 7 days in the luteal phase. It's enough for the synchronization.
Thank you, Samuel. What about you?
Yeah, so in my side, we tend to use it quite a lot. Not that it's any benefits for synchronization, but it helps us for organizing our workload. So we are now reaching a threshold of our center that it's growing too much for the 2 rooms that we have. So we really need to spread out our pickup rooms, because we are now in the limit that we need to start constructing to have more rooms. And we use estradiol for that. And we notice a benefit in terms of scheduling. But for synchronicity, that's not where I would bet as well. The studies that originally showed that from Fanchin ever since have not shown that. So the studies that came afterwards didn't show that E2 was helping us a lot to increase the number of eggs. The only more recent study was using antagonist pretreatment, and that, to be honest, is my first choice, is to use antagonist pretreatment and not E2. But if I do use E2, it's to 5 to 7 days, or sometimes maximum of 10 days, not the 2 months, which I think is what you're talking about. 1 or 2 months, no, that I don't use.
But I think it's very important that not less than 5 days, because it doesn't work if it's less than 5 days. So the next question is about testosterone. So what's the best way to use the testosterone? How long it should be prescribed to have some results and some benefit from testosterone?
This
Not less than.
First of all, I think that actually we don't have enough evidence to use testosterone. This should be clear from my lecture. I don't suggest the use of testosterone. Testosterone, we perform studies in order to evaluate testosterone. So actually, we don't have evidence to propose testosterone in our poor responders. As I said before, we don't know about the dose of testosterone. About the duration, for the duration, we know that it should be prescribed for at least 2 months. 2 months before starting stimulation. Regarding the dose, it's a big question mark. In the study that we do with Nikos Polidos from Spain, we give testosterone at a dose of 5.5 milligrams per day, which is quite low compared to the previous one. So, if I can give an advice to the clinicians that are now with us in this webinar, is not to prescribe testosterone in poor responders and wait in order to have more evidence regarding the role of testosterone, because I think that probably testosterone is not the solution, and I think that probably we will not find a difference in patients having testosterone. This is my feeling.
So we will wait for your results of your trials. Okay. About drug-free EVA, drug-free in vitro activation. The idea is really interesting, and it's I cannot say that it's cheap, but that's only one laparoscopy with mechanical activation and retransplantation in very difficult cases, which when we need to do something for the patient. What do you think about the possibility of using this drug-free EVA?
I think that it's rather a complicated procedure, because the patient needs to undergo 2 laparoscopies, one in the beginning to take out the ovaries and the other at the end. I think that this is only for even not for poor responders. I think it's for patients with POI, with ovarian insufficiency. Kayamura invented this procedure. As I said in my lectures, they found that during the activation there might be some problems. That's why they did not perform this activation. But actually, I think in the later paper of Fabien Online, he presented the results of only 11 patients, and some of them had to undergo IVF, others got pregnant with natural conception. So actually, again, I think we don't have enough evidence, and personally, I've never performed such a procedure to my patient. This is clear. It was just in the context of a lecture about poor responders that indeed it exists as an experimental treatment. Okay.
So it's more experiment. It's you cannot see it in practice for that moment.
No.
Samuel, what about your opinion?
Yeah. So I would also add a little bit on the information that came from the Danish group of Anderson, which had an approach similar, which was extremely interesting, by biopsy and fragmenting one of the ovaries while leaving the other ovary inside. And what you noticed there in the study that they published last year was indeed that you didn't have more eggs with your own auto control. So that was actually a very interesting study to confirm that even when you auto control yourselves, that didn't seem to be a huge benefit. But then again, you had some patients that did fall pregnant after that. And we ourselves in EVI, we do have the experimental data like Draco was mentioning, and there were case reports. But the problem is that is a case reports, one success story makes you cause other 10 patients to potentially suffer. So I think it's really just too early to go and do laparoscopies to all these patients. And again, I believe that the majority of the science is veering in the other direction, is taking the ovarian response to its face value, because we know that it's not going to get better, and thinking about other ways like dual stim to get more eggs at once.
Samuel, just a question. In EVA, you do a drug-free EVA or a conventional EVA?
Yeah, well, we even had Karamura to assist with the first method, but now it's being done, to my knowledge, exclusively drug-free.
Drug-free, okay.
Yeah.
Okay.
And the 2 or 3 patients that I've monitored myself, indeed, you do see that the follicles come and you get 1 or 2 eggs, but you get 1 or 2 eggs from these patients anyway.
Anyway.
Yes, but in drug-free EVA, there's only one laparoscopy. So you get the tissue, you perform a mechanical something, and then you put it back at the same laparoscopy.
In the same time, yes, in the same, yes. You're right, there's just one laparoscopy, yeah.
Okay. So about the STIM. The question is, if we can get more sites after dual stimulation, is it possible to try it to go further and to do it not only dual but triple or quadruple or maybe more times to get as much as possible?
Yeah, so maybe I will respond a little bit sooner. Personally, I've only done TrioStim once. We didn't get more eggs. So like the miracle drug of DHEA, the Gleicher case reports in which the patient started with 4 or 5 eggs and ended with 18, I didn't see it with TrioStim. EV Madrid is doing TrioStim with some frequency, and they are also reporting exactly the same. So this benefit that is noticed with dual stim with an average of 1 to 2 eggs extra in the second cycle in some of the prospective studies that have been done. It's not, to my knowledge, been seen so far in TrioStim, but I don't believe there are a lot of people that are courageously doing TrioStim, also because these are patients that are kind of exhausted, right? So already to make them do dual stim is an issue which is difficult. Most people that are doing dual stim are using embryos and not oocytes. Most people that are doing dual stim are doing freeze-all embryos in the second cycle. We are doing it a little bit differently. We're using oocytes and we're doing fresh embryo transfers. But these are treatments that are being done in a patient population which is already kind of tired, right? So TrioStim by default, it's not something that I believe will become commonplace.
Okay. So for that moment, we have no evidence, we have no good evidence for PRP therapy, but what do you think? Is there any future in that kind of treatment? Is it some biological basis for that? Why it should work or shouldn't? Please tell us what do you think about?
I think that PRP is clearly a commercial advancement. There might be a physiological background, but actually it's done mainly for commercial reasons. I know that it's a treatment that costs a lot, no? And unfortunately, in my opinion, people coming from all over the world in order to have this PRP. And based on the available evidence, as I said before, the evidence in fact does not exist. We have just a few case reports. There is no randomized study, nothing at all. And just to tell you that recently the national authority in Greece, where let's say PRP was attended, denied the use of PRP in everyday practice and stated that PRP should be done only in a context of studies. Okay, so I think this is important.
Okay, Samuel, what do you think about PRP therapy?
So I have had patients that did PRP, never one from my advice, and I don't believe that it's any benefit. Our patients, curiously enough, don't go to Greece. I think the majority of Europe will go to Greece because that's where it's being mostly used. Our patients go to Brazil because it's another country where PRP is very much used. And again, you will see the same pattern that Panagiotis was talking about, which is tendentially it will be a commercial-based system in which those that are trying to attract patients will use it. We don't use it. We don't believe in the evidence behind it. And those that have high numbers of PRP, because those clinics exist, I'd really like to see those numbers out in a publication.
So it's clear. So we need numbers. We need publication, of course. I think that's a really interesting question because in some guidelines and in everyday practice, sometimes we see that schemes of controlled ovarian stimulation with clomiphene and letrozole. In your everyday life, in your centers, IVF centers, in your IVF clinics, do you use combination of clomiphene or letrozole with FSH for stimulation of some kind of patients? Is it possible or not? Do you use it? Not possible, but do you use it in everyday life?
Okay, let's. I'll talk first. No, I don't use it. Based on the available evidence, also from Cochrane, but also there was a very nice meta-analysis in Human Reproduction Update by Zhang. There is no evidence to use letrozole or clomiphene. I think that it may have a role in patients that do not, let's say, have the money to pay their treatment, because at the end of the day, it does not offer any benefit, but it does not harm as well. So let's say you have a patient that has undergone 3 or 4 IVFs. Maybe in the 5th one, you can give a bit of clomiphene and some gonadotropins in an attempt to reduce the total amount of gonadotropins and reduce the money that the patient gonna pay to your clinic. But it's not in order to increase the number of oocytes. This is clear that clomiphene or letrozole does not increase the number of oocytes or your ovarian response compared to conventional ovarian stimulation.
So how is it in your clinic?
Yeah, so we're using it in only one situation. It's in the context of a prospective observational trial with choline alpha. So basically the rationale is that if you prime with letrozole, that potentially the increased bioavailability of choline alpha could work in a different way. Beyond that way, it's not our common practice to use this. I can call to the attention, however, that's a study that combined moderates, not mild, but moderate stimulation with clomiphene coming from our group in Valencia. Didn't show more eggs. It tended just to show that the embryos seemed to be somewhat better and that the cost was lower. But again, even there, it's strong enough to say that all patients need to go. I think we are all agreeing that 1 or 2 eggs extra is much better than any other strategy.
Thank you. Thank you very much. And I think we have no more questions, but we have a feedback from our participants. Some of them said that it's really very nice opportunity to have evidence-based ways to treat low responders and to predict ovarian response, because it's really not very easy option to choose when you have so huge number of articles about some kind of experimental treatment, and to navigate in this situation and to choose or not to choose some experimental treatment in a so difficult category of patients, it's possible only with evidence-based protocols. So thank you very much. Thank you for your time. Thank you for your experience, for your expertise, and your wonderful lectures. Thank you, and have a good day.
Thank you very much.
Thank you very
much.
much.
Have a very nice day. Thank you. Thank you.
Thank you. Bye.
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 Шановні колеги,
Dear respected colleagues, our symposium is coming to an end. The theory and the practice of reproductive aspects of a human being. This is really was in line with the name. Those 2 days were filled with theory and the practice. From many countries of the world, from the USA, Finland, Spain, Greece, Portugal, Kazakhstan, we had presenters. They shared their knowledge, their practical experience, their clinical experience, and eternally grateful also to our Ukrainian scientists, practitioners who participated in our symposium. You can agree that those 2 days have passed us 2 minutes. It's unfortunate that we have ended, but everything that's good is coming to an end. And our symposium that happened to be on just one breath has came to an end. But still, it only says that we are just waiting for the next. The most sincerest gratitude to the organizers of our symposium. We have started from schools and from Mykola Hrihorovich. Thank you so much, dear Professor Grishchenko, for a good pickup of ultrasound school, an MSc company that supported the conduct of that school, and it was just so wonderful. Thank you so much, the organizers of live surgery, especially to Anatoly Verchuk and the company Bova, who have joined to the conduct of this school, to our wonderful friends from the OR and ERs, from the Vinnytsia Inamed, Professor Hurenko, from Ivano-Frankivsk, Pauchko Yuri Stepanovich, and Professor Chaika Kirillov Vladimirovich, our wonderful friends from Odessa Clinic, and Hotchuk Vasil, and of course, to my wonderful medical centers from Chernivtsi. At one press we have the use alarm, and this was the actual encouragement of the Professor Lukashenko, Valentina Pavlivna, and the Dr. Babi, who have made it possible and provided for a successful conduct of the alarm, and to all of our young colleagues or junior colleagues who were able to present their knowledge and their practical successes on this alarm. And we've seen that on the youth alarm, we've made such a wonderful thing to our youth, especially we've presented with the lectures with Professor Zhabchenko, Helen, and Professor Suhan. How do you have to present? How do you need to present? How do you need to train people and all of that? The most sincerest words of the gratitude to our wonderful partners of Ukrainian Association of Reproductive Medicine, medical companies who helped us to fill in our symposium by interesting and lively presentation. This is the company MSD and the Richter, Gideon, Yuzin, Abbott, Fairing, Sonofar, and yet again the MSD again. Thank you so much for such a wonderful preparation and being concerned with how well everything went and all of that. Also, gratitude to the team of Logistics, to Irina Burun and the technical team and IT team in the studio, our wonderful interpreters that have managed to do so and created this drive and the will of our symposium. Thank you so much. And I'd like to say that my heart is filled with love and gratitude to my medical center from Chernivtsi city, that from all of these months they were actually they were holding their breaths till I was in there, so that when I was preparing for the symposium. If I haven't forgot anybody, Irina, as I remember everybody, yes. Thank you so much who've been with us to this last minute of our symposium. I wish you all a good health, stay safe, and our final objective, to have more children healthy, happy, in all the luck in the world in our not as simple but as such an honorable task. Thank you so much, and see you in 2021. Let us got created and conducted in offline version. Thank you so much and goodbye.
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
There's something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow. To make a difference by inventing for life.